5, 4, 3, 2.
इसमें स्क्रीनशॉट लेना है.
We are live, sir.
दोनों को दबाना है.
Good morning, everyone. I welcome you all to this academic feast known as the 9th ENT Update 2020. May I request our head of the department, Dr. P.K. Rathore, to kindly start the proceedings.
Hello. Once again, good morning to all of the delegates and the esteemed faculty members. This ENT PG update we are carrying on annual basis for last few years. Now we have designed a program based on our previous feedback from the postgraduate students who have attended the PG update. Now our main aim is to focus for postgraduates to prepare them for forthcoming examinations. So now we have designed some program, and now I'll request host to begin the proceeding with first lecture. Thank you.
I now call upon Dr. Jyoti Kumar, Professor, Department of Radiology at Maulana Azad Medical College. Our first lecture is on radiology of temporal bone. Ma'am, please start the proceedings.
Thank you so much for making me the opening batsman here. And I hope my screen is shared. Is that so? Can you see the slides?
No.
Hello?
Good morning, everybody. No, Dr. Jati.
Okay. Share screen. I have pressed share screen and then gone on to my PPT. It is not visible. Can you see it
Not
here?
yet. Not yet.
Not yet. Okay. Give me 1 sec, please.
Hello. Hello. Good morning.
What are the instructions for me to share my screen? I just pressed on the share screen, right? Hello? Hello? Is that so now?
नहीं CM Mandela.
It is visible.
It's visible now.
Okay, great. So I shall be talking on imaging of temporal bone. I would just request everyone else to please mute themselves, and we can then go ahead. Okay, thank you so much. And so this is on basics of temporal bone, what an ENT resident should know. And what I have planned for the next 30 minutes is anatomy of the temporal bone. I will share the anatomical pictures with you predominantly on CT and a few images on MR, and also discuss the illustrative pathology for a few cholesteatoma cases, which is the most common indication for temporal bone imaging. So CT remains our workhorse. It is a widely available technique with low cost and gives us excellent spatial and temporal resolution. Spatial meaning that I can distinguish two closely opposed structures lying next to each other as distinct structures, and temporal resolution meaning that I can acquire my CT very, very fast. Mostly it is an HRCT temporal bone which is indicated. We do it for various indications like congenital or acquired hearing loss, trauma, chronic otitis media, preoperative for cochlear implantation. And contrast is required for a very limited number of indications, which include tumors, abscesses, vascular involvement, and complications of chronic otitis media like sigmoid sinus thrombosis, or if there's an intracranial abscess that we are looking at. So in those indications, we require to give contrast. Otherwise, a non-contrast, high-resolution CT temporal bone just simply suffices. So temporal bone has three parts: outer, middle, and inner ears. The outer ear, the external ear, is comprised of the external auditory canal, the pinna, of course, the external auditory canal, and the tympanic membrane. Now, external auditory canal has an outer fibrocartilaginous 1/3 part here, and the inner 2/3 is the bony part, and we have the tympanic membrane lying medially. So very similar to this anatomical picture that we have, we see exactly the same way on our coronal images of CT. So this is the cartilaginous external auditory canal, the bony internal auditory canal, and the tympanic membrane. I hope you can see this thin wisp of line which separates the external ear from the middle ear, which is the tympanic membrane. Sometimes you need to alter your window settings on the console to see it better. So this is your tympanic membrane. The superior part is the pars flaccida and the inferior one is the pars tensa, and you know it all. You know these parts very well. The middle ear is divided into three parts: epitympanum, mesotympanum, and hypotympanum by these two tangential lines that run along the margins of the tympanic membrane, along the tympanic annulus. So this is the first line and the second line. This is the epitympanum, or the attic as it may be called, which contains the major part of the ossicles. Mesotympanum mainly has the handle of the malleus, the long and the lenticular process of the incus and the stapes, and the hypotympanum is relatively featureless. Again, very similar to your anatomical diagram, we see our epitympanum above this point. This is the tympanic annulus. So above this line is your epitympanum containing most of the ossicles. Then this is the line which will separate the mesotympanum from the hypotympanum underneath. What is Prusac space? Now, Prusac space is the area where which is the most common site for primary acquired cholesteatoma, and this is the site of the Prusac space, which as we see on this diagram is the space between the lateral malleolar ligament, the neck of the malleus here medially, and the scutum laterally. So the scutum, which is this bony projection spur here at the superior tympanic annulus. So this is the scutum, the neck of the malleus, and the superior malleolar ligament, lateral malleolar ligament, which may sometimes be seen and sometimes may not be seen. But this part here is the Prusac space. So any soft tissue here, we need to be a little wary. How do you see the ossicles on CT? Now, these are consecutive CT axial images from top to bottom. And what I would like to point out here is that these three appearances, the ice cream cone appearance at the top in the epitympanum, the two dot appearance, and the two line appearance. So in the mesotympanum, so ice cream cone, two dot, and two line. If you see these three signs of the ossicles on axial HRCT temporal bone, you can be relatively sure that yes, my ossicles are good. So these ossicles are well preserved. If you see these three signs, these are signs given by different parts of the ossicles at different sides of the middle ear. And we shall see that as we go along. But remember these three signs: ice cream cone, two dot, and two line. Moving on to inner ear, we have cochlea, vestibule, semicircular canals, and the internal auditory canal containing the 7th, 8th nerve complex. So cochlea is your anterior most structure. So as we go from anterior to posterior, this is the cochlea. As we go back, the vestibule and the semicircular canals. These are also seen on the axial images very well. So as we go from top, you will see the superior semicircular canal. Then as we come down, we'll see the vestibule and the lateral semicircular canal, the posterior semicircular canal here, and the cochlea as we go further down, because it's the most inferior and anterior structure in the temporal bone, the cochlea. Now, this is just a broad overview of the various structures as you see on imaging. Don't worry, I shall take you through scan by scan section of the temporal bone anatomy again after we review few critical structures here on some selected images. This is the internal auditory canal containing the 7th and the 8th nerve complex. This is the facial nerve which emerges from it, right? This is the labyrinthine segment. This is the labyrinthine segment. Then this is the genu at which it turns back. So this is the horizontal segment which turns back from the genu. And as I go in the next section, I can see this horizontal section along its entire length. And as it goes back here behind the pyramidal eminence, it forms the second genu, and then which continues further down vertically as the mastoid segment. So these are axial scans, and I'm cutting through the vertical mastoid segment like this. Of course, I'm going to see the facial nerve as a circular dot. So this may be a little overwhelming to the new residents in the department, and I'm here to make it simpler for you, all of you, and we shall now look at all these scans step by step from superior to inferior as we cut the bone axially. So this is how you take axial sections through the cochlea, horizontal sections through the ear. So as we are at the top of the image, what is the first structure that we cut through? Now, since it's a one-way program, I can't see any chat, I can't see any faces. So it's a little, it's not a very encouraging feeling for me here, sitting here alone and doing this. But this is the topmost scan here, and this I'm cutting through the superior semicircular canal. So this is the first thing that I see, the superior semicircular canal. As that was the crus, right? That was the arcuate eminence here, the topmost. As I go down, these are the two limbs that I'm cutting through, right? This circle and this circle will be seen as two dots, the superior semicircular canal. This is the internal auditory canal from which I see the labyrinthine segment of the facial nerve emerging, and this is the superior semicircular canal. So this labyrinthine segment curls over the cochlea. Anything anterior to the internal auditory canal is a cochlear structure, and the structures posterior to the internal auditory canal are vestibular and canalicular semicircular canal structures. So this is cochlea, and this is vestibule and semicircular canals behind the IEC. And this is the facial nerve 1, the labyrinthine segment emerging. And here is the genu from which the nerve greater superficial petrosal nerve emerges. That's the branch of the facial nerve which emerges at the genu. And then the facial nerve turns back, which is the horizontal segment of the facial nerve. And since it's a horizontal segment, and I'm cutting through the length of, cutting through the through the temporal bone horizontally, now I can see the entire length of this horizontal segment of the facial nerve. And this is the short process of the incus. In the short process of the incus is the surgical landmark that you also use to identify the facial nerve, and that is how this is closely seen on the CT image. This is the ice cream cone appearance of the ossicles formed by the malleus head, the incus body, and the incus short process. So incus short process and facial tympanic segment closely associated here. On the coronal sections, I will also show you how this horizontal semicircular canal is related to the the facial nerve canal is related to this horizontal semicircular canal superiorly, and inferiorly lies the oval window just beneath this horizontal segment of facial nerve canal, or the fallopian canal as it is called. So that's the IAC structure. Anterior to the IAC is your cochlea. So this is the middle and the apical turn of the cochlea, and this is the modulus, the cochlear aperture through which the cochlear nerve enters the cochlea, and this bony central axis is the modulus around which the cochlea turns. Behind is the vestibule and the semicircular canals. This is the typical appearance of the vestibule and lateral semicircular canal, giving a signet ring appearance. Very important to identify if you need to identify inner ear malformations, because lateral semicircular canal is one of the most common structures to get dysplastic, and then this appearance gets lost. The island between the two structures may get smaller or may just completely get lost, or maybe completely lost. So we have seen this ice cream cone appearance formed by the malleus head, the incus body, and posteriorly by the incus short process. As we go down into the mesotympanum, we see here is the two dot sign formed by the neck of the malleus here, and we have come a little down. So the neck of the malleus and the long process of the incus. So these are the two bones which give us this two dot appearance, and we can also see the stapes crura here, the anterior and the posterior crura. In between this black thing is the obturator foramen, and this is your side of oval window. We had seen the horizontal segment of the facial nerve canal and through, and now this is the posterior genu. This circular dot, this gray circular dot lying behind the wall of the middle ear. This is the pyramidal eminence. This is your pyramidal eminence. So in the posterior wall of the middle ear, this bony mountain-like feature. So this is the dot of the second genu, and whereafter it turns and becomes your vertical segment. This is the basal turn of the cochlea, right? And this is your round window, where the middle ear and the basal turn of the cochlea communicate, the round window. And this is the cochlear aqueduct. It's a perilymph containing structure joining the posterior fossa with the basal turn of the cochlea. This is your posterior semicircular canal, in this, which is something that you see in this orientation in your temporal bone, is your posterior semicircular canal, and a structure just lying parallel and behind the posterior semicircular canal will be the vestibular aqueduct, which contains the endolymphatic duct and the sac here in the posterior fossa. So looking at the posterior wall of the middle ear, we have this bony mountain here, which is the pyramidal eminence, which separates the sinus tympani medially and the facial recess laterally. So this is the plane which is very critical to evaluate when we are evaluating a patient for precochlear implantation, because this is the most often used route for cochlear implant, where you go transmastoid through the facial recess and into the round window niche. So that's the most common plane, and this plane is critical for us to evaluate when we are evaluating a child for precochlear implant. We need to look at the mastoids. We need to look at how good the facial recess is. Is there any nervous or vascular structure which lies in this path, which can be a critical surgical catastrophic we don't want any catastrophe to happen. We don't want facial nerve to lie here. We don't want any vessel to lie here along the cochlear promontory. So all that can be ruled out on CT before a cochlear implant is taken up. So that was the posterior wall of the middle ear. And here we have the anterior wall of the middle ear, where we look at the three critical structures again, similar to your posterior wall, where we had three things to look at. Anterior wall again has three structures. This is your carotid canal, which houses the carotid artery. This is the eustachian tube opening, the subtle black line. And this is your canal for tensor tympani. So these are the three structures along the anterior wall of the middle ear. And we have gone further down into the hypotympanum, and we are seeing this facial nerve canal as a rounded dot through and through. We could trace it right up to the styromastoid foramen as we go down. Now looking at coronal scans. So these were our axial scans. Now we are cutting perpendicular to these axial scans, one behind another like this. So look at this coronal scan. When I cut through this plane, what I would see here is two dot sign of the facial nerve canal, because I am cutting through the horizontal segment and I'm cutting through the labyrinthine segment. Now in the coronal scan, these two structures now will give me a two-eye appearance of the snail, as it is sometimes called, the cochlea forming this snail. So whatever structure was being seen in its entire length in the axial scan will now be seen as dots, and whatever was seen as dots will now be seen as a vertical line. So the mastoid segment of the facial nerve canal, which was seen in cross-section on axial images, I will show you how it can appear very straight and very well visualized as a straight line on my coronal scan. So from anterior to posterior, so this is the external auditory canal, this is the scutum, these are my ossicles, this is the tympanic membrane, this is the handle of the malleus attaching to the tympanic membrane, the umbo, the Prusac space, which lies medial to the scutum and lateral to the malleus neck, the two-eye appearance of the facial nerve canal, the first and the second segments, the cochlear snail-like curve, meso, and hypotympanum. Scutum is is a structure which is often eroded by a pars flaccida cholesteatoma. This is the promontory which is formed by the basal turn of the cochlea, and this forms a bulge into the middle ear, and this is how the promontory is seen on CT. So sometimes there is cochlear ossification when we don't see the cochlea, but it is not same as cochlear aplasia. And how do we, as a radiologist, differentiate between the two entities? In both the cases, we do not see the cochlea. So if the promontory is present, I know that I'm looking at a cochlea which was formed but has been later deformed by cochlear ossification and hence not visible. Unlike cochlear aplasia or Michel aplasia, where the cochlear promontory will not form in the first place. So we have seen the Prusac space already. And this is our internal auditory canal. And this is the subtle bony crest that we see here, which is the falciform crest separating the superior and the inferior halves of the facial nerve canal. And this is what I was talking about, that this is your second part of the facial nerve canal. Now, this is seen as dots because I'm cutting through a coronal scan, one behind another. Now, you can imagine if a structure is lying horizontally and I keep taking coronal scans, I will keep cutting through it in cross section. And this is how I can trace this rounded structure, the facial nerve, to one behind another until it forms the mastoid segment. And on the coronal scan, I can see it lying just underneath this lateral semicircular canal, as you can see here, and this is your oval window niche.
महेंद्र बाहर एक बार ये जो टेबल और ये चेयर्स वगैरह पड़ी है ना, इनको थोड़ा सा वॉश करना पड़ेगा, बहुत गंदी हो चुकी हैं। और फर्श जो है ना, उसपे कुछ निशान पड़े हुए हैं, दाने दाने दाने। फर्श भी अगर धुल जाए ना सामने।
Asif, can you switch off? Sorry, Dr. Jyoti. You can
No worries. It happens. This is a fallacy of the Zoom meeting. We have all had face-to-face situations like this. So it's an interesting thing, and somehow we need to be careful what we are talking also. And so this is the horizontal facial nerve 2, which lies beneath the lateral semicircular canal and the zoom window and the oval window here. So when this facial nerve, when this facial nerve 2 is dehiscent, it lies beneath, it lies obscuring the oval window at times. That's another critical structure that we need to alert our ENT colleagues with. And the wall, and sometimes when it, this oval window may be atretic or stenotic, again, an important structure to look at. So we go posteriorly, we see the vestibule and the superior and the lateral semicircular canals. And this is the mastoid segment of the facial nerve canal. Now I can see through and through as a vertical line, very well seen up to the stylomastoid foramen at its exit. And we can create these 3D images. Of course, it's a very, very time-consuming procedure. And although they look very good to the eye, practically, these are not really diagnostically useful, but yes, they are appealing to our clinical colleagues, surgical colleagues. So, MR, just a few words on the MR. I can see the fluid-filled inner ear structures. This is what it is good for. MR, we do not really use it for evaluating the external and the middle ear. So what we use it is for the inner ear structures. The internal auditory canal, mainly the 7th and the 8th cranial nerves, which are not directly seen on CT, but which are directly seen on MR, and the brain and the auditory cortex. For any lesions, the CP angle here, any lesions which can cause hearing loss, which are beyond the temporal bone into the brain, into the CP angle, are best evaluated on MR. So these are the 4 nerves in the internal auditory canal, and we all know what is the mnemonic that goes 7 up, coke down. So facial nerve lies up. Okay, so I've gone to the this is the sagittal oblique images again through the internal auditory meatus, where I see all these 4 nerves in cross section. So 7 up, that is the facial nerve up, coke down, cochlear nerve down. And these are 2 anterior structures, and posteriorly we have the superior vestibular nerve up and the inferior vestibular nerve down, as the name suggests. So this, when when there's cochlear nerve aplasia, this dot here in the antero-inferior aspect of this internal auditory canal will be lost. Now let's look at a few cases of cholesteatoma, just because this is the most common indication for temporal bone imaging. And this is something that you will see day in and day out. So for evaluation of chronic otitis media, it is a clinical diagnosis. We have to remember that it is a clinical diagnosis, and radiological imaging serves as an adjunct to assess the extent of disease, to evaluate what complications has it resulted in, and for preoperative assessment. So we use it routinely for a preoperative assessment. So this is what a cholesteatoma will look like, a non-dependent soft tissue mass. Now this soft tissue could be anything. It could be granulation tissue, it could be cholesterol granuloma, it could be anything. So what we infer cholesteatoma as is when it causes bone erosion or displacement. So when it causes ossicular destruction or displacement, that is when we interpret it as cholesteatoma on CT. And CT is what is most often used. In a case of revision, post-revision evaluation after surgery, when the ossicles have already been taken out, there is a previous setting of bone destruction. So in that scenario, cholesteatoma may not be very well inferred on CT, and that is when an MR may be used. So otherwise, for a first-time evaluation, CT just suffices. So you can see your, as an ENT surgeon, you can see the cholesteatoma very well. You can see your ossicular destruction well. You can see all those things that are happening in the scutum and the middle ear and the external auditory canal. What we can help you with is what is happening inside. So let's look at a few examples. Now this is the images on the right are normal anatomy, and the images on the left are the abnormal, are the positive cholesteatoma cases that I'm showing you. So here we have the normal ice cream cone appearance, and you can see how destroyed this looks on this CT. So this is a cholesteatoma, soft tissue with bone destruction. This is a scutum, which is well preserved triangular projection, and this is where the scutum is destroyed. So a pars flaccida cholesteatoma, destroying the scutum, displacing the ossicles medially. But I am not really helping you with this because you have been able to see it already on your examination. But what I can really help you with is involvement of the facial nerve canal and involvement of the labyrinth. This is where you will not be able to see it, but the CT scan will be able to help us with that. Of course, there are situations where we can overcall facial nerve involvement as compared to, because the bone here is very dehiscent, and this thin wall, this is the horizontal facial nerve canal, right? So this is the thin bony wall, and when there's a lot of soft tissue here, as you can imagine, look at this. So this is kind of, this horizontal canal here is now mixed up. Sometimes we tend to overcall, but most often I like to believe that we are right. So this is a cholesteatoma with facial nerve canal involvement. This is the normal lateral semicircular canal with a good bony cover, right? And what I see here is the bony cover is very, very thin. It's almost lost here in the central part. And this is how this lateral semicircular canal, again, on the coronal image, shows us a good bony cover, and it is lost here. Another place where CT scores over clinical evaluation. So for radiology residents, I would like to tell them that facial nerve canal and lateral semicircular canal, these are the two things that you cannot afford to miss to look at on CT to help our clinical colleagues serve their patients. Other things that we need to look at is this sinus plate erosion. Like, look at this. This is the sigmoid sinus. This is your jugular bulb. This is your sigmoid sinus. This is the mastoid. So this is the bony cover around the sigmoid, and see how this bony cover is lost by this mastoid abscess. So this is again one thing where we can pick it up and warn our surgeons of an impending thrombosis if it has not already occurred. So MR can help distinguish cholesteatoma from granulation tissue and cholesterol granuloma, but it is not the required technique for primary evaluation, but it may be looked at in cases of revision surgeries. If I have excluded and if I'm exceeding my time limit, just let me know, because I'm not aware of what the time is. So let me know, dear, when time is up.
Dr. Jyoti, you can continue.
Okay. So on MR, we see here this is the soft tissue here, which shows restricted diffusion and no enhancement. So this is how we distinguish cholesteatoma from granulation tissue. And of course, again, this is not a foolproof method. We have a lot of fallacies happening here as well. So keep that in mind. And we may be able to help you with distinguishing between these three entities on MR, which we cannot do on CT. Looking at a few further complications, this is the normal labyrinth, as we have seen already, and this is where we do not see the inner ear structures, but we see increased density. This is the cochlea, which has completely opacified, and here the vestibule and the semicircular canals are completely gone. So it is a case of labyrinthitis ossificans secondary to chronic otitis media, and this is a case of infection which has spread into the scalp. We can see an abscess here into the scalp with intracranial extension with sigmoid sinus thrombosis. Now there are certain surgical landmarks again which we can pre-warn our clinical colleagues with, and this is the normal coronal anatomy of the temporal bone, where we see this is the dura, this is the level of the dura, the tegmen, and the mastoid roof are at the same level. However, when this mastoid thing dips below the tegmen, that is when we can call it a low-lying dura. And for a surgical access, it may be a little problematic here. The surgical access will now get restricted and there are more chances of injury. So we can help pre-warn our colleagues. It is best seen on a coronal scan. The sigmoid sinus, this is the sigmoid sinus. It can protrude here anteriorly into the mastoids, again restricting surgical access. We can have a high riding bulb, a dehiscent bulb. This is the jugular bulb, right? So it could be an enlarged bulb reaching high up, again in the line of the surgical plane. It could be dehiscent, as we see here. The lateral wall is not well seen, again making it more prone to risk during surgery. Or it could have this projection, this diverticulum, which is projecting into your plane of surgery. So all these variations also need to be mentioned. And hence, we devised this reporting template for reporting chronic otitis media in our department, and where we like to call each of these in this tabulated form so that it's easy to appreciate, where we talk of external ear, tympanic membrane, soft tissue density, middle ear. Now, where is the soft tissue present? Has it gone into any recesses like the Prusac space, anterior epitympanic recess, sinus tympani, facial nerve recess? Because these recesses, sometimes these recesses may be blind to examination, and we can then, if we know it pre-operatively on CT, it will help the surgeon. How intact the ossicles are, what are the various sites of bony erosion, what is the structure of the inner ear in this, is it abnormal, is it normal? How are the mastoid air cells? Are they pneumatized or sclerotic or opacified? Plus any other variant finding that we have talked of. With that, I thank you for your kind attention.
Thank you so much, ma'am. It's always a pleasure to listen to you. I would like to invite questions from the faculty now.
I must appreciate Dr. Jyoti's effort in this presentation, and she's our radiologist who has special interest in temporal bone and head and neck radiology. And I'm very pleased to tell you that we have around 223 delegates as of now in audience, and we have around 23 faculty. So it makes around 250 people joining this webinar. And I would like to invite comments from the other faculty members. If they have any questions.
Dr. Jyoti, am I audible?
Yeah, good morning, sir. Good morning.
Good morning. This CT has really revolutionized the otology, especially the temporal bone imaging. By CT scan, it has two things like anything. So, what is the role of CT in autosclerosis?
Oh, so sir, autosclerosis, as we all know, is a condition where the bone actually becomes spongiotic and soft, and it is a genetic condition, and it was initially it has been believed to be a an audiological diagnosis where you have those specific signs, the Carhart's notch, and etc. And but CT has come up in a big way to assess this condition. CT can show us these autospongiotic foci adjacent to the vestibule, the fistula antifenestrum and the fistula retrofenestrum at times. So the bone there, the dense bone, uterus, is white, now becomes. But in fact, there are a few studies which have shown that CT has been able to pick up autosclerosis before the patient has presented clinically. So that is a revelation that sometimes when the patient is asymptomatic, CT has been able to pick up autosclerotic foci even then, and that the same goes for histology. So I will not say that CT is overcalling autosclerotic foci, but histology also, I think it's supposed to, it's believed that about, if I'm not mistaken, about 10% of people have autospongiotic foci in their temporal bones as per histology. And so out of 300 people here, 30 in this conference, 30 people have autospongiotic foci. So and CT has been able to pick them up not only definitely after your clinical evaluation, but also when the patient is actually asymptomatic, much before the patient gets symptomatic.
It means you can come to know whether there is an obliterative focus or it is a small focus beforehand, so that it's not a surprise for the surgeon to or get false when he sees the totally obliterated focus in the whole window. My last question, Dr. Jyoti, before we wrap up, what is the plane? Because nowadays there is lot of cases of third window or superior semicircular canal dehiscence are there. So what is the CT for that entity?
Yes, sir. Again, so third window phenomenon presents with characteristic either vestibular dysfunction, that's the or auditory dysfunction as conductive hearing loss. And the most common cause for superior semicircular canal for third window is your enlarged vestibular aqueduct and superior semicircular canal dehiscence. So superior semicircular canal dehiscence on your routine axial and coronal windows can be missed. So we need to look at special planes. Of course, to a keen eye, it may be seen even on these planes, but it's easier appreciated on special planes for superior semicircular canal, which are along the axis of the superior semicircular canal. So these are called the Stenvers and the Postul's plane, parallel and perpendicular to its axis. So those reconstructions help us to evaluate the boundary of the superior semicircular canal. In fact, less than 1 millimeter thickness is considered a finding which should be reported. So saying it as thinning of superior semicircular canal, and when it's completely absent, of course, it's completely absent. And also believe that the length of the absence of the superior semicircular canal wall, that length also correlates with what symptomatology the patient has. So the greater the length, the more the chances of the patient having both auditory and vestibular dysfunction. So, but over and all, it still remains a clinical diagnosis, and we are certainly there to kind of confirm that diagnosis for you.
Dr. Jyoti,
Thank you, Doctor.
I have a question. Basically, in exams for PGs, the very common.
Hello. Hello, Dr. Ravi. Dr. Ravi.
Yes, sir.
Good morning, Dr. Jyoti, and all the faculty members and the delegates.
Good morning, sir. Good morning.
Jyoti, as usual, you are excellent in your presentation. I joined
you, sir. Thank you.
You people a bit late. I only wanted to know if you have also touched the trauma part of the temporal bone.
No, sir. In half an hour, I thought chronic otitis media would be the most apt.
Okay.
Dr. Jyoti, I have just one question. What is the role of X-rays in temporal bone imaging? Because this can be sometimes asked in exams. So for our ENT residents, what do you think is the role of X-rays in evaluating the temporal bone?
Practically, what I've seen in the last 1 year, the only X-rays that I've seen is a post-cochlear implant check X-ray. So that is the only X-ray I've looked at. All those X-rays for the mastoid X-rays are redundant in this era.
I would say that the temporal bone X-rays are now obsolete, except for the post-cochlear implant evaluation to see the position of the electrodes.
That also has gone to CT in institutes which have that facility, intra-op CT and stuff. That also has moved on in advance, but we are still sticking to X-ray examination. So that's all right. That also serves our purpose.
Okay. Thank you very much. Thanks a lot.
Thank you, sir. Thank you.
Thank you, ma'am. I would now like to call upon Dr. H.C. Taneja for his lecture on audiology. Sir is Director Professor at Department of ENT at Maulana Azad Medical College. Dr. Taneja, please.
Are you getting my audio?
Yes, sir.
Okay. So Dr. Jyoti,
please switch off your presentation.
Yeah. अरे 2 दिन का. So good morning, everybody. Till now you have seen the anatomical part of the temporal bone. So now I am talking about the physiological part. So audiology is the study of hearing and balance. So before jumping to the investigation part, we should know the few fundamentals of the sound. We must know that audible frequency range for human ears is 20 to 20,000 hertz. And human hearing spans in 10 octaves. You might have seen in the tuning fork as well as in the audiometer. The next frequency is the doubling of the previous frequency. For example, in pure tone audiometer, it's 125, 250, 500, 1000, 2000. So this type of pattern is known as octave. So human hearing frequency range spans around in 10 octaves. And another thing we must understand is the decibel scale. What is decibel scale? Because there are different types of decibel scales in use. The most commonly used is the sound pressure level method. In sound pressure level, as you know that in the universe there is no place without sound and light. So it's omnipresent. For that purpose, to scale the intensity of the sound, we have to take some reference value. For reference value, we use 0.00002 Pascal. So this is the faintest fluctuation in air which a normal ear can detect. So this sound pressure level decibel we get by using the formula 20 log base 10 with the ratio of the pressure measured and the pressure reference. So air pressure reference is 0.00062 Pascal. So you might have seen the audiogram. So on x-axis, we have frequency, and on the y-axis, we have intensity. Suppose we have to plot using the sound pressure level unit audiogram. So normal audiogram will something look like this. So we have to have a uniformity, so we converted it to the HL type, hearing level. So all intensity, they appear at the same level for different frequencies. Actually, they are not when we are using sound pressure. The another unit in use is the sensation level, SL, hearing decibel SL. So what is sensation level? So here we use the individual's own threshold. So own threshold of hearing is a reference here. For example, at 1 kilohertz sound presented at 50 decibel to a patient with a threshold of 10 decibel hearing level. So the sensation level will be of 40 decibel. So that we get by deducting the threshold of the patient from the sound presented. So 50 decibel minus 10 decibel will give 40 dB sensation level. This is another important graph. Here you can see the minimal audible pressure and the minimal audible field. So what is minimal audible pressure? Minimal audible pressure, this is a monaural sort of sound presentation. And here a insert type of earphone is used. And 1 ear is tested at a time. Here in graph you can see with the dotted line that this is the normal threshold. For the minimum audible field, we use the external speaker. Here we don't use headphone. So external speaker is placed in between somewhere away from the ears, and then we deliver the sound and then we look for the threshold. So here you can see that minimal audible field threshold is better than the minimal audible pressure. So binaural hearing is always better than the monaural hearing. And this is another commonly shown graph. So this is a equal loudness contour. So here you can see the amount of energy required in lower frequency is much higher to deliver the same level of the loudness at 1 kilohertz. At 1 kilohertz we have better level. So the types of hearing loss, if there is a involvement of the external canal or medullary mechanism, then it may lead to the distortion of the conduction, and that will lead to the conductive type of the hearing loss. And beyond that, when there is involvement of the inner ear and further medially, then it will lead to the sensory neural type of hearing loss. So we have battery of the audiological tests. So broadly, we divide audiological test into two groups, subjective and objective type. So in subjective type, we carry out usually two types of tests, tuning fork test and the pure audiometry. And this is a manual one, but when it becomes automated, then it becomes a backseat audiometry, which I am not covering. And objective tests, they include the impedance audiometry, photoacoustic emission, and auditory response. So my main focus is on the pure audiometry, which we use in routine ENT practice for assessment of the function of the cochlea and middle ear. So the aim is to get the information in the form of what kind of hearing loss patient is having. So qualities, that is conductive loss or sensorineural hearing loss, and quantitative assessment of hearing loss and how much loss the individual is having. So for that purpose, we need a pure tone audiometer, and a chart is being used for plotting the graph, and x-axis we denote the um, x-axis we denote the frequency, and y-axis we denote the intensity of the projected sound. So this is a standard audiometer which has a display with that you can know which frequency is being used and at what intensity sound is being used. So see up to the left, and buttons are there to perform the test. So now we have various types of sound delivering system for ear conduction, and we have the over-the-ear headphone, which is most commonly used, and we have insert type of earphones. They give better threshold, and this is around the earphone. These types of headphone used for extended high frequency perimetry. And this is the bone vibrator with the headband. So this part rests over the backside bone or middle of the skull, and this is placed with the help of this pad at the head of the vessel. So what are the conditions we have to carry out pure tone audiometry? The soundproof room or sound treated room. So difference between these two is the soundproof room. They have better level of the isolation of the ambient noise in the atmosphere. So they are available in the form of ready-made cubicles which take care of ventilation of air, humidity, and the lighting. And sound treated room, we convert our audiometry room by placing sound dampening panels on all the walls, so there is no reflection of the sound. But the problem with the soundproof room is if some patients they have claustrophobic feeling, sound treated room, because it is a large room, patient doesn't like this type of room. Our patient should be cooperative and fully conscious. And usually in children over the age of 5 years, they are quite cooperative to carry out this test. So before subjecting patient to the pure tone audiometry, we must examine the external canal for any cracks or cavity or discharge there is present that need to be clean. And patient is asked to remove the glasses, earrings. And we always ask our residents to provide the otoscopic findings and the tuning for test findings to the physician. They help him to perform the pure tone audiometry and correlate the test results with these findings. Sometimes they do not match. So then he can again go into the details and find out what is the result of mismatch. Calibration. These audiometers are very sensitive instruments, so central unit and headphone they need to be calibrated regularly. And in the graph you have seen the audiometer 0 is the most absolute 0. As I told earlier, there is no place in the universe where there is no sound. So audiometric 0 is the 0 which we get by carrying out the test on the healthy individual from 16 to 25 years of age, not having any ear injury or ear insult in the past. And this is the threshold of those healthy individuals. So this is audiometric 0. And calibration of the audiometer in routine when an audiometry starts his day, first he carries out audiometry for himself by putting headphone over it, and if the result matches with the previous day audiometry of himself, then it means audiometry is functioning well and so it's suitable to take it to the proven audiometry. But annual calibration of equipment is required that needs the help of the instructor. So they do it in detail indeed. So this calibration can be performed by using human volunteers and artificial ears, but carrying out with the help of the human volunteers is a big exercise and time consuming and the cooperation of the large number of individuals. So artificials are preferred to carry out the calibration of the earphone audiometer. So method for ear conduction and bone conduction control we have to detect. For air conduction, already I have told headphone insert earphones and around the headphone are used. And for bone conduction, bone conductor over the cassette process is used. So what we do, we present the sound for familiarization of the patient. First, we present in much higher intensity by headphone to the patient so that he can understand what kind of tone he will be getting. So, for example, if person with normal hearing, we present tone of 1 kilohertz at 30 decibel. If patient is having some hearing perspective or SMS, mild that situation will go to the 50. But in no case we don't go beyond the 80 decibel. And then when patient is able to listen the sound, then we have to give the instruction to the patient that whatever faintest sound he is able to hear, he has to indicate that he is getting the sound. So intensity is not important for the patient, but the thing is he must get the sound. How faint it is, it doesn't matter. So patient must identify 50% of the presented stimuli. So normal duration is usually 1 to 3 seconds stimuli duration, and normally we have gap which is not less than the duration of the stimulus. And for bone conduction, we use the bone vibrator, which is similar to the ear conduction method, different, but the thing is in the form of bone vibration. So here comes the masking of the text here. Because we know that there is intraoral attenuation. What is intraoral attenuation? Intraoral attenuation is the loss of intensity when the sound reaches from one ear to the another ear. For example, for ear conduction over the ear headphone, the intraoral attenuation value is 40 decibel. So let me explain how this works. For example, we are presenting 60 decibel sounds in the test ear. Then non-test ear sound reached is 40 decibel lesser than the test ear. So here it will be 60 decibel versus 40 decibel. So it will be 20 decibel. So patient in the non-test ear or in the opposite ear will perceive sound with intensity of 40 decibel. But when we use the insert type of earphone, this attenuation is 70 decibel. So if you are presenting 80 decibel sound to the test ear with the help of insert earphone, the non-test ear will be getting 10 decibel sound. That is 80 decibel minus 70 decibel attenuation. So net value is 10 decibel. So other ear, opposite ear shouldn't interfere in the testing of the ear which is being tested. So we need masking. So here we use the narrow band noise centered at the test frequency, and that masks effectively. And I will later on cover how it is achieved. So the test first we start with 1 kilohertz. Here threshold is best for human ears. And then we go to the higher frequencies, 2 kilohertz, 4 kilohertz, and 8 kilohertz. Then again, we come back to the 1 kilohertz and we repeat it if it remains same, or not more than, difference is not more than 5 decibels, we keep it. The best threshold is kept as a threshold. And then we go to the 500 hertz, 250 hertz. Then we plot the audio graph. So how these are marked? So threshold intensity on the audiogram paper is marked for right ear in red color and for left in blue color. So here we are having graph of masking. So on my left side, here you can see that we increase on this axis. You can see the effective masking level. On y-axis, you are seeing the threshold prescription. So how threshold changes when we apply masking to the test here. So here you can see the angulation is 45. So there is a ratio is 1 decibel per decibel masking change in the intensity. So after 3 increments of 10 decibel in effective masking, we get a P2. So this is the right level of the masking. For this patient, the masking level is 40 decibel. So at 40 decibel, we are getting effective masking. So this is a method to mask the ear. But on the middle here, you can see there is crosshair because there is hardly 2 dots are seen, which are showing the plateau. So after that, there is central masking. And here on my right side, you can see initially there is a peripheral masking, and afterward central masking starts. And here you can see the angulation is less than 45 degrees after 40 decibel of masking. So there is a central masking which is not desirable. So this is the blank audiograph, how it looks like. So these are the intensities in decibel, starting from minus 10 decibel and then go to 120 decibel and frequency 125 to 8000. And we write for right ear and for the left ear. So what are the legends we use for plotting the audiogram? For ear conduction without masking, we used red circle, and for left ear, we used blue cross. And for ear conduction with masking, we use triangle of red color for right ear. And for blue, square is used for masking left ear conduction. And for bone conduction, we use arrowhead facing left side, which is red in color. And for left ear, we use arrowhead facing forward, blue color in non-masked bone conduction. And masked bone conduction is denoted by large bracket of red color for right ear and bracket closed blue for left ear. But in certain cases where there is a severe to profound sensing neural hearing loss is there, we reach to the maximum output of the audiometer at that particular frequency. For example, we are testing kilowatt. The maximum output available is 120 decibel for that particular frequency. If individual is not responding to that particular frequency at that particular intensity, we at 120 decibel put this down arrow. So this suggests that that patient is not responding to the maximum output of the audiometer. So how to interpret the pivotal audiogram? So we read air condition threshold, and if it is more than 25 decibel, it is considered that patient is having hearing loss. And for bone conduction, this is 20 decibel. If it is more than 20 decibel, then it is considered the patient is having hearing loss. And by combining two, we get to calculate the airborne gap. So for that purpose, we use three frequencies. Preferably they fall in the range 500 hertz, 1000 hertz, and 2000 hertz. And if airborne gap is more than 50 decibel, it is considered as normal. So it means there is an involvement with the protective mechanism of the ear. So how this is being hearing loss is classified. So here you can see in this audiogram that up till 25 decibel, it is considered to be as normal. So here you can see minus 10 to 25 decibel HL is a normal range. And 26 to, this is denoted by purple color, 26 to 40 decibel HL is considered mild hearing loss. And this is the red zone. This is 41 to 55 decibel HL. And patient is having moderate hearing loss. And this is the green, which is 56 to 70 decibel HL, and there is a moderately severe hearing loss. And yellow zone is the zone which is having 71 to 90 decibel HL, and this denotes the severe hearing loss. Blue, this denotes the profound hearing loss, where there is a loss of more than 90 decibel. So now I am showing the different graphs. So here you can see this is the normal left ear audiogram here. Bone conduction and air conduction also in each other. So this is an audiogram of a normal individual of left ear. And here you can see the bone conduction threshold is within 20 decibel range, and air conduction is at much lower level. It's more than 15 decibels. So this is not conductive type of hearing loss. So here you can see both ears are being plotted here. So here you can see the right side having a type of hearing loss. So this is the audiogram. Here you can see that air conduction, they have overlapping of left ear. And here there is a sharp dip at 4 kilohertz. So this is suggestive of something type of hearing loss due to noise exposure of long duration. So here you can see the sensorineural difference in both the ears. Right ear is like a mild kind of hearing loss, and left is having severe hearing loss. And this is the audiogram. Here you can see that bone conduction threshold is has gone down to more than 20 decibel, and air conduction has further gone down. Which gap is more than 15 decibels. So this is an audiogram of the mixed type of hearing loss, because the conductive element is affected and the sensory segment is also affected. So again, this is audiogram of the left side is sensory hearing loss, mixed type of hearing loss, and this is a commonly asked audiogram in the exams, in the examination. To read this audiogram, here you can see there is a gradual dip at 2 kilohertz in bone conduction. And air conduction has gone further down, and the gap is more than 50 decibels. So this type of audiogram we get in stethoscope plate fixation, that is in the otosclerosis. So again, this is a sensorineural type of hearing loss due to noise exposure. So now we will be talking briefly about the special tests which are the part of the Kyoto audiometry test. The first test which is commonly used is a short improvement sensitivity test. This was given by Dix and Alpine. And what we do, first we get the threshold of the patient for that particular intensity at 20 decibel. So test starts with threshold plus 20 decibel, and there is a continuous tone which is presented to the patient with in between short increase of tones which lasts for 0.3 seconds or 1 decibel with the interval of 5 seconds, and we present such 20 stimuli to the patient. So each stimuli I give, because we have 20 stimuli, each stimuli I give a score of 5%. So 20 stimuli they give 100% score if they can 25%. That's not, it's a very, very rare to have this type of situation. But if a score is more than 60%, this indicates cochlear type of hearing loss, and this is recruiting, and these are the individuals, they face problems with hearing aid they are using because this recruitment phenomenon. A normal score is equal to 30%, but if its score is less than 15%, this is suggestive of retrocochlear type of lesion. So this is a diagram. Here you can see that this is the threshold, this bottom line, this is the threshold of the patient, here 20 decibel. So we are presenting to sound, and the duration of stimuli is 300 milliseconds or 0.3 seconds. There is 50 millisecond rising time, 50 millisecond decay time, and this had to last for 200 milliseconds. And between these two peaks, there is a gap of 5 seconds. And tone decay test is meant for the retrocochlear type of pathology, and here we present continuous tone of 5 decibel above the threshold at 4 kilohertz. If individual is having threshold of 40 decibel, then we present start test with 45 decibel. The normal subject should hear this tone continuously for 60 seconds. So this is important. You must remember. If patient gets this tone continuously at that particular intensity for 60 seconds, then test is complete. If not, then we increase the intensity of the particular tone by 5 decibel till subject hears for continuously for 60 seconds, or there is total 3 minutes time has been elapsed. This completes the test. Tone decay of more than 30 decibel is suggestive of retrocochlear pathology. Briefly, I am touching about the auditory brain response audiometry, which was given by Zavet and Wilson in 1971. So here in this diagram, you can see through the headphone, click stimuli is presented. It's shown by that triangle to the test ear, and the waveform is recorded with the forehead and the ipsilateral. So here we get the 7 waves, but here we have shown only 5 because we study up to 5 waves here. And out of these 5 waves, 5th wave is the most robust wave. And these waves appear at the interval of 1 millisecond. And the other prominent waves are wave 3 and wave 1. Wave 2 and wave 4, they are the feeble waves. So this is a neurological test which assesses the function of the auditory pathway after the brainstem. And here we get the set of 7 positive waves which they occur within the 10 millisecond after click stimuli. So they are labeled 1 to 7. So from where these waves originate, so first wave originates from the distal part of the cochlear nerve. Second wave originates from the cochlear nerve proximal part, and wave 3 has its origin from the dorsal and ventral cochlear nucleus. Wave 4, superior olivary complex and the nucleus of lateral lemniscus. Wave 5, inferior colliculus. And wave 6 and 7, they are having their generators in the medial geniculate body and the inferior corpus. So this is the ABR of an individual of which is having a normal hearing. Again, here we are following same color coding as we follow in the community. So this is ABR of the left ear. Here on this side, you can see the intensity at which click stimuli is given. So first we started with 70, then 50, and then we further went down 30, 20 like that. So here you can see the most robust wave is the wave 5. As we decrease the intensity, the latency of this wave decreases and amplitude also decreases simultaneously. So here we could identify up till the 10 decibel. So here we started absolute latency from say for 6.67 seconds. When we reach to 10 decibel, it has increased to 9.84 level, and amplitude has also gone down significantly. So identification of wave is important, and wave 5 is the most short and persistent wave, and wave 3 and 5 are most important to study the hydrogen layer. And parameter we see is the race threshold for wave formation and absolute latency of wave 1, 3, 5 peaks are studied, and wave 5 latency increase is suggestive of retrocochlear lesion. Interpeak latency interval, they are also important to compare with the other side of it is normal, and difference of the IPL 1 to 3, 3 to 5, and 1 to 5 are being studied, and they increase in case of hyperthermia and absolute intraoral latency difference of wave 5 is prolonged in retrocochlear type of lesion. The application of ABR in effective screening tool for retrocochlear pathology, but nowadays imaging technique is preferred over it, and screening of newborns, especially high-risk babies, and diagnosis suspecting demyelination disorders and malingering individuals, this instrument is helpful. The limitation of this is in normal ABR, there still rules of acoustic neuroma, but not all intrinsic brainstem and non-acoustic tumors of recipient, and it doesn't diagnose the auditory cortex lesions. So with that, I come to the end of my presentation. Thank you very much for patient listening. Hand over to Weston.
Thank you so much, sir. I'm sure the residents would have benefited a lot from this lecture. I now invite questions from the faculty members, please. Do we have any questions from the faculty members?
Dr. Ishwar sir, hello.
Yes.
Hello, Harish.
Yeah, sure.
Congratulations, well presented. I just have a query or a question which is asked in the exam for the why this Karash notch occurs at 2000 only.
It occurs as a natural frequency is at 2 kilohertz of ear, and when we present sound, this mobile foot plates, due to inertia, is out of sync with the skull. So because of that, when it gets fixed, so the dip is seen at 2 kilohertz. Okay.
You are not audible. Speak loudly.
Hello.
हेलो हाँ आवाज नहीं आ रही जोर से
बारी हेलो हेलो
हेलो हनायो
नहीं तुम्हारी आवाज सही आ रही है मेरे को हेलो
हेलो हाँ
हेलो आर यू गेटिंग माय ऑडियो
हाँ Now you are audible. Go ahead.
Okay. One is considered to be natural frequency of the ear because every object has natural frequencies. And the second thing is when we present sound through the bone vibrator, so whole skull sets into vibration. And due to inertia, stapes foot plate is not vibrating with the skull. So that movement of the stapes presents sound to the auditory pathway. But when this gets fixed, so that out of phase movement is not there. So because of that, there is a dip at 2 kHz. Can you hear my answer?
Yeah. Yeah.
Okay, thank you very much, Dr. Taneja. Thanks a lot for a nice presentation. I think we can go to the next talk by Dr. Gulati.
Thank you. Yeah, thank you, sir. We have something very interesting coming up now. The next lecture is on how to crack OSCE. And for that, I now call upon Dr. Gulati, Professor of Excellence at Department of ENT, Maulana Azad Medical College. Sir, please.
Dr. Taneja, please switch off.
Yeah.
I think you have to unshare the presentation first.
Yeah. Thank you.
Okay, a very good morning to all of you. The topic which was given is OSCE run, how to crack it. You know, there's a very nice saying that whenever you go on a holiday, it is not only the destination that matters, but the path along the destination to reach the destination, which is equally important. So today morning at 9 o'clock, we started on this path towards our destination. And in the path, we had 2 lovely halts in between, which was a beautiful lecture by Jyoti and then by Harish. But at the end of the day, every resident has only one destination. And that destination is the final examination. Whether it is an MS examination, a DNB examination, a NEET examination, a next examination, whatever examination. But for a resident, it is that examination which makes all the difference, and that is the destination. The how to crack an OSCE, it is not only for an OSCE, let me put it, how to crack any examination is a very simple thing. Believe me, if you look at it, 3 words will describe it in very short, how to crack any damn exam in the world. And the 3 words are, know your subject. There is no shortcoming for that. If you do not know the subject, believe me, it's a very difficult thing to crack any examination. Having said that, if I again quote a small quotation, to crack any exam, it's all about a mindset, it's all about time management, and then comes the preparation part. You know, in a theory examination, you have 10 short notes, or you have 5 questions or 3 questions or whatever it is. If you spend your time answering the first question that you know very well and spend your 2 hours on that, and the remaining 9 short notes go into 1 hour, believe me, you are never going to excel at anything. So that is what is going to make all the difference. So let me look at the Indian context. The Indian context is 546 medical colleges on date, approximately 80,000 undergraduates coming out this year, 32,000 seats for post-graduation, 650 DNB accredited institutions. Now, if you look at this, this works out to be approximately 40,000 postgraduate seats in our country. So 40,000 students are going to appear at this destination somewhere or the other, somehow or the other. Now, let me just summarize again our problem for today. Our problem for today is very simple. There are 2 problems. One of them is education and other is evaluation. I think we need to unmute somebody over in the group. Dr. Nandini, thank you. So the problem is basically twofold, the education and the evaluation. why is the problem occurring? Physicians of tomorrow, our students, our residents, are taught and evaluated by teachers of today, you and me, using the skills and methods of yesterday. You know, if I go back in my training, what I did during my MS in paper 4 in ENT recent advances, I teach almost as history of medicine today. That time, a short note, let me say, on endoscopic sinus surgery was something which I didn't read also at that time. Endoscopic sinus surgery was a very simple answer. Endoscopic, endoscope, sinus means nasal sinuses, surgery means operate. So operate on the nasal sinuses using an endoscope became endoscopic sinus surgery. And who knew today, 30 years later, 35 years later, we have a full specialty in itself on that. So this is what the problem is, and what is the attitude of ours is very well depicted by this baby in the picture. So we have problems in our system of evaluation. Quote again, happiness should be a feature before an experience and also after it, and not just after an experience. What I mean to say over here is that an examination process should be a pleasure to approach not only before an exam, but also after an exam. That is, while I'm preparing for an examination, it should be a comfortable exercise and enjoyable exercise. Now that exercise extends for my 3 years of residency training. If I attend my rounds every day, if I attend all my clinics every day, if I attend all my lectures every day, if I attend all what my teachers say every day, it becomes a very pleasurable experience learning. And at the end of the 3 years, believe me, most of you would like to say, okay, fine, let me go for a movie today, one day before the examination. And it should also be a pleasurable experience after the examination. That is, when the result comes out, everybody should come out with flying colors if you have done your 3 years of residency training in a proper manner. And that residency training is not only just getting a theoretical knowledge, it is how to go about approaching an examination, how to go about learning a clinical examination. So till you form a system to evaluate, to examine, you are never going to be a successful clinician. And your examination starts the minute you start approaching the patient. Now, if I ask how many residents are wanting to appear in an examination tomorrow, you don't have any time to study, you have not studied at all. So how many of you are going to enjoy an examination tomorrow? Are you willing to appear for the examination? So you saw one candidate and you saw so many residents standing in the background, all of them saying, na, mere ko exam mein nahi appear hona, aaj maine padhai nahi kari. Why should this attitude be there? Maine padhai nahi kari. Agar 3 saal if I have studied properly, OSCE, MS, DNB, MLE, ECF, MG, you name it in any exam, I should always say, ha re, like what Daler Mehndi would not have said, rather than saying, na re. And if you learn that, that is the key to crack not only an OSCE, but any exam. Now, what do I need to evaluate a student for? Incentive to learn. If I am going to get a gold medal, that's enough of an incentive. If I'm going to get a degree, whether it's a DNB degree or an MS degree or a diploma or anything, it should be an incentive. That is my aim to achieve. Feedback to the student. It also gives the feedback to the student. Look, gentlemen, you're doing very nice. Prep up more. If you're doing a little bit less nice, so you need to pull up your socks so that you reach the destination comfortably. Modification of learning activities. Now, this is something which each resident must know, that clinical studies do not involve studies only in your room. Love and Bailey said, you want to embark on a distance across the seas, you need to sit in the boat and let the boat go into the sea. Only then you are going to cross the ocean. If you are going to sit in the boat on a port itself, you are only going to sit over there and only watch the waves and do nothing more than that. And when you come out, you will never be a sailor, you will never be a captain, you will just be a passenger over there. So you need to modify your learning activities by going out into the wards and learning what to do correctly. You know, it's not only just learning how to examine a patient, it is how to examine the patient correctly. Then selection of students, I have to have an attitude and an aptitude for learning. You know, there's no point, I want to be an engineer and I'm forced to be a doctor. I want to be a physician and I'm forced to be an ENT surgeon. No, that's not the correct way. If I want to be an ENT surgeon, let me be an ENT surgeon. Let me tell you, when I appeared for my MS examination at PGI, I had the option of giving 3 choices. And my choices were first choice MSc-ENT, second choice MSc-ENT, third choice MSc-ENT, period. At that time, it was a very difficult choice to make for anybody, first choice, second choice, third choice ENT. But I made it and I don't regret it even for a single day. Success or failure, this is where the evaluation process lies. And this, how we go about it, is very important. Feedback to the teacher. A teacher also needs to get a feedback of how he should modify his learning activity. That this is where the residents and the peers play an important role. There's no hard feeling if somebody comes and tells me, sir, your talk is very dull, monotonous, boring, please don't talk like that. I should always be willing to change my learning methodology. So it's not only an evaluation for you, it should also be an evaluation for me. Then the school public relations, how the college also has its public relations. Maulana Azad Medical College may be a good college, and when an examiner comes or when an examiner goes to MAMC or to PGI or to Chandigarh, believe me, an examiner also reads and goes ki yaar yahan ke bacche mere ko tang karenge. But if he has to go to Timbuktu Medical College, wo bolega chhod yaar jo marzi pooch luma, it doesn't make a difference. So the school public relations and the evaluation of the school also makes a difference. And then as a surgeon, I need to protect the society. In an examination, 3 aspects need to be evaluated: what we know, what we do, and how we do. Now, these 3 things are very important for you to do it in the correct manner, learn it in the correct manner. And what should be the objective of any examination? Whether it is an MS or an OSCE, it should be an impartial examination. It should be uninfluenced by external factors. It should be unprejudiced, and it should be a detached thing. You see, uninfluenced by external factors. Maybe that's to some extent wrong also. You know, I may be a very good surgeon, I may be a very good physician, a very good candidate. But if I go over there wearing an orange trouser, pink shirt, have a stud in my nose, have coiffured hair and all that, I may not do very well, because that's not befitting for a doctor. So it's not only these external factors, these are influenceable in external factors. So one must know how to go to an examination or conduct yourself in a dignified manner. And then nobody wants a partial examiner. Everybody wants an impartial examination. But not only that, everybody wants an impartial examiner and the examination process. So a student evaluation. Why do I need to evaluate the student? Incentive to learn, feedback, modification, selection, success, failure, feedback, public relations, protection. These we have just done through. So the need of the day is to make any examination system reliable, valid, and objective. This is 3 words which are very important. In every examination, there is a variable. Lesser the number of variables, the better it is going to be for an examination. So a student should be the variable thing. The examiner, if it's constant, and the case and the questions, if are constant, believe me, the examination process becomes very nice. So if everybody is given a case of unsafe CSOM with the same set of questions of the same level, and the same examiner is asking him, only the student differs. So you can always compare how the candidate has excelled himself in the examination process. So when to test one variable, if other 2 are constant as much as possible, the system becomes unimpeachable. Reliability. If each student faces the same examiner, same questions, same patients, the examination can be made more reliably. There's no point in giving somebody a case of acoustic neuroma and other person a case of deviated nasal septum and then try to compare, oh, you're comparing apples and oranges over there. That should not be the end aim over there. So a system should be that one needs to make it reliable, and that is where the OSCE system comes into the picture, because all over the country, the exam is going to be held on the same day. All over the country, the same type of patients are going to be given. A predetermined set of questions is there. A pre-evaluated set of marking pattern is there. And the examiners are briefed, debriefed, and then the examination pattern happens. The questions are set. They are not only set, then they are evaluated, then they are validated, revalidated. So we have a common set of situations which everybody faces all over the country, irrespective whether he is in Tamil Nadu or in Jammu and Kashmir, whether he is in Arunachal or in Gujarat, but everybody faces it on the same time in the same day. The objectivity, the expected answers can be pre-prepared, and the pre-marking pattern is predetermined so that we reach some semblance of an order over there. So what does an examiner want? As an examiner, I would want a precise answer from a candidate. I would also like a correct response. I would like an analytical mind, a comprehensive knowledge, a communicative candidate, a logical approach, a clear mind. And above all, I would also want a clear conscience that I have done a good job as an examiner, and I also want to produce a successful candidate. Every examiner, remember, is a parent. Every examiner is a responsible social individual. He wants the residents to clear and serve the society, but I would definitely want a clear conscience when I pass an individual. At times, I have, I can commit myself and say that yes, I have at times cleared candidates which should not have been cleared, but then that was the way of life. And I've marked those cities where I have candidates such as these who should not have cleared with a red dot on my map, so that when I'm driving down the countryside, if I'm passing through that town, I drive very, very carefully, because if I have an accident, that gentleman whom I passed over there, who should not have passed, is an ENT surgeon, and if I need a tracheostomy, he is going to do my tracheostomy, and with that surgeon, I would not trust an autopsy over there, so I need to have a clear conscience when I pass an individual. So whenever you answer, be precise in your approach, give a correct response. Let me tell you, the examiners may at times just look at you and smile, and then you feel that you have conned the examiners and fooled the examiner. No, believe me, he is much more experienced and senior than you, and he knows what he is talking about, and he knows that you can't fool him, but he is letting you ride over there, and you need to be careful of that. I need an analytical mind. I don't want A for apple, B for baby, C for cat, D for dog. I also can ask you if A is for Alabama, B is for Brahmkumari, or whatever it is. So you need to have an analytical mind also. Comprehensive knowledge. You have to be a jack of all trades and a master of all if you're going to be a good surgeon. Just being a jack of all trades and master of none is not going to serve too much of a purpose. And also, as an ENT surgeon, you don't have to be an ENT surgeon. You also have to be a neurosurgeon, a faciomedical surgeon, a dentist, a general surgeon, a head and neck surgeon. So a multitude of comprehensive issues you must know in any examination. A communicative candidate, you must know how to communicate. You know, there's no worse thing in an examination than mumble jumble over there. Believe me, you talk loudly, you talk clearly, you talk confidently. At times, let me tell you, you can even get away with a wrong answer. You can get away with murder, because the examiner always feels if he's talking loudly and clearly, he must be knowing his subject, so I can switch off my antenna and go to some other area. A logical approach. So if you're going to examine the oral cavity, see the lips, see the teeth, see the gingivobuccal sulcus, see the tongue, see the floor of the mouth, and go procedure step by step to have a logical approach. And believe me, you'll reach a logical answer and a clear mind. You need to think out of the box, and you need to think clearly. And what does the candidate want in an examination? He wants a valid, reliable, and a fair exam. He also wants encouragement during the examination. You know, there are certain issues which come across. Tell me, do you know this answer? No, sir. Then you have to tell me this answer. No, that is not. A candidate wants an encouragement, and I know that you know the answer, but you are not able to bring it out. The examiner must come and encourage him, and that is something which is important. And every candidate wants a fair examination. He wants a value for marks. He doesn't mind failing, provided he's told that this is why you have failed, and he understands that he was not prepared with the subject. And above all, every candidate wants success. Just like every examiner wanted a successful candidate, every candidate also wants a success. So when you're taking a case, competency in history taking is important. Interaction with the patient, rapport with the patient, empathy with the patient. Sympathy, maybe no, but empathy, yes. You must put yourself in the patient's shoes and then give that empathy. Skill in interviewing, how you're going to interview the patient, pacing the questions, pattern, response, how you're going to analyze it. All these are going to be your skills over there. Competence in a physical examination. Examination of a limited area done in an allocated time. You have half an hour to do a case or 45 minutes to work up a case. You just see to it that you can take a history, you can do a good examination, you can reach your valid thing, and then you can think and put your points down, put your thoughts down. What can be the provisional diagnosis? What can be the differential diagnosis? How can you reach a final diagnosis? All these steps, if you're going to do, you're going to reach a conclusion, which is going to be in that allocated time for you. So inspection, interpretation of the patient's charts, laboratory investigations, all of them are very important. And then in competence, it is not only your competence as a surgeon, you also need to have competence in providing information to the patients, interpersonal skills, surgical or clinical instruments, examination of specimens, physical examination on simulated patients, on direct patients, on models, mannequins, practical procedures, examination of the various components. All these things are important. So we come to the topic of OSCE. Objective, structured clinical examination. Objective, it is objective. Structured, it is structured. Clinical examination, the words explain it all. So when we talk about OSCE, the principles of OSCE are that we have stations. Now what are stations? Stations are nothing but conference stalls. How you have the conference stall? 2 meter by 2 meter, 2 meter by 3 meters. You have in a circular way or a quadrangular way in a room, in a hall which is set, and each one of the thing goes from one station 1 to the station N, and you get all the candidates circulated the simultaneous. So if you have 30 stalls, you will find 30 students going into the hall. Each station will be about 5 to 6 minutes. So if you take 30 stations, 30 into 6, that makes it about whatever the number of minutes come. So you know the examination is going to last that much time, and it is going to finish in that much time. Each candidate is going to get the same time. You know, all of us do realize one problem, that the first candidate who goes and gets evaluated for maybe 45 minutes, 1 hour, while the last candidate who goes in gets evaluated for 5 minutes. It seems unfair, but the practical thing is, the bottom line is that. So if they, over here, every candidate is given 5 to 6 minutes to answer the specific questions which are based on the stations, and a careful watch. Yeah, all the candidates are under videos. All the candidates are being watched by the observer examiners, by the volunteers over there, and also you are how you are conducting yourself, you can be observed. So all these steps are a part of the OSCE. So when the relevant steps are there, it is recorded on a paper, it is scored on a paper, a checklist which is pre-planned, and the total time spent is about 2 to 3 hours, and 30 students come out in 2 to 3 hours as far as the objective structured run is concerned. That's what it is. So if I look at the overview of an OSCE, we see this is how the stations will look at. I've just taken 10 sample stations over here. Station 1 would be a history-taking station. You may be given a short case over here, take the history related to maybe, let's say, deafness, maybe vertigo, maybe anything, and you take a history in that, given 5 minutes over here. Then you go to after 5 minutes, you go to the next station where your response to the history is going to come in. So you have questions based upon the history of the previous station, and you answer them accordingly. Next station, at the end of 5 minutes, you go to the clinical examination. You have a patient over here, or you have a model over here, or you have a simulated patient. Do a clinical examination with respect to, let us say, maybe a thyroid swelling, maybe a maxillary swelling. You examine it carefully, note down your finding on a paper. At the end of 5 minutes, you go to the next station where your responses to the previous stations are to be checked. So if you have in the clinical station, let's say a thyroid, and you have a thyroid which moves on deglutition over here, on station 4, you may have a response over there. The swelling in the neck moves on deglutition, yes or no. So you have to mark over there, yes or no. So I would know whether in the previous station for a thyroid, have you checked for deglutition, movement on deglutition? Have you checked the movement on, the tongue? So that's how it would be going. But we'll come to that example very shortly. Then comes X-ray. Now I may give you a CT scan over here, ask you to study the CT scan in reference to maybe a temporal bone, or maybe a maxilla, or maybe anything. And then once you study it, you note down the points, and then on the next station, you answer the questions based on that CT scan or the X-ray. Was it a contrast-enhanced CT scan? Was there a breach in the lamina pepricia? What sort of a cribriform plate was there? So I can ask you the questions based upon that. Then you can have a specimen. I can keep a specimen over there and have the questions based upon the specimen. This specimen is that of a laryngectomy. What is deficient in that? The tracheostome is not visible over there. Tracheostome. So all these questions you can base on a specimen over there. Next would be a problem-based question. I can give you a problem, a clinical situation, or a clinical finding along with an investigative finding, along with a radiological finding, and then build up a series of questions to evaluate your skill and knowledge over there. Next, I could have instruments over there. I could have counseling station, counsel this patient regarding a child who has a congenital hearing loss. How would you rehabilitate the child? So here my communication skills come into the picture. So if you look at it, we have all the domains which are checked over here. Over here, my communication skills will be there while we're taking a history. For counseling, my communication skills will be there. For instruments, my recall of knowledge will be there. For performing a particular task, let us say in the clinical examination, my psychomotor skills can be evaluated. So all the 3 domains in this examination process are dominated. Now, one question over here, when all the candidates are occupying all the stations, somebody will be entering the station number 2 directly, but he does not know what history was taking. So he will stand outside for the first 5 minutes because he has not been to the station 1. And at the end of the round, when he comes over here, everyone would have finished the 10 stations except this gentleman who was outside the station. So he will go to station 1, and then he will go to station 2 to answer. So that's the end of the OSCE round. 5 minutes extra will have to be taken by that candidate. So what are the different types of stations in an OSCE? It would all depend upon the scope of subject to be covered and the predetermined objectives which are there. But remember, the number of stations should be big enough to cover the whole syllabus. It should not be small enough. So, and then there should be a minimum number of stations should be with the number of candidates who are appearing. So if you have 30 candidates appearing, you cannot have less than 30 stations. You should have 30 stations. So that is how the OSCE would work. So the stations could be a history-based station. It could be clinical examination-based, analytical station. I could give you an audiogram to evaluate. I could give you any investigation to evaluate, and then see what your analytical skills are there. It could be investigation-based, task-based. Do this examination, perform this test, do a knee jerk, do a Valsalva's maneuver, anything I can ask you to do. I can give you clinical spots. I can give you a simulated station a counseling, and in between, because if 30 stations are there, so 3 hours would be a very long time. So I can give you a rest in between, a rest station where you do nothing but sit down and have a cup of coffee or something. So this is how the series of stations would work. So now let us look at an example. Now, station 1 would be, let us say, take history related to otalgia from this patient. So now you take a brief history related to this patient in 5 minutes, and then you go on to the next station after 5 minutes, and you have this response sheet over there. Now, in a case of otalgia, what all did you have to look at? Pain, which year, how long, what type of a pain, character of a pain, increasing and decreasing factors. So all these things you should have taken while you are evaluating a patient of pain. So, and this is what the next station is. This patient has history of pain in both the years. Pain is present since 2 days. Now, supposing he gives a history, the pain is present in the last 10 days, and you have not taken the history. So now at the pain is present to 2 days. You do not know the correct answer. Now, if you give a wrong answer, you may get a negative feedback over there. Or you just skip that question, so I do not know. So you do not get any credit for that. So you have a credit, you have a discredit, or you have no credit over there. So this is how you would be taking a history station. Now, a skill station, examination space station, palpate the neck nodes, neck of the for lymph nodes. Now you have 5 minutes to examine, you note down your points, and when you go down to the next thing, over here it was an observer station. At the same station, there is an observer station over there with you who's watching you evaluating the neck. And he has a checklist with him. Did he stand behind the patient for examination of the nodes? Did he palpate one side at a time? Did he flex the neck while palpating, look for tenderness, examine the raised temperatures? So the general things for a swelling or for a neck node are evaluated at this station. And over here, we have the observer station. There's an examiner who's watching you do it. He can also ask you questions based on this station, and therefore you get a full evaluation over here. You are observed. In a conventional examination, what happens? I send you to the other room, you take a history over there, you do the examination over there. The examiner probably would never see you taking an examination, taking a history. So it becomes a blind procedure and something like that. So this is how the station progresses. A 2-year child. Now over here, it comes as convey the diagnosis. So over here, this becomes basically a counseling station, your communicative skills. So what have I tested over here? The knowledge about the disease process, whether he knows what the disease process is, how to manage it, how to rehabilitate, ability to convey it. Again, it shows me how to convey it, and my attitude. You know, how I talk to the patient, how I approach the patient is very important. So over here, the observer, what he can see is, did he make the patient comfortable? Was the mother fear regarding the diagnosis and management dealt with by the individual? Instruct regarding the use of antibiotic drops, how to use the antibiotic drops. So all these things form a part and parcel of the process. Now, this also is an observed station. We have an examiner over here who's evaluating you. So you see, I am not only testing your knowledge, I'm also testing your psychomotor ability. That means how you're going to do about it. I'm testing your cognitive, your situation where how you're going to communicate with the person, your attitude towards the patient in general. So this is what makes all the difference. Another station, on a model, do a laryngoscopic examination. I may keep a mannequin over there and ask you to do a laryngoscopic examination. So over here, this is also an observer station. Examiner is watching you, and what will he say? Did he position the dummy correctly? Did he fix the light source correctly? Did he extend the neck properly? Did he take leverage along the teeth? So you can get a positive mark or a negative mark over here, and the answer will be yes and no. It's a predetermined checklist. So this is how the OSCE keeps on progressing. So the stations may be observer-based, which can be examination, task, communication skills, and history-based. They can be non-observer-based, instruments, radiology, specimen. I don't have to have an examiner over there. So the thing is kept over there, questions are asked, and you continue. Then there can be Viva stations. Now, just as a conventional Viva, we have 4 Viva stations, ear, nose, throat, recent advances. So you have 4 stations, 5 minutes for each. So 20 minutes Viva is a fair enough Viva. So you go along all the stations to answer, but you will be asked the questions related to that particular field in which the examiner has been asked to do it. Then the analytical based, few points you must note. You must read and follow the instructions carefully. If you are told to examine the right ear, examine the right ear. If you are told not to do a tuning fork test, do not do a tuning fork test. So you are given very specific instructions so that all the tasks can be completed within that limited number of time in an OSCE. So you perform that given task with care, keep the time limit in mind. You have a limited time over there, and be specific and brief. Give your point answers in a bulleted manner over there rather than writing a descriptive essay. So this is where it differs from a conventional exam where you can write stories, essays, picture, whatever you want, whether it is relevant, irrelevant, logical, illogical, but over here you need to be to the point. Non-observer stations, like I mentioned, instruments, investigations, radiograph, osteology, spotters. So these may be evaluated during the Viva also if you want. So when we look at the stations, in a Viva station, I can ask you about an instrument, but they are just a starting point for the discussion. What is this? It's a Boyle-Davis mouth guide. Where is it used? For a tonsillectomy. Then my Viva can go on tonsillectomy. What are the complications of tonsillectomy, indication of tonsillectomy? Whatever I want to ask over there is my sweet will then. Then the instruments may be there. I may ask you to identify, use, surgical procedure, complications, pre-operative. Now, these can be non-observer based stations also. I can put a laryngoscope. Now, over here would open a field of whale of questions in laryngology, head and neck surgery, foreign body, anesthesia techniques. So all these things can be evaluated at this station. So anatomical attributes, indications, difficult situations, workup. Any questions I can ask you based upon a laryngoscope. It may be observer-based station. It may be a non-observer-based stations. Same way I can ask you questions on ear surgery. I can ask you plain radiographs. I can ask you contrast radiology. I can ask you CT scans, MRI, anatomy, pathology. You know, there's so many things that it all depends upon how sadistic the paper setter can be. He can really go into every field of ENT in detail and work out a good OSCE presentation over there. Same way, histopathology slides, gross specimens can be kept, investigations can be kept, which can be audiogram, impedance, BERA, butterfly charts, calorigram, polysomnograms. It's a large whale over there what you can really see. Viva OC. Now, Viva OC purpose is, now this is where the examiner-candidate interaction comes. The examiner can go into the depth of the knowledge. How deep is it? How is the analytical situation? How does he respond to difficult situations, to challenging situations? An examiner can evaluate over here. So while he puts the questions orally, we can evaluate the candidate's demonstration of his knowledge, his understanding the subjects, his thinking, and his problem-solving ability. So aim of Viva OC is to get a brief encapsulated attitude. Also, communication skills, confidence, articulations, ability to answer properly, the one's thinking, and the time management skills. You can't waste your time. If you don't know an answer, be frank enough. I don't know the answer to the candidate. Examiner can go to the next question rather than waste time on one station. So whenever you have categorized must-know areas, should-know areas, good-to-know areas, desirable-to-know areas, there is no excuse for not knowing a must-know area. If I say, what is this? And you say, this is a ear, I refuse to pass you. So you must be there are certain must-know areas which you must lay more stress upon, and there are certain genetic predispositions, everything. They are good-to-know areas. If you know them, I give you credit, but I do not know discredit. I do not give you discredit if you do not know those areas. So be prepared to answer a variety of questions in any examination. एक ये जो है बंदा, इसने हमारी जान को तंग किया हुआ है. ये कौन है ये? अगर वो कपिल शर्मा शो में वो गुत्थी आता था पहले, यू नो दैट ग्रोवर, एंड ये तो हमारी जिंदगी खराब कर दिए हैं. ये कोरोना ने has ruined our entire structure. So necessity became a mother of invention. So the OSCE, rather than be a physical examination, became a virtual examination, an online virtual examination, what the national board is following. So those of you who would be appearing in the examination on the 11th, let me give you a clue. You are going to be evaluated on the OSCE aspect in a virtual manner. So you will be sitting in the various centers. You may have individual screens or a central screen. The OSCE will be projected on the screen, and there you are going to answer the questions based upon that. Your answers are going to be evaluated spot on in the National Board of Examination headquarters itself. And the second part of the OSCE examination, that is the clinical part, the case part, and the observer part, will be observed directly at the center where you are preparing for the examination. So necessity became a mother of invention. The OSCE, which was originally initiated in the University of Dundee, which then took over to the Royal College, and then the Royal College was a very strict OSCE without any candidate examiner interaction. The Indian OSCE model changed that, made it much more interactive, and this was again incorporated into the Royal College examination to make it more interactive. And now the Corona times have made further modifications into the OSCE system, where we have a blended system of examination. We have an OSCE part and we have a direct observational part in a conventional type of an examination. So necessity becomes a mother of invention, and believe me, that is what makes all the difference. So in an objective of the OSCE is same test on the same day, at the same time, with the same marking pattern, with the same examiners, using the same objective structured practical examination. So this is what the main aim of goal of OSCE is, and how you're going to crack it. So what should be your attitude? Get the habit of developing a system of examination. Learn the basics. Avoid selective reading. Pay attention to the daily round teaching. That's most important. Discuss, discuss, and discuss. I do not I would not go back and I would not hesitate to say that certain DNB trainings which are being held in corporate hospitals where the teaching is not proper. Believe me, have guts to go to your teacher and say, please teach me. Believe me, if he's a good teacher, no teacher is going to mind if somebody resident comes and says, please teach me. We live for teaching. Amitabh Bachchan ka dialogue tha, I eat, I sleep, I do what that. So I also as a teacher, I sleep teaching, I eat teaching, I live teaching, I enjoy teaching. And a candidate, when he comes to me, believe me, I will love that candidate if he comes and says, sir, please take a class for me. And what should be your attitude? Avoid a monotonous speech, avoid mumbling, avoid distracting mannerism. Sir, no, that's not to be done. Avoid meaningless phrases, avoid interjection. The examiner is asking you, before he finishes the question, you start answering. Believe me, like KBC, the whole question may be different. So you do not know what you're in for. Avoid motionless presentation. Sir, I would like to do this and do that. No, it's a very irritating thing. Bring expressions, change your modulations, change your speech tone. Believe me, make it interesting. No examiner minds it. And avoid a loud dressing sense. Please go dressed in a nice manner. The fundamental of an OSCE over here is when everybody gets the same things equally, all are happy. And in your OSCE exam, you all will get the same case, same question, same problem, same marking pattern, and a similar happiness or a similar sadness if you do not do it properly. The bottom line, the process of evaluation judges your assessment, critical approach, judgment process, problem-solving ability, presence of mind, and a communicative skill. What should be my approach in an examination? I should go relaxed. I should go without any tension, without any fear. Or kabhi bhi koi bhi examiner jab aata hai, I should have the confidence of taking him on. But if you're not certain of where you're going to go, you may very well end up somewhere else. So know that your subject is there and you're going to be evaluated. That is what the key to it is. And what should be my approach in an examination is done by this lady over here. She is a candidate going for the examination, happy-go-lucky, enjoying her task over there. खुश है जिंदगी में, मस्त है जिंदगी में. मेहरबान एग्जामिनर है, आइए मेहरबान. Sit down. Be happy. Take my exam at any time. मुझे कोई गम नहीं है एग्जाम से. And believe me, you saw how an OSCE should be answered by this beautiful song. She was smiling, she was confident, she was making her tones up and down, she was giving expressions, and believe me, I see no reason why she would not have passed. Thank you so much for being with me on this non-ENT topic, but that is the destination, what we all had. Ravi, I was given a time till 11 o'clock. You have still 2 minutes short. Thank you so much. Thank you so much, Praveenji, for organizing this in a lovely manner. The entire ENT department, I think, deserve the credit. All the residents deserve the credit for organizing this Zoom meeting so nicely. Thank you for bearing with me.
Thank you so much, sir. It's right through my PT days. It has always been wonderful to listen to your lectures all the time. Thank you so much. And I invite comments from the faculty now.
Hello.
Ji Praveen ji.
Ji. Very nicely taken lecture, sir. Just by way of this communication, I want to give message to the delegates that knowledge, understanding, applicability, and skills are important in any objective examination because it is a competitive screening test. So competitive means every mark will be negatively assessed. So be careful, and I think Dr. Gulati has given a very nice lecture, and it will resolve your most of the problems. And thank you very much, Dr. Gulati.
See, Praveen ji, bottom line always comes, जो जीता वही सिकंदर. एग्जाम में अनफॉर्चुनेटली सिकंदर चाहिए हमको पोरस नहीं चाहिए, चाहे जो भी एटीट्यूड हो पोरस का सिकंदर के साथ, एक राजा का एक राजे के साथ, लेकिन जो जीता सिकंदर वही होता है.
गुड मॉर्निंग डॉक्टर एचएल जी.
हाँ जी.
आपका लेक्चर मैं नहीं सुन पाया. आई वाज इन द बाथरूम.
लेकिन अभी आप बड़े बाग में बैठे हो.
अब मैं बाग में आ गया हूँ ना. यार ओके. चलो, मस्ट हैव बीन एन एक्सीलेंट वर्क.
Thank you so much.
Thank you.
Good morning, sir. Ishwar here.
Hey, Ishwar.
Sir, it's always pleasure to hear you. आप motivational speaker preacher और बन जाओ. You are elevate the ये ना बच्चों का एक होना चाहिए regularly because it boosts their morale. You can do well. and that is what is required.
I think in the new CBME program, even from the undergraduate levels, Ishwar, the communication skills has been laid a lot of emphasis on good communication skills, because if we see a lot of violence against doctors occurs because of non-communications, because of lack of communication skills. And if you are on a continuous dialogue with other people, believe me, a lot of these issues of violence, etc., can be sorted out, and you always turn out to be a good doctor. So I think you are absolutely right. Communication skills as a training part for all residents and all our medical graduates is a very, very important feature over here.
Sir, communication in any relation will improve, sir. Even it may be in between husband and wife or family members, among that also. If there is exchange of ideas or exchange of whatever the problem, that will always save. It is the basic fundamental rule for a good coexistence, even in the family.
हम सबने
them also.
कोविड टाइम में 8 महीने घर रह करके, घर में ज्यादा देर रह करके एक ये चीज सीखी है जो ईश्वर ने बोला, हस्बैंड वाइफ की कम्युनिकेशन बहुत इंप्रूव हो जाती है. एब्सोल्युटली राइट ओवर देयर.
हेलो सर, उसके लिए वेबिनार नहीं है ना? वेबिनार भी तो होना.
So I think if there's nothing else, I say thank you so much.
Thank you, sir. Thank you very much, sir. Thanks a lot.
Okay, dost.
I think we can start with the inauguration ceremony. Dr. Vasun.
Yes, sir. Yes, sir. So I'd like to invite Dr. Rathore now for the welcome address, please.
My voice is clear?
Yes, sir.
Yes.
It gives me immense pleasure to all delegates and the esteemed faculty that at present we have 413 live delegates, including faculty, and this shows that how far we have reached from our beginning. And again, a very good morning to all persons at the behalf of the ENT department and head and neck surgery department, Maulana Azad Medical College. I welcome all of you on online update program, PG update. In current changing environment of deteriorating physical training and updated webinars, the ENT knowledge is essential for the practice of the specialty of ENT. And this our department is doing its bit in this go. See, this is a bilateral sort of, this earlier we used to have a physical program, then bilateral things were allowed. And this time we have some restraint, and I think delegates will bear with us for a time being. Few years back when we started this educational fiesta, with the help of the department faculty, we formulated a update module, and which was improved every year with the help of the feedback from our delegates. Mainly we are focusing on postgraduate teaching programs. And every year we improved upon this, and I proudly feel, give this update. Here we have modified our recent version of a medical training for the help of all the delegates who are probably joining from the all over the country at present. And we have carefully shaped this program with help of our departmental faculty, and we have all India esteemed teachers, very renowned people, without ENT surgeons. They will add their experience to this, and this program you will like as a formulating stone in your career. I hope you will find our effort useful and enjoyable. Please do give your feedback to us so that we can improve further, and your feedback will definitely improve a force to our future endeavors in this postgraduate update. All right. Now, I take this opportunity that we have recently Dr. Ashish from CMC Vellore and Dr. Nitin from Director AIMS Raipur. They have both logged in and joined with our, I welcome both of these esteemed teachers. Thank you. And I take this opportunity to congratulate the host room for its excellent organization of this annual academic fiesta in innovating in difficult times of COVID pandemic. Now the medical teaching in future will not remain same. This COVID is here, has changed the medical teaching in a different format. So we are modifying as per the time, and we are also improving our skills of these computer trainings also. And I think we'll be communicating with our delegates and the faculties in the same form in future. I now invite our respected Dean Maulana Azad Medical College, Dr. Nandini Sharma, to formally inaugurate this PG update and oblige. Thank you, madam.
Thank you, Dr. Rathore. Am I audible?
Yes, ma'am, you are audible.
Okay, okay. Eminent speakers, as I can see from the list of speakers in the program, distinguished participants, head of the Department of ENT, and all my other colleagues, a very good morning and a warm welcome, though it's a virtual welcome only to NAMC and to the 9th ENT update. It is something very interesting to note that this update has been continuously going on for 9 years without fail. And even now in the pandemic, the ENT department, with its never say die spirit, has kept it up by changing the platform. So it's not a real one this time, it's a virtual one. So at the outset, I think the Department of ENT of Maulana Azad Medical College deserves applause and congratulations for not breaking the tradition of holding this very important learning, which is imparting to the postgraduates, and I'm sure to all the other faculties and junior as well as senior. So this is something very important. And they are, of course, at the forefront of the fight in this pandemic also. But despite that, they have taken out time and made this effort to get this virtual platform. And from the list of topics that I see on the program, it's quite exhaustive. And I'm sure it will cover a lot of, it is going to impart a lot of knowledge. And what I just heard a little of what Dr. Achal Gulati was speaking about is bound to be a very interesting program also. I wish I could hear more, but the only thing is that it is not possible to spare that kind of time. Next year, I'm sure I'll join you all. So it was a very interesting thing with all the movie clips and all. And of course, ENT is a very interesting branch that way. So, and for making it interesting, I think the credit goes to the department for having continuously, as Dr. Rathore was saying, upgrading, updating, and improvising, improving, and innovating in the program. So I'm sure you'll continue to do that. The speakers, of course, drawn from in-house as well as all the faculty from the teaching hospitals, other teaching hospitals. We are grateful to them for having spared the time and joined us here. And all the students, the postgraduates, the young faculty, and as well as I'm sure that senior faculty would benefit greatly from all the knowledge that is imparted, which is going to be of benefit as I think the plan is to make the postgraduates benefit and the help in their examination, especially from the case studies and what I think I just heard about OSCEs being used in all the, so that is something very important, I'm sure. So the audience is also going to be very rapt. If it's a need-based program, you always have a very rapt audience, a very interested audience. And when the audience is interesting, the teachers are also very interested in teaching. So all in all, I can see a very win-win combination here. And I'm sure this is going to be a very interesting, a very enriching program for the speakers as well as because we are all learning also while we are teaching, as well as the people who listen and people who imbibe this knowledge. I will not take much of your time. It's a very interesting program that you have lined up. So you should all go ahead with it. But thank you all once again for actually making this happen. And, our college is always grateful to all the faculties who take knowledge forward and carry the flag forward of the college. And warm welcome to you all again. Hopefully it should have been not a virtual welcome, but then even a virtual welcome is great in this era. So with this, thank you all. And please carry on with your very interesting presentations. I'm sure all your speakers are as interesting. Thank you.
Thank you so much, ma'am. May I now request Dr. Ravi Meher, please, to address the gathering.
Thank you, Dr. Vasant. So I would like to thank our Dean ma'am for her constant support and encouragement to all the academic activities which are being held by the Department of ENT. And I must also thank our head of the department, Dr. Rathore. And it was his suggestion that we should not break this tradition of holding the conference, because initially we thought that because of COVID, we have to call off the conference this year. But it was his suggestion and advice that we should continue and we should hold it in an online mode. And because of this only, we are able to meet today in an online mode. And I also thank all the faculty members, Dr. Pasi, Dr. Gulati, Dr. Ishwar Singh, Dr. Taneja, especially my colleague Dr. Vikram, Dr. Vikas Malhotra, Dr. Shruti and Dr. Anjan for their constant support in organizing this program. And my special thanks to the moderators of the this conference, Dr. Vasun, Dr. Deepika, Dr. Hitender and Dr. Riyaz. So I'm sure this is going to help our postgraduate students which are actually who are lining from all over the country. And right now we have more than 450 delegates online. And lastly, I would like to thank the Sun Pharma for giving us the online support. Because of this only we are able to hold this in an online way, right? And special thanks to Mr. Naveen Kaul, Mr. Deepak and Mr. Arvind Singh from Sun Pharma for providing us the online platform. Thank you very much. Over to Dr. Vasan.
Thank you, sir. Now we move on to our next lecture, candidacy and surgical aspects of cochlear implant. May I now invite Dr. Rakesh Kumar, Professor at Department of ENT at AIIMS, to start his lecture, please.
Good morning, Dr. Rakesh. Sir, please unmute yourself. Sir, please unmute yourself. Sir, in the left-hand corner, there will be a mic button. Yes.
Yeah,
yes, sir.
I have done that, but you tell me, can you see my screen?
I can hear you now. Yeah, okay. I can hear you, but we cannot see the screen. Please.
Okay. Now can you see?
Yes, sir, we can see your screen. Please make it full screen, sir.
Yeah, that I will do. Okay.
Yes, sir.
So
thank you.
Is it okay now?
Yes, sir. Absolutely correct, sir. Thank you, sir.
I'm not able to see myself. I don't know.
Sir, you are visible to us. I can see your video and we can see your presentation also.
Okay. Okay. So we can start.
Yes, sir. You can start.
So over next 20-25 minutes, I will be talking on cochlear implantation, mainly the case selection, how to investigate, and the techniques of doing cochlear implantation. So candidacy criteria, it is mainly for the prelingual children. So we take up kids who are up to 5 years and another group which is 5 year plus. So any child who has profound bilateral sensory hearing loss is a candidate for cochlear implant, but age is the main factor. So ideally it should be below 1 year, but as we all know that the cases which come to us is quite late. So Ministry of Health as well as ADIP have kept the age up to 5 year and 5 year plus. So they are the two groups. And another important factor is there should be a lack of hearing aid benefit. In younger children, when you give them hearing aid and still they show the lack of progress of simple auditory skill, then that is the case for the cochlear implant. And this has to be continued over next 3 to 6 month period. But at the same time, I will tell, don't delay other things because child is using hearing aid and after 3 months you start doing other tests. So all things has to go simultaneously so that we should decrease the overall time taken from the enrollment of the child and the surgery. Then there has to be radiological evidence of cochlear ossification. If that is the case, then a shorter trial with amplification can be considered. And to obtain the optimal benefit out of cochlear implant, the parents have to be well motivated, because it is one of the parent at least has to put full time with the child to ensure that the child is getting properly trained. So without training, the cochlear implant is of no use. Parents should understand the importance of regular speech processor programming as well as assessment sessions and the regular training. Because if you depend too much on the auditory verbal therapist, they will give how much time? Maybe half an hour, maybe 40 minutes, maybe 20 minutes. So it is the parents who stay with the child. So they should continue using this cochlear implant the training once the child get up in the morning till the child sleeps. So whole day they have to be involved with the child. So what is the best stage of implantation? For the language acquisition is from say 6 months to 5 years. So optimal implant age is up to 2 years. Suitable is up to 5 years, and beyond 5 years it become variable. When you work up the case, you have to know whether the patient which you are dealing is prelingual deaf or postlingual. Is he having isolated hearing deficit or there is a global development delay? Comorbid condition like seizures, behavioral problems, problem with the vision or the cerebral palsy, because these all things affect the ultimate outcome in cochlear implant cases. So this has to be noted. Any past history of otitis media or meningitis, IV medication or toxins, birth weight, whether the child was low birth weight, history of asphyxia, hyperbilirubinemia, sepsis, and then you have to take the family history, whether the other siblings are also affected, whether the parents have consanguineous marriage, and the vaccination history. Clinical evaluation remain directed towards the ear, nose, throat examination, mainly ear. The audiological evaluation and the general physical examination is done. It is important to have a team. As an ENT surgeon, you can't decide and do the implant with the optimal outcome. So what the other team member should be the pediatrician, mainly for genetic testing and any other problem. The pediatric neurologist, again for IQ, SQ and DQ assessment. Cardiologist to rule out any cardiac congenital problem, and ophthalmologist, again to see the vision. We emphasize on history and evaluation. So how it helps? It helps in getting some prognostication of the patient and also to identify the etiology, so that if they want to plan the second child, we can counsel the parents better. Assessments of the hearing should be the universal screening for all newborns, so that you can pick the kids who have congenital hearing loss early and intervene early. The high risk screening is not good because you tend to miss out almost 50% of hearing loss kids. Also, you have to assess the hearing clinically, as well as you have to ask the parents whether the child hears or not. At time, especially with the tests which are like ABR, sometimes you get the good wave where the child is not hearing and vice versa. So it is important to know what the parents feel. Free field audiometry, impedance, autoacoustic emission audiometry, and the ABR is other tests which should be done in all these cases. So when you do audiological investigation, how you proceed? You've done the hearing evaluation. If there is a severe to profound hearing loss, intervention required is high output, bill for 3 to 6 months, and check with the aided audiogram whether there is an improvement as well as subjective improvement in the child's hearing. You look for the outcome. If there is an improvement, continue the hearing aid. If there is no improvement, consider the cochlear implant surgery. And in the meantime, till the time the child is waiting for the implant, continue hearing aid use. Then counseling with parents are important. They should have the realistic expectation after the child undergoes the cochlear implant surgery. Parents usually feel that child will be normal hearing and speaking child, going to normal school and will have good school performance. So it is the surgeon's responsibility to explain the benefit and the risk of surgery, the variability of the outcome, and the most emphasis has to be the requirement for the intensive post-operative rehabilitation. Unless they are willing to slog or put time with their kids over the next 3 years, the outcome will not be optimum. And also what is required is prolonged input from the implant center team as well as local professionals. So it is not one-off surgery that you do surgery, patient goes home and all your responsibility is finished. You have to be with your patient lifelong. CT scan or MRI, this is mainly to know the inner ear anatomy and if there are any malformation. So this is what an ideal or the proposed system under which we report the CT scan and MRI. If you see the external ear, right and left, middle ear, which includes soft tissue ossicles, the facial nerve canal, any mastoiditis, semicircular canal, lateral, superior, posterior, endolymphatic duct and sac, vestibule, cochlea, how many turns, whether sclerosis, how is the modulus, cochlear aqueduct patency, round window patency, oval window patency, interauditory canal, carotid canal location, jugular bulb location, any other finding. Okay, so this has to be recorded properly, and then it has to be the final impressions to you. So if you go stepwise, you are unlikely to miss anything, and it will give you a comprehensive report. So when you do the imaging, both HRCT and MRI is required. HRCT is mainly for bony labyrinth and osseous structures, whereas MRI is for nerve, CP angle, and the brain. Nowadays, seeing the film or the report is not done. What is required is 3-dimensional multiplanar interpretation onto the radiologist screen. So there you have to see, and then you make the 3-dimensional picture into your brain, because all these things are difficult to report on the films. So what is the aim of imaging? It is different when you do pre-operative and when you do the post-operative. Pre-operative, you want to rule out any contraindication, want to detect the position of your implant. And secondly is to detect situation that might make surgery risky or difficult, so that you have the appropriate steps or the plan B with you when you go for the surgery. And post-op, you want to detect the post-op complication, if any. So this is mainly for anatomy. So these are the cuts. If you see the basal turn, middle turn, this is modulus, center, the apical turn, and middle turn, basal turn, and the osseous spiral lamina, which is separating the two, and this is basal turn. Same with MRI. You see apical turn, middle turn, then osseous spiral lamina, this black, and this is the basal turn. And these are the vestibuli, scala vestibuli, scala tympani, the modulus, and the osseous spiral lamina. So you can nicely see on the MRI. Again, the anatomy, the normal, the nerves, the cochlea, vestibule. Okay, and if a particular cut, you can see the 4 nerves, the superior vestibular, inferior vestibular, cochlear, and the facial nerve. This is complete labyrinthine aplasia. You don't see anything. And this is cochlea is absent, only the vestibule is there. This is IP1 on left side, and on right side there is a total aplasia of the cochlea. And this is type 2 Mondini. Labyrinthitis ossificans, which is sequelae of meningitis. This is a CT scan, so you hardly see anything. Nothing here. And your MRI will show nicely that the cochlear turns are not seen. Interauditory canal stenosis. This is narrowing and this is almost complete absence. And MRI also showing the same thing. High riding jugular bulb. See that? Sorry. Axial cut, coronal cuts. Opposite side is normal. And this is aberrant carotid canal, coronal section, and the axial section and the coronal section. This is post-op. When you get the scan, you can see whether your electrode is in position or not. So to summarize, what are the criteria which are for a prelingual child to undergo cochlear implant? This is Ministry of Health guideline. So prelingual deaf children, severe to profound bilateral sensory hearing loss, age group between 1 to 16 years. However, children using hearing aid and getting auditory training from the age of 1 year or less may be considered higher age also, but it has to be decided case to case basis. There should not be any appreciable benefit with the hearing aid after 3 to 6 month use. There should not be any mental retardation, no active middle ear problem or perforation, no cochlear aplasia, agenesis of cochlear nerve, no retrocochlear lesion or central deafness, and the good family support. Postlingual, they want bilateral profound SN hearing loss, no appreciable benefit with hearing aid in both the ear, no active middle ear diseases or perforation of the ear, and deafness should be due to cochlear lesion. Post-meningitis labyrinthitis ossificans is a contraindication. However, if there is a early stage, like patient has presented to you early, then you can do the cochlear implant. These are the ADIP scheme. Again, it says the Indian citizen, the age of the child up to 5 years on the 31st December of that year, and up to 12 years if it is the postlingual deafness. Degree of hearing loss has to be severe to profound. Child should not have any associated developmental or the mental retardation or cognitive deficit. Hearing disability certificate should have used its hearing aid for about 3 months. And the income, family income, it is given 100% subsidy if income is 15,000 per month or less, and 50% if it is 15,000 to 20,000 per month, and it is only given one side cochlear implant. So surgery, when you do you should not try to clean ear one day before surgery in OPD. So it has to be cleaned on the table. Otherwise, sometimes there is a trauma or there is a fungus, so that is contraindication, temporary contraindication. So you do examination under microscope and clean the ear and have the normal tympanic membrane. Try not to lacerate or injure the lining of the external canal or the tympanic membrane. Clean and drape, do gross work, and again you clean it and change gloves and re-drape before opening implant, again you have to change the gloves. So the basically sterility and the cleanliness of the surgical field is most important, because you are putting a foreign body, which is implant. So any infection is bound to cause your surgical failure. So you have to be very, very careful. There are two techniques of doing cochlear implant. One is transmastoid posterior tympanotomy approach, which is commonly done, and second is Verrier technique. So this is the position. You keep the head straight, and then you mark where the implant should be and where the space for the speech processor. The small incision, which is 4 to 5 centimeter. Then lift up the palvas flap. This is basically transmastoid posterior tympanotomy approach. After doing cortical mastoidectomy, you have to make the bed for the implant, and then you make the channel, and then you have to do posterior tympanotomy. So ideal should be that you should be identifying the chorda tympani, the facial nerve, and then you open into the middle ear. Okay, this is the temporal bone. You can see the chorda tympani, the facial nerve, the round window, the stapedius tendon, promontory. So it should be, you can see if you identify the landmark, and then you can nicely see inside. So it is not a crunch access to the middle ear. This is after you do gross work. Again you have to clean and redrape, and final the cochleostomy you have to do once everything is clean. This small video, if it is, I don't know whether that will be getting relayed to you or not, because the internet connection is stable. Lifting up the flap, the palvas flap. We use the suture instead of retractor, supposedly less traumatic, doing cortical mastoidectomy. Lot of this thing, irrigation. Then you drill the bed for the implant, this metal implant, so, and the channel for that, and then you do posterior tympanotomy. Take 1.5 or 2 millimeter burr and just go parallel to the thin posterior canal. Okay, under direct vision you should open it, and this is about 2 or 3 year old video. So this is cochleostomy, not the round window one. So cochleostomy is done. Perilymph you can see, and then you put the implant. As you know, metal is not having separate earth electrode. That is only beneath the implant it is there. We put it, and there is a 2 ring which seals the cochleostomy. No need of sealing that. And this is the posterior tympanotomy sealed, and you can suture the flap and the skin. This very technique I have taken from web. So this is a suprameatal approach. This is the endomeatal incision. You lift up the posterior canal flap and enter the middle ear. This is the flap you create, suprameatal, and a small this thing, and then you can you see that there is a tunnel which has been drilled here, so it is being put there. This come inside, and it is being pushed into the cochlea, scala tympani, and the small electrode which is there, it was coiled there, and you reflect the flap and complete the surgery. So if we compare to, I am doing the transmastoid posterior tympanotomy. So world over, it is a gold standard. Started from 60s, so we have long experience of doing this surgery, and there are hardly any complications. Whereas Verrier is a relatively new technique, and not very many surgeons are doing it. Access is through mastoid, and then you do the posterior tympanotomy. Here, access is suprameatal, and you make a tunnel into the posterior canal wall, which enter, suppose it is right here, enter about 10 or 11 o'clock, and then you do the cochleostomy, and then you put the electrode. Facial nerve exposure in mastoid approach is under direct vision, and we do left and right mastoid surgery. So every ENT surgeon is conversant with cortical mastoidectomy and facial nerve course. So it is direct vision. So chances of injury and complication of the facial nerve is less. Whereas Verrier technique, it is a blind technique. So you just take a perforator with guard and then you drill it. So facial nerve is not, you are not visualizing it. Electrode, you put through the posterior tympanotomy. So you can see and directly manipulate it. If required, you can change the angle at which you are pushing the electrode into the scalar tympani, which is not there, that luxury is not there when you go through the small tunnel. In Verrier technique, there is a long bony canal. Through tunnel it is passing through. Chances of long-term strangulation of electrode is there, theoretical possibility, and sometimes it get extruded into the external canal. So nowadays people start putting a temporal fascia there to reinforce the canal so that the electrode should not extrude into the external canal. Special instruments, no special instrument for the transmastoid, whereas for Verrier technique you need a perforator with guard. Anatomical abnormalities, if they are for the middle ear, the external ear, then the transmastoid is a better technique because you are seeing and doing as compared to Verrier technique where it might be difficult. So once you do cochlear implant, so what the post-op management is, beside the antibiotic painkiller, the visitors has to be minimum. Again, post-op infection has to be minimized. There should be barrier nursing. You should not touch your patient after touching the infected case. You should wash your hand. Then the dressing has to be with the sterile set and proper scrubbing. You should be very careful with your sterility. After discharge, you have to have the low threshold for readmission and intervention. If there is a problem, admit patient and you manage that. After the implant is done, after 2 to 3 weeks, what should be done? The auditory verbal training is the answer, which is done after you switch on, and the emphasis has to be listening on the patient. The child should focus on listening. The listening skills is, first thing what the child has to do is they are taught to detect the auditory signal. Okay, some signal is coming. They should be turning their head. They should be try to locate that signal. So that is first thing. Secondly is to discriminate the auditory signal. So what this signal is, whether this is the animal voice or it is a toy voice, that has to be discriminated. And then the auditory identification and association. Suppose the father is calling, then he should be able to identify and then associate that sound with the, okay, this is father, this is mother, this is dada, baba. So this is the third part. And then the fourth is auditory memory. So whatever he learned, he keep it in the brain, the memory, so that next time when the similar sound comes, so he can correlate that sound with that memory he has. Then the auditory sequencing, then processing, and finally auditory understanding. So this all lead to the speech. So outcome in cochlear implant is measured with the CAP score or the SAR score. CAP is 0 to 7, SAR is 1 to 5. So this is what the CAP score is. CAP score is category of auditory perception scale. So 0 is no awareness of environmental sound. 7 is the use of telephone with known listener. Okay, so that is 7. Whereas SIR SAR score is speech intelligibility rating, which start from 1 and reaches up to 5. 5 is when the connected speech is intelligible to all listeners. Child is understood easily by everyone. Whereas 1 is connected speech is not intelligible. Pre-recognized word is spoken in language. So that is 1. So normal, if you see 7 to 12 month CAP score should be about 1 or 2. SAR should be 1. 1 to 2 year CAP score is 4, SAR is 2 to 3, and 4 to 5 year CAP score should be 6 to 7, SAR should be 5. So this is what the normal development is. So when you do implant, so that become the, say, first month or the day 1, and then your CAP score, SAR score should be this one. So that says whether your child is progressing normally, or there is some interventions needed. So there was a audit which we have done about 219 patients with cochlear implant has been done over 5 years with minimum follow-up 6 months, and the mean follow-up was 3.5 years. So this was the outcome. So postlingual there was 24, 23 were good performer, 1 was poor performer. Prelingual was 195, good performer was 130, and poor performer was 65. So we thought, let's just see what are the factors which are seen in poor performer and what are the factors which were better in good performer. So if you see the age, good performer age, the age at which implant was done was 4.12 years, whereas poor performer, the implant was done almost 1.5 years later. So age is an important factor. And see, this is the CAP score. In good performance, see, it started from 3 and reaches up to 6, whereas poor performance, in the beginning there was none, and even at 1 to 2 year it was only 0.6 and it reaches only 4. The same way was the SIR score. If you see the good performer, it is 1.8 and reaches 4.8, whereas in poor performance there was none at up to 1 year, and after that also it was not very good. Speech discrimination, good performer, again started with almost 40 and reaches up to 72, whereas at 1 year there was no speech discrimination, even up to 2 years no speech discrimination. At 2 to 5 years there was 24, and more than 5 years was 37. So who are the kids who are likely to perform poorly? So we see the pre-implant hearing aid use, more than 3 months, no effect. Residual hearing, no effect. Adverse prenatal factor, no effect. Neonatal jaundice, no effect. And meningitis, none. Hyperactive child, none. Syndromic, none. So they were not important factor. So in radiology, when there is a dysplastic cochlea, the thing is we feel that dysplastic cochlea should do poorly, but again it was not an important factor. Intraop, you see, if there is a incomplete insertion, again it is not a factor which is causing the ultimate outcome, affect the outcome, because there is incomplete insertion, good performance 6 and poor performance none. Abnormal NRT is also not important. So what are the important factors? What we find, the important factor is irregular speech therapy, which was seen in poor performer in 40 patients and good performer only in 70, and they see the p-value, how significant it is. And the family conflict, again it was seen more with the poor performer. So that indirectly affect how you are involved with your child in post-op rehabilitation. Complications are rare. It can range from bleeding, infection, device malfunction, facial nerve weakness, ringing and dizziness, poor hearing outcome, and long-term maybe meningitis. So there was a study which was recently published in 2020, which says the complication rate was about 10.1%. It was a series of 1,452 patients, so 148 complications were seen. And major complication they have divided, which require the admission and surgery. And minor complication is where the surgery or the admission was not required. So major complication was 4.75% and the minor was 5.4%. And 40 cases of major complication required reimplantation. That means reimplantation was required in whatever major complication, 2.75%. And device failure was the most common cause of reimplantation, 29 patients. And hematoma was the most common complication, 21 patients. So we assessed our patients, and the complication what we found was 18 out of 534, which the rate was 3.4%. Device failure was in 7, which constitute 39%, almost same what was the previous study was. Electrode exclusion in 5, again 28. The one of the case was where the patient was out station after surgery. He went, his is straight, and then there the ENT surgeon thought there is a wax and he has pulled the electrode out. So you have to instruct your patient. So whatever problem is there, don't clean your ear with instruments, and if problem, come back to the operating surgeon, or if local surgeon, if you know someone who is doing cochlear implant, probably better to go there. Trauma in 3 cases, which constitute 11%, electrode migration in 2, that is 11%, and improper electrode placement in 1 patient, which was taken up in the same sitting and reimplanted the same electrode, and he was doing fine. So cochlear implant is a teamwork. So thanks goes to our ex-HOD, Professor S.C. Sharma, present HOD, Professor Alok, Dr. Kapil, residents, our rehabilitated team, constitute Ms. Sivani and her team, and the patients. Thank you. If there are any question, I will be happy to answer.
Thank you, sir, for an excellent lecture. Any comments from the faculty members, please?
Hello, Rakesh.
Hello, sir.
Hello, Rakesh. Ishwar here.
Mr. Ishwar, tell me. I can hear you.
I have a small query. How do you manage this ossification patient? Post meningitis, there is a ossification. Up to what level you keep on drilling to insert the electrode? And if the same size of the electrode is used or any different, and if smaller size electrode is used, will it affect the outcome of speech?
Okay. See, the maximum which I have drilled is about 7 to 10 millimeter. Okay. So if you select your cases beforehand, hello. If you select your cases beforehand, if you get if there is a history of meningitis, it is always advisable that you get the MRI, repeat MRI just before surgery, because that will tell you how much ossification is there. Usually it is, most of the cases, it will be like 2 or 3 millimeter what you can drill and reach there. In one of the case, almost half of the basal turn I have to drill. Okay, so that was only one case. Otherwise, most of the cases 2 to 3 mm is enough. Regarding your special electrode, because we have rate contract with the nucleus, so nucleus doesn't have a special electrode. So electrode, the length is 24 millimeter. So they say that you can use it as a compressed and otherwise. So if you are able to put like even 6 or 7 electrode, that is enough. Okay. Otherwise, hello.
Hello.
Yes.
So 7 to 8 electrode insertion is good enough for the speech development.
Yeah. So if you are able to put that is enough. I have seen Professor Dekar doing it, and he could not find the scala tympani, so he has drilled about 6-7 millimeter hole there and put the electrode, and he was doing okay. Regarding a special electrode, there are electrodes comes for there are 2 electrode, one for the basal turn, other for middle turn. One can use that, and this metal has different electrodes. The compressed one, the soft one, you can use them. So there are different electrodes comes, but I don't have experience with those different electrodes. So most of the time, if you select your case properly, so 2 to 3 millimeter drilling is enough to reach the scala, and then you can put your electrode.
So in case of meningitis, one should not wait for a hearing aid trial. I think if there is a hearing loss following meningitis, because ossification can occur, so one should go for a cochlear implant rather than wait for hearing trial. Am I right?
Yeah. Yeah, right. You're right. And even if you're using implant, this hearing aid, don't wait for 3 months. By the time the investigation is finished, you take up case early, because that allowance has been given, even the Ministry of Health guideline and the this thing EDIP guideline. So don't wait for long. If you wait, say 1 year, 2 year, it will be ossified. Then you can't put it.
Hello, Dr. Rakesh.
In your analysis, the factor which you came across was age. What was the upper age for your best performer?
This is like this is a group of patients. So as a general fact, earlier you operate, better should be outcome.
Hello.
Okay,
Yeah, that is
but
okay.
as you
Age
know,
is a factor.
Rakesh. Hello.
yeah. So what our analysis says, the patient who are implanted at 4.1 year age were doing better than patient who are operated at the age of 5.4 year. So that much difference is there.
Hello, Rakesh.
Thank you.
Hello, Rakesh.
Yeah.
Rathore this side. Hello.
Hello, sir. How are you?
Hello. Fine, Rakesh. Actually, my just one comment was there. While you just now told that in meningitis need not do, but what the literature says, because it is a neurodense area, so doesn't mean that internal auditory meatus will behave similarly, just like meninges.
Yeah.
So even in such cases, you should follow the protocol. Means give some hearing aid trial. Don't just jump to the, because it will not make any much difference if you are going for hearing aid. And if one even a smallest nerve is available, it is going to give you the benefit. So then you need not do the cochlear implant. So I think the protocol should be maintained. No, need not jump for meningitis patient. That means directly operate. That's how the ministry has actually classified it. Thank you.
Yeah, usually when you work up your cases, it take about a month or two. So by the time you can straight away tell them to use a hearing aid. So, but there is no point just to use a hearing aid for 3 to 6 months. No point in delaying that. And as you rightly said, the hearing aid, if you are giving and if it is getting benefit, then probably he's not the candidate for the cochlear implant.
Dr. Rakesh, it was an excellent talk, Dr. Rakesh.
Yes. Yeah, Dr. Ravi.
I have just one query. Do you have any experience of inserting a dummy electrode in the case of this labyrinthine ossificans? I mean, in case of meningitis, to prevent labyrinthine ossificans and then do an implant later on? Because this I have heard and I have seen the literature also that people put a dummy electrode to prevent ossificans.
Yeah, this is a possibility which we read in literature. If you are a patient the implant has to be delayed for some time, then you can put a dummy implant. But usually, when you do for the post meningitic cases, you always ask for the dummy implant when you open up, whether you have opened up into the scala, the tympani or not. So that you can check by putting the dummy implant and how much it is going. So if it goes and accommodate more electrode is better, but at least 6 or 7. So then you should do the implant. Don't try to force it in. So dummy electrode, putting it and waiting for his condition to improve is a option. Yes, Doctor Ravi, you are right.
Okay, thank you, sir.
Okay, thank you very much.
I now invite Dr. Ravi Meher, Professor at Department of ENT, MAMC, for his talk on endoscopic ear anatomy and surgery.
Dr. Ravi, unmute yourself.
Okay, so my slides are visible?
Yes, sir.
Okay, so I will be talking about endoscopic anatomy of middle ear. And this has gained importance because of the fact that we are doing lots more cases of ear surgery by endoscope. Earlier, people were using microscope, but since last 10 to 15 years, there has been increased use of endoscope in performing various middle ear surgeries. So we should know what is the endoscopic anatomy. How does the middle ear look when you visualize it through the endoscope, right? So the middle ear can be divided into various compartments. and the part of the middle ear which is basically adjacent to the tympanic membrane is the mesotympanum, right? So if you see the boundaries of the mesotympanum is basically the fibrous annulus. Anything which is posterior to the bony annulus is the retrotympanum. Anything which is below the bony annulus is the hypotympanum. So the part of the middle ear cleft which is anterior to the annulus is the protympanum, and above the annulus is the epitympanum, right? So you must be aware, aware of all these terms: the protympanum, hypotympanum, retrotympanum, and epitympanum, right? And we'll go to the anatomy of each compartment one by one. So the retrotympanum, I think this is the most important part of the middle ear cleft, because most of the important structures are actually in the retrotympanum. The old window, the round window niche, as well as the various recesses like facial recess and the sinus tympani, these are part of retrotympanum, and this is the most commonly involved area with the disease also. So the cholestoma actually can involve this area, the sinus tympani, the facial recess, the round window, then it can go medial to the ossicles, so, right? So this is the most important part of the middle ear as far as the disease is concerned. So the retrotympanum can be divided into two parts by a bony ledge which is called a subiculum. So it can be divided into superior retrotympanum and the inferior retrotympanum. We'll come to the subiculum later. Just to tell you about the superior retrotympanum. The superior retrotympanum actually extends from the facial nerve superiorly till the subiculum, right? And from the subiculum till the funiculus is the inferior retrotympanum. So we have two portions of retrotympanum, the superior retrotympanum and the inferior retrotympanum, divided by a bony ledge which is called a subiculum. So in the superior retrotympanum, we have a very important landmark, that is the pyramidal process. So this is the pyramidal process. You can see here, this is the pyramidal eminence which give rise to the this tapetal tendon, right? And this pyramidal process is the pivot around which you have four important recesses. Two recesses which are lateral and two recesses which are medial. So we can also see here the facial nerve here, right? So we can see that the recess which is lateral to the facial nerve is the facial recess and the lateral sinus. So this is the lateral sinus and this is the facial recess. There are certain sinuses which are medial to the facial nerve or medial to the pyramidal process. The anterior one is called as posterior sinus. So this is the posterior sinus and this is the sinus tympani, right? So these are the four important recesses and the sinuses which are actually divided by a key landmark which is the pyramidal process. Now we come to the sinus tympani, and this is the most important sinus of the middle ear in the retrotympanum. This is because the disease can involve this sinus and you can have difficulty in removing the cholestoma from this area. What are the boundaries? Boundaries are superiorly it is bounded by the ponticulus, inferiorly the subiculum, laterally is the facial nerve, right? So it is one of the medial sinuses. So the laterally it is bounded by the facial nerve, and medially is the basically the cochlea and the basically the vestibule, right? So the middle part of this the sinus tympani is formed by the posterior septal canal and the vestibule. Right? The importance, the surgical importance, that this is a hidden area. It can be difficult to visualize through the microscope. So when you are doing surgery with the microscope, this area is actually a niche which is hidden by the posterior canal wall, and you are not able to see the sinus tympani. But with the endoscope, especially with the 45-degree endoscope, you can visualize this area very clearly. And the visualization also depend on the depth of the sinus tympani. Greater is the depth of the recess, more difficult it will be to visualize. And this is the most common site for residual cholestoma. You can leave cholestoma while doing the surgery. The classification of sinus tympani. So the sinus tympani can be classified according to the shape. So the shape of this is the classical shape which is bounded by superiorly by the ponticulus and inferiorly by the subiculum. So this is a classical sinus tympani shape, and anterior and superior to this is the posterior sinus. If this ponticulus is absent, what will happen? The sinus tympani will be communicating with the posterior sinus. So this whole area will be one large sinus, and this is confluent sinus. This is called as confluent sinus tympani. You can also have partitioned sinus tympani. This sinus tympani itself can be sometimes partitioned by a ledge of bone into superior sinus and the inferior sinus, right? So this is partitioned sinus. Then you can also have restricted sinus. Sometimes what happens, there is a high jugular bulb, and this high jugular bulb actually restricts or it decreases the size of the sinus tympani, and this is called a restricted sinus tympani. It can also be classified on the basis of depth of the sinus tympani. And again, as I have already told you, deeper the sinus, more difficult will be the disease removal, right? So in type A, what happens? The sinus tympani is not very deep, and it is a small sinus, and the depth actually reaches just the anterior portion of the facial nerve. Right? In the deep sinus tympani, the depth of the sinus tympani actually goes below the facial nerve. And in case of deep sinus with posterior extension, it goes way beyond the facial nerve. So if you want to remove a disease from a deep sinus with posterior extension, sometimes even with endoscope, you might be able to visualize the disease, but the instruments might not reach this area, and you might have to do approach which is called as posterior retrofacial approach. So you go do a mastectomy and go below the facial nerve to remove the disease, right? Ponticulus, so this is another ridge of bone which actually arises from the pyramidal process and goes to the promontory. So how to remember? P for ponticulus, P for pyramidal process, and P for promontory. So all three P's, it extends from the pyramidal process to promontory. And what does it do? It actually separates the sinus tympani from the posterior tympanic sinus. Again, the ponticulus can be of different types, and we have already seen absence of ponticulus can lead to confluent sinus tympani, and there can be sometimes communicating ponticulus in which you have a bridge sort of thing where the disease can actually go from sinus tympani into the posterior tympanic sinus. Right? So there are different variants of the ponticulus which can be present. Come to the subiculum. This subiculum is another ledge of bone which actually extends from the styloid complex. So what is styloid complex? Styloid complex is that part of the middle cleft which is actually originating from the second branchial arch. Right? So it actually forms the facial canal also and the posterior part of the middle ear, and it also gives rise to a ledge of bone which communicates from the styloid complex to the promontory. And again, it divides the retrotympanum into superior and inferior retrotympanum. Right? So the inferior retrotympanum actually is also called as sinus subtympanicus because it is below the sinus tympani. Right? So the another name for inferior retrotympanum is sinus subtympanicus. Again, there can be variations of subiculum. Here, for example, the subiculum is absent. So the sinus tympani is actually communicating with the sinus subtympanicus. There is another important space which is called a subpyramidal space, and as the name suggests, this is a small potential space which is going below the pyramidal eminence, right? And this can communicate with the sinus tympani inferiorly, or it can also communicate with the posterior sinus superiorly. So if you see the diagrammatic picture, here is the sinus tympani, and you can see a space which is going below the pyramidal eminence, and it is communicating with the posterior tympanic sinus. So this is a subpyramidal space communicating with the posterior tympanic sinus. In this picture, you can see it is communicating with the sinus tympani. So this subpyramidal space can also get involved with the disease, and if this is involved, then it is again more difficult to remove the cholestoma matrix from this area. We come to the inferior retrotympanum, also called as sinus subtympanicus. Here we have two important ledge of bones. One is the funiculus. This funiculus is actually a ledge of bone which is arising from the jugular bulb area and is communicating to the promontory. And this funiculus divides the sinus subtympanicus from the hypotympanum. Right? So this is a bone. This is a ledge of bone which actually separates the retrotympanum from the hypotympanum. And another bone. This is another ridge of bone which is actually forming the floor of the round window niche. So this is a round window, and this whole area is sinus subtympanicus. This bone actually forms the floor of the round window niche. This is the posterior pillar of the round window. This is the anterior pillar of the round window. This is the subiculum, and this is the roof of the round window, which is also called as tegment. So the fustes has importance in cochlear implant because it can actually lead you to the round window membrane. So this is another picture of sinus subtympanicus. We have already discussed the boundaries, which can be seen here very clearly. That is the subiculum, and inferiorly is the funiculus. Anteriorly and medially is the round window niche area, and posteriorly is the styloid complex. So this area is the area which is called as inferior retrotympanum, or also called as sinus subtympanicus. Again, the funiculus can be sometimes absent. If the funiculus is absent, then you have communication of the hypotympanic cell with the inferior retrotympanum or the sinus subtympanicus, and it can be sometimes bridge-like. So if it is bridge-like, then again it will communicate with the hypotympanic. We come to the next part, that is the hypotympanum. As it suggests, the name suggests, it is below the bony annulus, and the most important landmark for hypotympanum is the jugular bulb. So the jugular bulb can be sometimes covered with bony, sometimes can be dehiscent. Usually it is covered with the bony shell, but it can be dehiscent, and sometimes it can be high jugular bulb also. And in that case, the sinus tympani is restricted, and there can be sometimes bleeding if you are not aware that there is a high jugular bulb, and you can inadvertently damage the jugular bulb, leading to massive venous bleeding from the middle layer. So the depth of the jugular bulb can vary from 1 millimeter to 5 millimeter. The protympanum. So the protympanum is an area which is in the anterior part of the middle ear cleft. There are two important structures. One is the eustachian tube, and another is the supratubal recess. So this is the area which is anterior to the promontory, and there lies the eustachian tube area. Right? So the protympanum can be divided into two important parts. One is the eustachian tube opening, which is inferiorly, and superiorly you have the supratubal recess. This supratubal recess can be sometimes absent, and the depth of the supratubal recess depends on the attachment of the tensor fold. If the tensor fold, this is a tensor fold, and this is a tensor tympani ligament, and you have here the eustachian tube. So if the tensor fold is attached vertically, more vertically, then you can have a recess which develops just above the eustachian tube, and this is called a supratubal recess, right? And if it is attached more horizontally and straight, then you have absence of supratubal recess. So this tensor fold is a membranous fold which actually separates the anterior epitympanic sinus from the supratubal recess. The tympanic portion of the eustachian tube. The tympanic portion of the eustachian tube has a size of around 11 to 12 millimeter in diameter, and there can be various shape of the eustachian tube opening. It can be rectangular, triangular, or irregular, and just medial and superior to the eustachian tube is the carotid artery. So the internal carotid artery is medial to the eustachian tube opening, and sometimes the internal carotid artery can be dehiscent. So in that case, you have to be careful while drilling this area. Usually the eustachian tube area is not involved. The protympanum is last area to get involved with the cholestoma, and usually it is a clean area, and you don't need to actually go in this area during surgery. We come to the epitympanum. The epitympanum has two parts. It can be divided into two parts: the anterior epitympanic space and the posterior epitympanic space. So this division is based on the bony ledge of bone which arises from the tegment, which is called as cob. The posterior epitympanic space is a large space and it houses the head of the malleus and the body of the incus. And we have a smaller anterior epitympanic space. So the cob, it demarcates the anterior epitympanic space from the posterior epitympanic space. This is the ledge of bone which arises from the tegment. The length of this bone can vary from person to person, and if it is very large, then you can have a very deep anti-epitympanic sinus, and sometimes the disease can actually reach this area. Then you need to drill the cob to clear this area in the surgery. This was first described by William Howe. We come to the posterior epitympanic space. The posterior epitympanic space, if you see, is divided into two halves: the superior space and the inferior space. And this
Dr. Ravi has a, I think, internet issue. He's trying to log in. I think we'll take another 2 minutes.
Hello. Hello, Dr. Vikram.
Yes, sir. So I think
what is the problem? Are you not? You are also in the department, no?
No, I am not in the department, sir. He is actually.
So department has a problem of connectivity.
Yes, sir. I think he's trying to log in through his laptop now. He was through the PC initially. It is not working. So he, I think, will in another 1 or 2 minutes.
We can chat meanwhile. Query to from the participants in particular. You can ask them to ask.
So the participants on this forum, I think we are only the faculty members who can be there. On
okay. Achha. This only faculty members.
Yeah.
So that participant forum would also not be working at the moment?
No, it's working. It's only Dr. Ravi's internet which is not working. So, and we can't see their responses. Probably the guys from Sun Pharma can see the responses from them.
So can we convey to Sun Pharma people?
Okay. Yes, sir. I think I will.
Sir, I will just put the questions on the chat mode.
Yes.
Okay.
Yes.
We should keep busy.
Yes. Just a second, sir.
Hello. Hello.
Oh yes, Ravi is back.
Sorry, sir. Actually, there was some power failure or something. We lost internet connection here.
Okay. So you have restarted?
Yes, sir. I'm restarting. So I think I had reached till the epitympanic space.
Posterior epitympano. Posterior epitympano, you were there.
Okay. Sorry. So, am I audible? Yes. So, tensor fold, this is a very important fold which we have already talked about. This tensor fold actually originates from the process cochleariformis and the tensor tympani tendon. And it also has attachment to the malleus, and it is anteriorly attaches to the zygomatic bone. And it forms the part of the epitympanic diaphragm. Also, it actually separates the anterior epitympanic sinus superiorly from the supratuberous recess or the protympanum inferiorly. The tensor tympani fold can be sometimes incomplete. If it is incomplete, the middle is actually able to ventilate. So the epitympanum is able to ventilate through the tensor tympani fold. But if it is complete, then there is no way by which the tympanum can actually communicate with the anterior epitympanum, except through the spaces, that is the anterior isthmus and the posterior isthmus. So if you see, this is the diaphragm. This is epitympanic diaphragm, and the parts of the epitympanic diaphragm are the ligamentous fold which attaches the malleus to the anterior ligamental fold, the lateral and the posterior ligamental folds of the malleus. It is also formed by the tensor fold, which we have already discussed. It is also formed by another very important fold, which is the lateral inclumalleal fold, right? And the posterior included ligament. So these things actually separates the separates the epitympanum from the mesotympanum. So this is the epitympanic diaphragm which separates the two, and you have only two spaces which actually ventilate the epitympanum from the mesotympanum, is the anterior isthmus and the posterior isthmus. So this is the epitympanic diaphragm, and when you are actually operating, you might have to, if there is an obstruction in this area, the anti-isthmus and the post-isthmus, then you have to clear this area. And also, sometimes when you want to ventilate the anterior epitympanic sinus, you can actually resect the part of the tensor fold so that the protympanum can communicate with the anterior epitympanum. Right? The Prusik space, this can be a very important short note or exam question. So the Prusik space is the most common site where cholestoma is formed, and if you see the boundaries, the superior boundary is the lateral malleolar fold. This is a green colored lateral malleolar fold. Inferiorly is the lateral process of malleus. Medially is the neck of malleus, and laterally is the sharpness membrane or the pars flaccida. Anteriorly, you have the anterior malleolar ligament. Right. So this is a very important space where you have the retraction pockets. The most common retraction area is the Prusik space, which is very near to the neck of malleus. And initially, if you see what happens, there is just small amount of erosion of the sputum, and the disease is just limited to the Prusik space, and later on it actually involves the other spaces. So why do we need to use endoscope in ear surgery? So the anatomy part is over, and I will just give you an overview of endoscopic ear surgery. The most important advantage of endoscope is that it can cross the narrowest portion of the extremity canal. So if you see here, the microscope image is actually limited by the narrowest portion of the extremity canal. So the field of view is very, very narrow. You cannot have a field of view which is more than the narrowest portion of the extremity canal. While with the endoscope, you have an advantage that you can go beyond the restricted area, beyond the narrow portion of the external canal, and you can reach till the middle ear cleft, and you can have a wide panoramic view. So this is the main advantage of endoscope over the microscope. Obviously, there is a higher magnification and excellent resolution with the introduction of high definition cameras. We have very good resolution of the middle structures. We can have angulated view, like for example, if you want to see the sinus tympani, you can use a 45-degree endoscope to have a clear view of sinus tympani. You can visualize the confines of the middle ear with minimal exposure, and you can go beyond the shaft of the long instrument. So when you are operating with the microscope, the shaft of the instrument, the drill, and your hands actually obstruct your view. But when you are using an endoscope, you can go beyond the shaft of the instrument, go near the structure which is being visualized, and you can have a very good view. Documentation and teaching is obviously there with the endoscope, and you can perform minimally invasive temporal bone surgery. So these are the advantages. You can see the picture here. This is a microscopic view, and this is the endoscopic view. You can see the limited view which is offered by the microscope and the wide angle view which is offered by the endoscope. So with the endoscope, you are even able to see the processes cochleariformis here, the tensor tympanic tendon. This is the reflected tympanic tympanometer flap, promontory, round window, stipulated tendon, and the facial. So you can see how clearly all the structures are visible. That is the main advantage of endoscope over microscope. But there are problems also when you are doing an endoscopic ear surgery. There are other problems like it's a single-handed technique. Your one hand is occupied by the endoscope. There's lack of 3D view. Cutting and removing bone is difficult. There can be difficulty in bleeding control. Heat injury is a possibility because of the light source which you are using, and there is always a struggle to keep the endoscope clean, the tip of the endoscope clean, because every time you introduce, there is smudging of the tip of the endoscope with the blood.
Hello.
So equipment what we require 0 degree and various.
4
mm, 3 mm, and 2.7 mm, and also 1.5 mm.
कल भी चलेगा ना, कल संडे है, कल मैं इधर ही आऊंगा.
और sir, please, Dr. Ishwar, please pick up your mic. So you can use 1.7 mm endoscope for cochlear implant also to visualize the round window niche area. 3-chip camera, high definition camera, medical grade monitor, light source, and routine instrument with some modification. You have commercially available endoscopic ear instruments which are there in the market. right? So what we need is the suction elevators. So you can attach suction also with these instruments, and you can dissect as well as suck the blood simultaneously. So it helps to clear the field, and then you need to have a curve instruments which can reach the nooks and corners of the middle ear. So this curve is very, very important because you can visualize the disease, but your instrument might not reach that area. So curving the tip of the suction can actually help to remove the disease from deep sinus lymph cells. External hair canal, you must clip all the hairs because these hairs can actually make your endoscope tip dirty. Whenever you introduce, the hairs will smudge the tip of the endoscope and you can have poor vision. Right? So trimming of the hairs is important in the external canal. Heat injury, you must use the light source not more than 60%. High illumination can actually cause a lot of heat transmission to the mucosa of the middle ear and can lead to mucosal dryness and even burns. So always try to use light source as 60% and you can also use saline. So repeated use of saline can actually cool the tip of the endoscope. Control of bleeding, again, patience is key. You need to give local anesthesia, keep ADR soaked automites, wait for the ADR to act, and obviously if you are doing it on general anesthesia, you can ask the anesthetist fully to lower the blood pressure for you. You can use suction instruments to simultaneously suck the blood and do dissection. So this is how you tackle the bleeding part. Drilling, again, drilling is very tricky in endoscopy ear surgery because the tip of the drill can actually damage the, if you inadvertently touch the tip of the drill with the endoscope, it can damage the tip of the endoscope. So you must use smaller size blood. We always do some amount of canalplasty so that it will give you much more space for introduction of the endoscope and the drill and the suction. Size of the endoscope is very, very important. Ideally, the International Working Group of Endoscopy Ear Surgeons, they describe that you should use 3 mm endoscope. So that gives you a wide magnification as well as does not compromise on the quality of image, right? So the 3 mm endoscope is good enough. It actually helps you to introduce it along with the drill and the suction. There can be potential trauma to the ossicular chain, so you have to be very careful while drilling. Your instrument should not cross each other, and there should be good coordination between operating surgeon and the assistant. There are ultrasonic bone curettes available, which are very useful while removing bone during mastectomy in endoscopic ear surgery. Regarding the round window visibility, round window niche, because now we are doing cochlear implantations via round window niche, via round window membrane insertion, and bony cochleostomy has almost been abandoned. We need to visualize the round window niche during the surgery, and this grading was given by St. Thomas classification. And when you see 100% round window, it is called as grade 1. In grade 2, you can see more than 50% of the round window, but not 100%. In grade 2B, less than 50%, and in grade 3, you only see 0%. Right? So no part of the round window membrane is seen in grade 3. So these are the classification which was described by microscope. But if you use endoscope through the posterior tympanotomy, then obviously you can have a very good image of the round window niche, and sometimes it also have a better visualization of round window membrane. So we did a study in which we compared the endoscopic image with the microscopic image, and we found that with the endoscope, the visibility of round window niche is greatly improved. So you can use endoscope, 1.7 mm endoscope, through the posterior tympanotomy and try to visualize the round window niche area. It actually gives you a very clear, good image of round window, and the surgeon is more confident in identifying the round window niche area and inserting the electrode. So that is the advantage of using an endoscope in cochlear implant surgery. Another important thing which can be sometimes asked in your exams is the classification of endoscopic ear surgery. So the transcanal endoscopic ear surgery classification was done by Cohen et al. From USA. And in class 0, we use only microscope. Endoscopes are not used. In class 1, inspection only is done. endoscopes are used for inspection and not for dissection. In class 2A, you use endoscope for less than 50% dissection. In class 2B, you use endoscope for more than 50% dissection along with the microscope. And in class 3, only endoscopes are used and microscope is not used for performing endoscopy ear surgery. So this is a classification which was given by Cohen et al. My advice to the youngsters how to start endoscopy ear surgery is to attend the endoscopic course or maybe watch videos on YouTube and start with simple diagnostic endoscopy. Your hand-eye coordination, introduction of endoscope into the ear is important, and you can do with simpler procedures like diagnostic endoscopy initially. Then you can perform myringotomy and broma insertion, foreign body removal. Later on, you can graduate to myringoplasty with and without flap elevation, then obviously transcanal endoscopy, and as you gain experience, you can perform endoscopic stepidotomy and cholestoma surgery. So it's a stepwise learning. You need to start using endoscope in ear surgery, and slowly you will gain confidence. Some of the pictures in this presentation were from this book, Endoscopy Ear Surgery by Livo Presutti and Daniel Marcioni. This is supposed to be the Bible of endoscopy ear surgery, and if you have time, you can read this book. These are few publications from our department on the endoscopy ear surgery. Thank you very much. Any questions, I would be happy to answer. Thank you very much.
That was a very comprehensive class by Dr. Ravi. I now invite questions from the faculty.
Dr. Ravi, have you started? Hello.
Yes, sir.
Hello.
Yes, I can hear you.
Yes, are you heading towards class 3 endoscopic ear surgery now?
Sir, yes, sir. We are doing class 3 endoscopy ear surgery. We have done a good amount of cases. We have, in fact, done a thesis on endoscopic mastodectomy. We have done thesis research on endoscopic stepidotomy, all done completely by endoscope. So Dr. Vikram is here, and he is also having good experience of using endoscope for mastodectomy. And in fact, he has devised few techniques also of doing mastodectomy, few refinements, few innovations, which we have published in a book also, in a chapter. So we are doing a good amount of endoscopy.
Good. Keep it up.
Thank you, sir. Thank you. Yes, Dr. Ishwar, can we go ahead?
Ravi, what are the hidden areas left now in the middle ear now with the advent of endoscope? What all area which cannot be reached with this endoscope, or we can see all the hidden areas?
Sir, I think endoscope has revolutionized the middle ear cleft anatomy, and we can visualize almost every area of the middle ear by endoscope, except for the fact that sometimes there can be small areas like subpyramidal recess. This subpyramidal recess you cannot visualize completely unless you drill the pyramidal eminence. So that can be also, when you do a bony dissection, you can visualize almost all areas of middle ear cleft.
Dr. Ravi.
And how much is the control with a single hand?
Sir, there is people are doing, using endoscope holders also, but the recommendation from International Working Group is that you must do it single-handedly, because surgery is a dynamic process. When you are using an endoscope, you have to go close to this instrument, to the structures in the middle ear. Sometimes you have to withdraw the endoscope. Sometimes you are doing dissection. So it is a dynamic process. You cannot fix the endoscope in an endoscope holder, right? So endoscope holders have another problem. Like if you are doing it under local anesthesia, the patient moves suddenly, and then it can actually cause trauma to the inner ear structures, because the endoscope is fixed by a holder. So I think endoscope single-handed technique is going to stay, and it is better technique, and we must learn to develop this single-handed technique. It has a long learning curve, but once you get hang of it, you will be doing it comfortably.
Ravi? Hello, Ravi?
Yes, sir.
Ravi, for postgraduate, please explain the genesis of COG.
Okay, so this cog is a structure which is actually, it's a bony ledge which actually arises from the tegment tympani, and it can be visualized in a coronal plane. And this cog actually divides the tympanum into two parts, the anterior epitympanic space and the posterior epitympanic space. In the posterior epitympanic space, we have the malleus, the head of the malleus, and the body of the incus. In the anterior tympanic space, you don't have any ossicle, but it is a potential space which can be sometimes eroded by the cholestoma. And if the cholestoma is going into the anterior epitympanic space, then you need to drill the cog and you need to remove the malleus, head of the malleus, nip the head of malleus to remove disease which is going medial and anterior to the cog. I think this explains the.
Embryologically, it is actually why it is a bony ridge. You see, the medullary spaces are just like mesentery, and here we have folds. Hello, Ravi.
Yes, sir. Yes, sir.
See, and the
yes, I can hear
means
you.
it is the junction of two pouches.
Right, sir. Absolutely. Saccus anticus and saccus.
Let me explain. Saccus anticus and anterior fold of saccus medius. That is what is called.
Right,
And
absolutely.
it is a very thick structure. It is very difficult to get eroded. So there is a surgical importance to this. Another thing, anatomically, you showed endoscopically. So please explain that where all these three pouches meet, and what is the importance of this surgical importance of these places?
Basically, sir, actually, if we see the medullary anatomy, these pouches actually form the various folds. So these folds actually divide. These folds are important for ventilatory pathway of the medullary cleft. These folds actually divide the epitympanum and the mesotympanum. Like I have already explained the epitympanic diaphragm. So these different ligaments and the folds actually form the epitympanic diaphragm with two spaces, which are the anterior isthmus and the posterior isthmus, also known as pouch of Von Troch, anterior pouch of Von Troch and the posterior pouch of Von Troch, and these are the spaces which actually helps in ventilating the epitympanum. Right? Any obstruction in these areas can lead to problems. So while doing endoscopic ear surgery, you can actually visualize this area, and sometimes it is possible to clear the disease from the isthmus without actually dislocating the ossicles. So there is a very important these tympanic membrane and these ligaments and folds are very important for basically ventilation of the medullary cleft.
Very nice, Ravi. Actually, what my context was that all these pouches meet, all these three pouches, they meet at the oval window niche. And this oval window niche anatomy is very important for all surgeries which we are doing as per otologists. All right. So the student should know the development and what are the variations. All developmental variation which you told as well as Dr. Rakesh initially has in earlier lecture. So if they know these medullary pouches and how their rotations are, then I think disease process they can explain properly as well as the anatomical variations. This was my context. So they should know the each point which is important. Sibiculum has a separate importance. Ponticulus pyramidalis has a separate importance. So they should explain it properly in there. Thank you.
Hello, Ravi.
Thank you, sir.
Ravi. Ravi, the anatomy under endoscope and anatomy under microscopes look to be different as per your lecture, if you understand. And this message should be sent across the postgraduate students.
Right, sir. Right, sir. Absolutely right. That is why we have kept this topic, because the endoscopic anatomy is very much different from the microscopic anatomy. When you are doing a microscopic surgery, you are seeing a very small area. But when you are using an endoscope, you are having a wide field area, and you can actually see the nooks and corners of the medullary cleft. So the importance of retrotympanum and the hypotympanum is very important when you are doing endoscopic surgery. I think if there are no more questions, we can go to the next lecture.
Yes, sir. Our next presentation is on newer modalities in diagnosis of voice disorders. So I now call upon Dr. Shruti Bhingra, please, Assistant Professor at Department of ENT, MAMC.
Thank you, Vasan. Please let me know if you're seeing my slides.
Yes, ma'am.
Okay. Okay, a very good morning to everybody. And after those super talks on otology, we are slightly deviating into the larynx now. I will be talking on newer modalities in the diagnosis of voice. And I will be basically covering stroboscopy, videokymography, laryngeal EMG, optical coherence tomography, and narrowband. And and asked in the exam. So let us start with the perceptual evaluation. Just let me do the slideshow. Okay. So you're a patient of vocal fold paralysis and you are looking at the vocal folds. It's not important to just see whether the vocal fold is moving or not moving. There are a lot of subtle things that you need to see beyond this. So once you have seen the breathy voice and inability of the patient to project his voice, you should look for paralytic falsetto. What is paralytic falsetto? This is a high-pitched compensatory voice that the patient may acquire because of a supraglottic squeeze as a result of immobility of one side of the vocal fold. This also happens because of contraction of the cricothyroid muscle, which also tells you that the superior laryngeal nerve is still intact. Then you should also look for disturbed articulation and frequency. I think somebody's mic is on. Yeah. So you should also look for disturbed articulation and fluency, which indicate a high neural paralysis, and the maximum phonation time is less than 20 seconds. So when you're doing a laryngoscopy for a unilateral vocal fold paralysis, you look for the final position of vocal folds. Now, this final position can take anywhere between 4 to 6 weeks to be certain, and this happens because of the synkinesis that goes on even after the paralysis. Then you should look for asymmetry of arytenoids, that is the anteromedial prolapse of the arytenoid on the side of paralysis. And what you should also see is the jostle sign. What is a jostle sign? That if the patient is adducting, the arytenoid of the normal side touches the arytenoid of the paralyzed side, and this arytenoid does not move. If it moves, that movement that shows that the cricoarytenoid joint is normal. So this helps you to differentiate a vocal fold paralysis from cricoarytenoid joint fixation. Then you should also look at bowing of vocal folds, and this bowing happens because of atrophy of the thyroarytenoid muscle and a level difference between the vocal folds. Also, you will notice that on the side of paralysis, there may be pooling of saliva, and there is hyperreduction of the false cord on the opposite side of paralysis. So suppose in this figure, the left vocal cord is paralyzed, you will see on adduction, the right false cord will try to medialize or hyperadduct. Then you should also look for supraglottic squeeze, which is I've explained is a compensatory maneuver for a glottic insufficiency, and E-sniff maneuver, which tells us about the asymmetry of motion. That is, you ask the patient to say E and then suddenly sniff. So you go from an adducted to an abducted position, and this will tell you about symmetry of movements of both arytenoids. Then you should also watch out for interarytenoid, because interarytenoid has a dual supply from both sides. So, so you ask the patient to sniff after a resting position. So in a resting position, cords are not adducted. So interarytenoid's action is out. And then the pharyngeal squeeze maneuver is that you ask the patient to say a high-pitched E, that is E, And when you're doing a high-pitched E, the pharyngeal squeeze happens. And this tells you about the swallowing function, that this patient is going to have a good swallowing function in spite of the paralysis. This is how it looks like. So once you have done this perceptual analysis, the next is that you go to stroboscopy. Now, strobe is I would not say a recent thing because it's already been 10 years, but some institutions may not be having a strobe, so it's nice to know. And strobe is basically based on the Talbot's law, who stated that if an image is present in the retina for less than 0.2 seconds and you project another image to the retina, they appear as a continuous image. So in a landmark experiment that was done by Ortel in 1895, what he did was that he had some light and a cardboard disc with holes. So as light was passing through the moving cardboard disc, this light was captured on an indirect laryngoscopy mirror. And with that light, he saw the vocal folds. And then he understood that if you divide the light like this, the vocal folds appear to be moving slow. So the things that you analyze in a stroboscopy are periodicity, that is the regularity of each successive vibration, the amplitude, that is the lateral excursion of the vocal folds, the symmetry of vibration, which is the vibratory characteristic of the phonatory mucosa, and also look for symmetry of both arytenoids, symmetry of both sides. Sometimes in a paralysis, the whole of the larynx is skewed to the side of paralysis. That's important to see. And then you look for glottic closure, which is a component of the musculomembranous part, whether you are seeing an hourglass-shaped gap or a spindle-shaped gap, depending on the lesion. And if you see scarring, you may see some glottal insufficiency like this. So in strobe, you will also look for mucosal waves, and the mucosal wave depends on the rheological property of the phonatory mucosa. So if you have, say, a vocal cyst on one side and a normal vocal fold on the other side, the mucosal waves may be different on both sides. The main drawback of stroboscopy is that it works well only with periodic oscillations and if the patient has a stable pitch. So what if the patient does not have a periodic oscillation? Say that the patient has a dystonia or maybe a muscle tension dysphonia. What do you do in that case? The second problem is that strobe is an illusion. It is not a real-time image. So there may be some faulty interpretation of the findings. And strobe only works to see the superior surface of the vocal folds and not the undersurface or the medial surface of the vocal folds. So what if there are voice breaks, tremors, or spasms? What if the patient has a functional voice disorder or a supraglottic compression? So if there is too much of supraglottic squeeze, you may not be able to see the chords at all. And sometimes the patient has an extremely rough voice, but structurally you don't see any abnormality. So what do you do in those cases? So what comes to our rescue is the video chymography. Video chymography is another new technology, and it is based on the principle of examining dynamics of vocal fold vibrations. It was first described in 1994. And how you do this is by using a camera, a special camera, which has two modes, the standard mode and a high-speed mode. So in a standard mode, you have 50 to 60 images per second, and in a high-speed mode, about 8,000 images. So the special equipment is a video chymography camera, a video processor, and a foot switch to control your switching of light. So what a video chymography is, you are evaluating the vocal folds and you examine one particular line on this vocal fold vibratory edge, and then all the images across this line are placed one under the other. So it is just one frame that you are looking at, but you are looking at all the images in that frame, one below the other, and these images are plotted against the time. So you are evaluating the vibratory function of the vocal fold rather than its structural function. So the advantage is that you will be able to see the presence or absence of oscillations, the regularity, right-left symmetry, duration of the open phase and the closed phase of the vocal folds, dynamics of the upper and the lower lip. Now, strobe will only show you the superior surface. But if you would take a cross-section like this and put all the images one under the other, you will be able to see the medial edge as well as the inferior edge of the vocal folds. And then you can see the sharpness and the roundness of the medial peak and the lateral peak, and any abnormality across the medial vibrating edge. Also, these images are real time. That is, when you are doing the laryngoscopy, at the same time you are seeing these images on your screen. So they are immediately available for analysis, as against some other techniques like high-speed digital imaging, where you take the data and then you have to assess it at a later date. So this is another example where you see that this vocal fold has scarring, right? The left vocal fold has scarring. And if you see the VKI image of the same thing, you will see that this left vocal fold does not show any vibrations. And it is like coming like a still image. This is another example where the vocal folds are appearing polypoidal. So when these images, these vocal folds were assessed, they appeared to be just like a polypoidal ring case sort of a thing. But when a video chymography image was assessed, the medial part is showing this sulcus, where you see this arrow. And then the authors were able to see that, yes, indeed, there was a sulcus on the medial side. So it sometimes helps you to see some subtle abnormalities which you may miss otherwise on a laryngoscopy. Again, in this example, these vocal folds appeared totally normal on examination, but the patient did have hoarseness, and VKI image showed that the right vocal fold was a little less vibrating as compared to the left side. So these video chymography images can be overlapped. So the right side and the left side, you can make a 2D graph like this. This is normal. And if one side has a decreased waveform, then you will see it apparently on the 2D graph. Nowadays, digital chymography is a newer thing which is coming up, and you have 3D chymography. What is that? You can assess the vocal fold in a horizontal plane, vertical plane, and the third dimension of time. So what is done is that along with a high-speed camera, you have another camera like this, which projects laser light. And this laser light falls on one specific area of the vocal fold. But this makes the equipment a little cumbersome to hold, definitely. But with this laser light and the 3D imaging, you can be easy to assess the vocal folds in all the 3 dimensions. Okay, next we come to laryngeal EMG. Laryngeal EMG is a procedure that evaluates the integrity of the muscular and the nervous system of the larynx. So if you have a paralyzed vocal fold and you don't know whether the problem is at the level of the nerve, the neuromuscular junction, the muscle, or the joint, this is when EMG is going to be useful. It is best done between 1 and 6 months from the onset of paralysis, because it takes about 3 to 4 weeks for Wallerian degeneration to completely set in. Now, how you do an EMG? So the patient, it can be done in a sitting or a lying down position. In a sitting position, patient slightly extends the neck, and this needle is inserted, and how it is done, I will just tell you the details. The most common muscles which are examined are the thyroarytenoid, the posterior cricoarytenoid, the cricothyroid, and sometimes the LCA and the interarytenoid. Now, depending on which nerve you are assessing, you can choose the muscle that you want to assess. And these electrodes sense the electrical impulses within the muscle and give us both a visual input as well as an auditory signal. So this has to be kept in mind. So this is like a standard equipment for an EMG. There will be electrodes, and a reference electrode and a ground electrode is also inserted somewhere away from the area of the neck, like you can put it in the mandible or in the forearm or the sternum. Then you have an EMG amplifier and a monitor with a sound system, because sometimes the examiner may just hear the sound and know that you are in the right muscle. The type of electrodes that are used are various, starting from concentric. Concentric is like this. You have a hollow needle, and then you have an electrode point in between. You can also use a monopolar, bipolar, single fiber, hooked fiber. The hooked fiber ones come like this. They have these small hooks, the E part, and the hooked fiber can also be in a curved form. They are easy to insert. They are used if you want to assess the laryngeal muscles over a long period of time. They keep themselves in place. They don't come out easily. But the problem is that once they are out, it is difficult to reinsert them. The most commonly used electrodes are concentric or monopolar. Now, supposing you want to assess the thyroarytenoid muscle, you insert the needle through the cricothyroid membrane, and it has to be 30 degrees lateral and 15 degrees down. Once the needle is in, if you have to ask the patient to say E, and when he says E, there is adduction and the thyroarytenoid muscle contracts, and you will see a sudden sustained EMG activity. If you are in and the patient starts to cough, that means you are in the airway. So you come out, shift by 5 millimeters more laterally, and then again try. If, however, you go too posterior, if this is the thyroarytenoid and you go too posterior, you may be hitting the lateral cricoarytenoid, which is just lateral to the thyroarytenoid. That will be if you are more than 15 millimeters in. And this is how it can be done. This is under general anesthesia, how it can be done. To assess the lateral cricoarytenoid, so lateral cricoarytenoid patient says E, which is a short initial increase in EMG activity followed by a decrease while phonating. And for the PCA, PCA is the abductor. So you ask the patient to sniff. And how you do this? There are two methods. You can either go directly in, 15-degree laterals, and go directly in. But for that, you have to pierce the posterior arch of the cricoid and go in, which is more difficult to do. The other way is that you rotate the larynx. You hold it with your thumb and just rotate it a little bit. And if you were to draw a line along the posterior border of the thyroid cartilage and the upper border of the cricoid cartilage, you will get 4 quadrants. And if you were to put your needle in the upper outer quadrant here, you are likely to hit the PCA muscle. You ask the patient to sniff, and as the patient sniffs, there is an increase in EMG activity. And when he says E, there is a decrease in EMG activity because it is an abductor and not an adductor. This PCA can also be assessed under general anesthesia, and this is where your needle will go. Okay, next we have the cricothyroid. Cricothyroid is a tensor of the vocal fold. So for the cricothyroid, you have to be very lateral, just hug the cricoid cartilage a little laterally, 50 degrees laterally, and you just have to go about half a centimeter in, and you ask the patient to start on a low note E and then increase the pitch. So E, like that. If you start on a low note and increase the pitch, because it is a tensor, you will find an interference pattern becoming more dense. So how do you interpret all these EMG findings? They can be really confusing. I have tried to make it very simple for you to understand. So basically it is done in 4 parts. First is the insertional activity, that is when you insert the needle. The second is at rest or during spontaneous breathing. The third is at minimum voluntary contraction, and the fourth is when there is maximum voluntary contraction. So normally, a normal motor unit potential looks something like this, which is something like an ECG waveform that you would see. It is about 5 to 6 milliseconds in time and 200 to 500 microvolts in amplitude. Now, normally, this is how it will look like. Velocity will depend on the myelination of the fiber, and the amplitude of this waveform will depend upon the number of motor units that it is activating. Okay. So what is insertional activity? In a normal muscle, if you were to insert a needle, there will be an initial burst of electrical signal which will last for 300 milliseconds. In an early injury, what happens? The muscle is very unstable. So if you were put in a needle in an unstable muscle, you will get a pattern like this, which will be more than 300 milliseconds. In a late injury, what happens is that this injured muscle is covered with fat or scar. So if you put in a needle in an injured muscle, there will be no activity at all. Next, we come to spontaneous activity. So a normal muscle has no spontaneous activity. A severely denervated muscle, that is a muscle after 2 to 3 weeks, will start to show unstable electrical charges. So these unstable electrical charges look like fibrillations or positive sharp waves. The muscle is degenerating and this process is ongoing. So if you see positive sharp waves and fibrillations, it is a sign of poor recovery, poor prognosis. So fibrillation potentials, positive sharp waves, complex repetitive discharges, and myotonic potentials. Myotonic potentials are seen in myotonic dystrophy, and the sound is like a dive bomber, which has been classically described. Now, when the nerve is in the regenerating phase, what happens is that this nerve is new, so it is a little poorly myelinated, and fewer number of muscles it is recruited. So because of the fewer number of muscle fibers, the amplitude will be small. And because of poor myelination, they will be long duration and polyphasic waves. So if you get a pattern like this, it shows that there is a recent nerve injury. If you see very high amplitude waves, so that implies that there are greater number of nerve fibers in the motor unit. And myogenic potentials, if the nerve is intact and there is a muscle injury. So supposing this nerve is intact and the muscle is degenerated. So because of the intact nerve, the time, that is the velocity, will be normal. But because the muscle is degenerated, the amplitude will be low. In maximum voluntary contraction or recruitment, there is an increase in the number and density of motor unit potentials, right? So recruitment is a good sign. So if you are seeing recruitment, it means that it is indicative of a good recovery. And this is how recruitment would look like. So you see giant amplitudes, but normal duration is implying that it is going to be in a good recovery. What happens in a neuromuscular junction injury? So in that case, the patient, once he will complain that there is voice fatigue or there may be fluctuating asymmetries of motion, like in neuromuscular junction disorders, there will be a decreased recruitment response. And if you do a tensilon test, tensilon, what it does is that it inhibits the breakdown of acetylcholine at the neuromuscular junction. So in myasthenia gravis, the recruitment pattern will revert to normal with repetitive stimulation. And if no vocal fold movement is seen clinically, but EMG is normal, this is a very tricky situation. So you're not seeing any vocal fold movements, but EMG is normal. That indicates that the patient can have synkinesis, a decreased muscle mass, or cricoretinoid joint fixation. So don't get confused. What the basic idea is that EMG only helps you to do some decision making. If you do a EMG within 1 to 6 months and you see no recruitment, you are seeing fibrillation potentials and positive sharp waves, it is telling you that recovery is less likely. And you will want to go in for a definitive procedure like an injection or a medialization thyroplasty. If, on the other hand, you are seeing polyphasic potentials, absent fibrillations, and good recruitments, it tells you that recovery is likely. And if the recovery is likely, you will give only a temporary injection and delay any surgical intervention. So practical applications of EMG are to differentiate vocal fold paresis from paralysis, cricoarytenoid joint fixation, and scarring. And in an article by Lucian Silica and Rosen Clark, they had said that LEMG helps to change the initial diagnosis from recurrent laryngeal paralysis to some other diagnosis like a cricoarytenoid joint fixation or scar or something else in up to 48% of cases. So it also helps you to differentiate superior laryngeal from recurrent laryngeal nerve paralysis. That will depend on the muscle group that you have stimulated, and to see neuromuscular disorders like myasthenia gravis, amyotrophic lateral sclerosis. Also, sometimes you see patients of malingering who say that there is some problem with their voice and they will start to whisper, but EMGs will be normal. And intraoperative evaluation in children. Now, especially in cases of vocal fold paralysis, nowadays, the ANSA recurrent anastomosis is on the rise. So before you do any ANSA recurrent anastomosis, you have to confirm by EMG that there is no sign of recovery. Only then you would want to cut the recurrent laryngeal nerve in these patients. So therapeutically, you will know whether you want to do a temporary or permanent medialization. Of course, for Botox injections, that is the most important indication that everyone knows. And the timing of intervention, when you want to intervene, whether in terms of temporary or permanent, and also to prognosticate recovery to the patient. So is LEMG a reliable predictor? Well, LEMG is a good predictor of poor recovery, which means that the positive predictive value is up to 90%. But it is an indifferent predictor of good recovery. This means that it will definitely tell you that the vocal fold paralysis is not going to recover, but it can't tell you for sure that if it will recover or not. Okay. Next, we come to optical coherence tomography. What is OCT? Now, we've heard a lot about OCT. It's used in ophthalmology a lot for taking images of the retina, and it has recently been introduced for examination of larynx as well. OCT is based on the principle of back scattering of infrared light. So it is a non-invasive technology. It precisely tells you about images of the epithelium and the superficial lamina propria interface, right? So if this were the vocal fold and this is the vocal fold cyst, this is an OCT image that is where you can see this very clearly and correlated with the pathology here. So what basically is done is that a 1 millimeter optical fiber is used, and it is in a plastic sheet like this. This optical fiber can be placed through a suction. The tip is in close or gentle contact with the area that you want to analyze. The wavelength of light used is 1300 nanometer, which is near infrared. The depth of penetration is about 1 to 2 mm, and an axial resolution is about 10 microns. So this is typically done under the general anesthesia. The surgeon is sitting at the hand end and using this optical fiber passed through the suction, and another assistant can see the image coming on a screen. And once you are just touching and you're close to the area that you want to analyze, you can see these waveforms. So the newer technology in OCT is polarization sensitive OCT, which is an augmented form of OCT. This is based on the principle that when light falls on the collagen, it appears as light, dark, light pattern. So why is this important? Because in a case where there is a scar tissue, there is increased collagen. If you want to inject steroid and you put your needle in, you can easily differentiate the scar from a non-scar area where you want to inject the steroid. The advantages of OCT are that the degree of basal membrane infiltration can be easily detected in early laryngeal cancers. It can decide a tumor-free margin or a transitional zone in early dysplasia. So if you are doing a surgery, I will just show it with an example. If you have an area of carcinoma and you are not sure about the margin, an intraoperative OCT will clearly define the surgical margin. And subepithelial implant injections in the no scar zone. But the disadvantage is that if it's a very thick exophytic lesion, then you cannot really make out. And you also cannot differentiate microinvasive cancer from severe dysplasia or carcinoma in situ. So if you have a scarred vocal fold like this, look at this line. This is in the OCT image, and this is the polarization sensitive OCT image. So in this scar, you can easily make out the light, dark, light banding patterns. This is again a papilloma picture where you see this frond, and this is the area of the papilloma, and this is a polarized sensitive OCT, which is showing you this dark area. Again, this is a malignancy, and this arrow is determining where is the line, where is the border of this malignancy, and better seen on a polarization sensitive OCT image. So it is typically done in the general anesthesia, but can OCT be done in an awake patient? Suppose we want to assess something in the office. So it has been tried, OCT has been tried to be used with the strobe now, and the technology time is not far when you will be able to combine a strobe and an OCT in the same flexible fiber optic laryngoscope that you're using. Okay. Next, we are coming to narrowband imaging, and I'll just brush through this quickly. Narrowband imaging is based on a blue-green light principle, which is preferentially absorbed by oxyhemoglobin. It ideally tells you the contrast and the difference between superficial capillaries, which look brown, and the deep veins, which look cyan. The wavelength of light used is 415 and 540 nanometers. And at this wavelength, when light falls on the superficial tissue, it is reflected by the capillaries. And what you classically see are these IPCL patterns, which are intraepithelial papillary capillary loops. And the classification has been given by Ni et al., where he's described arborization, loss of this symmetry, or some dots or brown spots, or this wriggly worm-like appearance. So if you're seeing this pattern on an NBI, first 4, it is not malignant. But if you're seeing 5A, 5B, and 5C pattern, it could be carcinoma in situ 5A and invasive carcinoma for a 5B or a 5C pattern. So this technology basically helps you detect whether this lesion could be malignant or non-malignant in an OPD setting. So because of this, you can do a target biopsy, you can upstage a lesion, and even in cases of post-CTRT, you can know if there is a recurrence or there are any metachronous lesions. It can be easily done in the office. Patients who have trismus or difficult airways and cannot be put under general anesthesia for a DL biopsy, a biopsy can be taken in the office using NBI and a flexible biopsy probe. Okay, this is an example of an NBI image. If you see this picture, you have a small lesion here in the piriform sinus area, which is better depicted on an NBI. This is an exophytic lesion on an NBI. And if you see this picture, you will see a smooth vocal cord, almost like no lesion is present. But if you see under an NBI, it will be better demarcated. Again, anterior commissure scarring and recurrence can be missed, but here you can see these NBI lesions. The accuracy of NBI, it is said to increase the sensitivity by 23% in detection of laryngeal cancer. And the drawbacks is that it is difficult to do if it's a superficial biopsy, if there is excessive secretion or too much proliferative growth, you will get only a superficial lesion. If there is bleeding, everything will look black, again, difficult to biopsy. And in post-radiation cases, there will be necrotic tissue and inflammation, and it will be difficult to see them on the NBI. So thank you very much.
Thank you for the wonderfully enlightening presentation, ma'am. We'll now take questions from the faculty, please.
Dr. Shruti, it was a nice presentation. For the PG students, what is the importance of stroboscopy? Because stroboscopy is, I think, very commonly asked in PG exams. So, what is the principle on which it is based?
I've already talked about the Talbot's law. So Talbot had described that when an image falls on the retina and another image is presented to the retina at very early, that is less than 0.2 seconds, it appears like a persistence of the image. So it appears like a slow motion and it does not appear as separate images. So that is the principle that is used for strobe. And the most used indication is that if you have symptoms of hoarseness, which are out of proportion to your examination findings, that is when you would want to take the patient for a strobe. Also, to know the depth of a lesion, if you have say a superficial carcinoma in situ, and you don't know, you don't know the depth of the lesion, so a strobe helps you to see that, depending on what is the vibratory capacity of that vocal fold.
Right. Thank you very much. So, I think we can move ahead to the next topic.
We'll now move on to sorry, sir. We'll now move on to our next lecture. That's Management of Facial Nerve Palsy by Dr. Amit Goel, Assistant Professor at AIIMS, Jodhpur.
Sorry, Dr. Amit Goel is Professor and Head of the Department at AIIMS, Jodhpur.
Sorry.
Dr. Amit Goel, please, you are most welcome.
Good afternoon, all. Let me thank Team Mansi and Dr. Ravi Meher for this initiative in these difficult times. And it's a unique experience to speak in front of many faceless audience, which we are not able to see directly. But I hope I'll be able to communicate the message clearly to them also. So the topic given to me is management of facial nerve palsy. I'll start my screen sharing. I hope you are all able to see my screen.
Yes, sir.
Yeah. So This topic is very important. As far as ENT surgeons are concerned, I hope since residency, all of us are very much concerned and we talk lot about facial palsy. We get patients also and we get our own patients getting landing up with facial palsy, either due to disease or maybe due to management also. So it's a very unique topic, and my talk will be focusing mainly once the facial palsy has occurred. So I will not talk anything about disease process or any surgical tips to prevent this complication. But once the patient has already suffered from facial palsy, I'll try to restrict to that. And what I'll do is mainly talking more about conceptual and some easy concepts which we can remember in our practice rather than going into much of the details of many newer things or so. So I'll try to make it a bit easier for the PGs. That's what I have tried to do. So here we go. So we'll rush through relevant anatomy and etiology and how to approach and how to assess a patient of facial palsy. Then certain diagnostic or electrodiagnostic tests which will help us in decision making, and then management of inflammatory causes, infective and traumatic causes, and then just a brief about rehabilitation and reanimation. So to start with the brief anatomy, as we all know, facial nerve is a very unique nerve in terms of that it is not only motor nerve, but it carries sensory fibers also and motor also, not only to the muscles of facial expression, which is the cause why we are much scared about facial palsy, because it's a lifelong advertisement if any patient lands up with a surgical complication. So it's not only motor to the muscles, but it also carries secretomotor fibers to lacrimal glands and to salivary glands also. And afferents also, special afferents from taste sensation from anterior part of the tongue, as well as touch sensation, general sensory fibers from the periauricular area. So everything has importance when we talk about facial palsy, because these will help us in topodiagnostic tests of the facial nerve palsy. So just a slide about common causes. There are numerous causes, but we mostly encounter with either neoplastic causes, mainly acoustic neuroma or cholesteatoma, if we call it a tumor at all. Or parotid tumors may lead to this facial nerve. Then traumatic causes, either temporal bone fractures or iatrogenic causes. That's very important. Infectious causes, mainly varicella zoster infection or mastoiditis, tubercular mastoiditis, all these may lead to facial nerve palsy. Then idiopathic Bell's palsy, we all know about it, and some metabolic causes may also lead to like diabetes mellitus to facial nerve palsy. So how to assess a patient? It's a very well-known system. It's a clinical system based on the patient's appearance and certain movements. And it is the most widely used facial nerve grading system. We all know about it. So it basically evaluates the patient at rest as well as dynamically on voluntary movements. So right from normal to total paralysis, we all can see that at rest up to grade 4, the patient may have almost normal appearance, but the dynamic starts getting affected from grade 3 itself. And there is another classification actually, Sunderland, but that is mainly based on the histopathology or physiological thing, and that's does not translate into clinical utility much, because we can't directly evaluate that thing. University of Iowa has proposed another system, that is repaired facial nerve recovery scale. So in which they are actually grading the recovery of the nerve facial functions after the nerve repair. So right from normal facial to no movement, they have also graded, but this system is also not very widely used. So clinically, we are much relying on House-Blackman scale. Once the patient comes, the history takes, as we all know, it's of paramount importance in any disease. Onset is very important, whether it's acute or insidious in onset. Any inciting factors, pregnancy or stress may lead to it. Duration, I think this is the single most important factor, whether it's a long-standing facial nerve palsy or a very recent onset facial nerve palsy, because that will define the management. So onset and duration, these two are the single most important factor. Then we have to evaluate for any other pathology, systemic conditions, autologic symptoms of any history of trauma or surgery might be there. concomitant symptoms in the form of some nasal congestion or fever or any facial history or rashes on the body of the patient, then neurological symptoms to rule out any neurological cause for it. So history in detail we have to take, and as we have seen, there are various fibers which are given by the facial nerve, carried by the facial nerve, and it's a very basic but simple slide. So if the injury is to the extracranial facial nerve part, then only the muscles of facial expressions will be affected. So mainly the patient will present to us with the inability to close eye or some laxity or brotosis and all. Facial movements are affected. Tympanomastoid segment, it carries, it's mainly that cauda tympani nerve. So loss of taste and dry mouth and hyperacusis may be another symptoms if the injury is in the tympanomastoid segment. If injury is to the geniculate ganglion, again dry eye or dry nose, because the GSPN nerve that carries fibers to lacrimal gland and mucosal glands of the nasopharynx and this oral cavity and all. So, and if the lesion is in internal acoustic canal, then again loss of hearing and balance may be affected. And if it's a CNS, then definitely we all know the frontalis that receives innervation from both the sides. So if it's a lower motor neural palsy, the whole all the muscles of one side of face will be affected. But if it's a human type of palsy, frontalis will be spared because it receives innervation from both the sides. It's all a basic thing which we have always been talked about. Regarding topodiagnostic tests, I think the first two tests are important, which are done clinically, routinely. Shermer's test to see the tear production, and it drastically reduces on the side of facial palsy if the site of lesion it is proximal to the geniculate ganglion region. Stapedial reflex, if the site of lesion is proximal to the nerve, origin of nerve to stapedius muscle, it is affected. The precondition to use stapedial reflex is that the middle ear should be absolutely normal. Then electrogastrometry, it evaluates the taste sensations on the anterior part of the tongue, and salivometry, that is salivary gland flow from the submandibular gland. But these two tests are not routinely used clinically everywhere. So mainly we more rely on these two Shermer's test and stapedial reflex test to know the site of lesion. Electrophysiological tests. Now they are very interesting. There are 4 tests described. 2 of them have replaced the other 2 at most of the centers, but their decision-making use, that is something which is debatable. Many centers they use it, many centers they don't use in their decision-making armamentarium. So I will discuss about it in a bit detail in coming slides. So nerve excitability and maximal stimulation test. They give current to the branch of the facial nerve and they see the muscle movement, and they compare from the other side. So based on the difference in that healthy side and the response in the healthy side and disease side, they come to conclusion about degeneration. But this electroneuronography, which actually it gives a maximal stimulation to healthy and disease side, and surface electrodes, they measure the activity. So what it is measuring, it's not only measuring directly the muscle muscle responses, but it's actually compound action potential it is measuring, and it tells us about the number of viable fibers present. So based on the difference on both the sides, we come to a conclusion, the degree of neural degeneration on the affected side. And the electromyographic test, it uses needle electrodes. So it is basically at rest in the voluntary contraction, we get the electromyographic signals through the needle electrode. So these 2 tests have actually replaced the other 2 tests at most of the centers. And a bit in detail about these tests, because there is a lot of confusion when to use, when not to use, what is the utility. So about ENOG, one thing is there is no use in paresis. So we don't advise any test if the patient is having even slight voluntary movements, because the slight voluntary movements, they itself indicate good prognosis. So no need of any test for them. In Ramsay-Hunt syndrome, no use of any of these tests because there are usually multiple sites of involvement might be there. In ENOG, there is no use of this test before 72 hours of onset of facial nerve. The reason being means the facial palsy has occurred, so should lose this test after 72 hours, because voluntary degeneration, it takes around 72 hours to set in. Before that, we won't be getting any conclusion. And after 21 days also, this test does not have any value because the regenerating muscles might have asynchronous discharges, which might not translate into effective compound action potential, and we might get erroneous false negative results. So that's called deblocking effect, and so this test should not be prescribed after 21 days. So we are left out with 3 to 21 days of window for this particular test. Now, the interpretation of this test is degeneration of more than 90% within 14 days have poor prognosis. And if suppose by 3 weeks we have a degeneration which is less than 90%, we can expect a better prognosis. And it's not only the percentage of degeneration, even speed of degeneration also matters, because if within 5 days we have seen severe degeneration, then those patients usually have poor prognosis. So based on this test, we can prognosticate the facial nerve recovery. EMG, if we are doing it within 3 weeks of duration, so we have to correlate it with the results of ENOG. If a patient is showing more than 90% neuronal degeneration on ENOG and we do EMG, then if we see active motor, we don't see active motor unit potential, the prognosis is bad. And if we are able to see active motor unit potentials within 3 weeks with 90% degeneration, still the prognosis can be good. And after 21 days, this EMG has more value because in long-standing paralysis, polyphagic potentials, they indicate re-innervation. So these two tests have to be seen based on the duration of facial weakness. And if it is less than 21, then the results of these two have to be combined to prognosticate the disease. So we are not diagnosing facial palsy, but we are just prognosticating the recovery by these tests. And many centers, they are not using these tests for recovery. And I'll discuss in some next slides how they are doing it. So one by one, if we take Bell's palsy, we all know it's a diagnosis of exclusion. The role of oral steroids, we all know, but the role of antivirals is seriously debatable. There is means nothing conclusive about the role of antivirals. And if you are using ENOG as your prognostication criteria, so if you are going for more than 90% degeneration, facial nerve EMG showing no activity, then consider surgical decompression. But this is debatable. Now, most of the these review articles and meta-analysis, they are saying they are equivocal results from surgical decompression, whether you do it or you just go with medical management, number one. Number two, at all, if you are considering surgical decompression, then middle fossa approach is the minimal thing to do, because it is a labyrinthine segment which needs to be decompressed completely. And remember, Bell's palsy, hearing is almost normal. If you want to do really effective transmastoid decompression, then hearing might be at stake. So what they recommend that middle fossa approach is gives you better results in terms of facial nerve recovery as well as in terms of hearing preservation in cases of Bell's palsy, if at all you are considering. But the literature is equivocal with regards to surgical versus medical management. Ramsay-Hunt syndrome, it's basically viral reactivation of virus, and cochleovestibular symptoms are also there along with this. So the best thing is to start antivirals and steroids within 3 days of onset of symptoms. Then you can expect a decent recovery, facial recovery. After 3 days, recovery might be there, but the prognosis is not that good. So 3 days is basically, it is described as a cutoff period. Within 3 days, you should start the treatment. And in older patients, definitely, or if it's a complete paralysis, the prognosis is not very good. And usually, prognosis may be complicated by some synkinesis or hyperkinesis or accompanying and other complications. Infections, acute infections or chronic infections may be there. The nerve might not be directly involved by the infectious process, or the bone still may be intact, but there could be still edema, inflammatory edema due to infection, which might enter the fallopian canal by various methods. And in necrotizing otitis externa, it is usually the direct involvement, and the treatment relies mainly on the antibiotics along with the steroids, and if needed, facial nerve decompression in terms of clearance of infective disease, as well as, if needed, exposure of the nerve. So, if at all you are seeing any CT scan, this is an advice for PG students. Stop seeing the films only.
You can see this facial nerve getting involved by the disease here, but you will have a better understanding if you see the DICOM images on a computer screen. As we can see, just look, point at my cursor, and this is the facial nerve, horizontal segment coming posterior, and you can see it's getting involved by the disease here, the vertical part. Similarly, in this coronal section, initially you will see two dots by labyrinthine and transverse section, and you can see the two dots. Now this is the nerve which is involved, and you can see it is directly in contact with the disease, then it's coming down. So always make it a habit to see the DICOM images on a computer screen. One by one, if parotidectomy, you are doing a parotidectomy and the patient comes out of anesthesia and you encounter a facial palsy. If it is incomplete, just reassurance, nothing else to do. But if it is complete and you are confident that anatomical the nerve is intact, then you can just follow up the patient. Usually it improves. But you have, if it doesn't improve in 6 to 12 months time, still it's a case for re-exploration. But if you have any doubt, then better to re-explore it immediately. Sometimes it might be a referred case operated by somebody else coming to you. So in that case, it's always advisable to contact the primary surgeon, because he might give you some important clues, or you can just follow up the patient. If you do re-explore the patient, there are 4 conditions of facial nerve you might encounter. If it's a swollen nerve, just close it, don't do anything, it will recover. If it's a fibrotic nerve, it's functionally useless, resect and reconstruct. If it's a completely transected nerve, that you pressure the margins and reconstruct. If it's a partial damage to the nerve, if it's up to 1/3 of the nerve, then no intervention is needed, or at best you can just put a split thickness nerve graft. But if it's more than 1/3 of the nerve is damaged, then removal of the involved segment with reconstruction is advisable. If it's a temporal bone surgery, you go for a ward round in the evening of surgery and you see the patient is having facial paralysis, just remove the pack immediately. First thing to do there. Then see. If it's a delayed palsy, definitely no surgical intervention is needed because it's due to edema. But if it's a partial paresis, again, nothing to be done. But it's a complete immediate palsy, and you are confident that you have not damaged the facial nerve, then the reason may be either the local anesthetic, the effect of which will go away within hours, or it could be due to edema, which will settle with time and no surgical intervention is required. But if you are not confident, then definitely it's a matter of re-exploration, and again, you might find an intact nerve or less than 1/3, more than 1/3 damage, or complete transaction, based on which you will just manage it. If it's an intact nerve, just close it. Now, remember, whenever you are going for re-exploration, it's always better to go for a CT scan first, because sometimes you might see that this is the facial nerve and you are seeing that it's just a looping. 20-25% of the nerve is involved, rest is intact. It might be a case just to follow up. It might save you from re-exploration. Help is very important. Never hesitate to call for help, because your mind is already exhausted and your confidence is also at low. So better to ask somebody for help. Timing of re-exploration, people say that sun should never set, but I will believe that better to wait for your own confidence to regain, and some help might arise. So you may take few hours to prepare for re-exploration. And remember, whenever you are re-exploring, always, because there might be, in primary surgery, there might be multiple damages. So always explore the complete course which was involved in the primary surgery. Epinurium, you have to, while reconstructing this anastomosis, epinurium, you have to peel off the epinurium and just try to stitch only the endoneurium using this sharp needle, cutting needle. Don't use the blunt needle, because that will further stress the nerve fiber. And like, it's a small video from our department, and you see that you have to rotate the burr in one direction only, largest possible diamond burr in one direction only. And with copious irrigation, this sharp, thin bony covering you can remove from sharp, either curate or some elevator, and then see the edges of this damage. Then prepare the nerve graft, suture it with the cutting needle without any traction on the nerve. It should be a tension-free anastomosis. Then this is anastomosis at both the sides, and then
You can use tissue glue over it if you want, then put a covering of fascia over it. So that's how these precautions you should take whenever you are reconstructing. Fractures, it may be longitudinal or transverse. I won't go in detail, but what I will go is, again, it's difficult to judge the time of onset because patient usually might be unconscious, or there might be some other concomitant injuries. So evaluation of facial nerve may be compromised, but you should try to do it as early as possible. If it's a delayed palsy, you are sure some attendant was there who could vouch that it is a delayed palsy, then just follow up. Might be edema or hemorrhage. Again, if it's a partial palsy, just follow up. But if it's an immediate complete palsy, then there are two systems to follow them up. Certain groups, they follow only radiologically. They get a CT done. And if the fracture line is crossing perpendicular to the facial nerve canal, or if there is sharp bone spicule or complete interruption, then they go for surgery. If the fracture line is parallel to the longitudinal axis of facial nerve canal, they just observe for 6 to 12 weeks. If no recovery, then they go for surgery. So radiology, they take radiology as their decision-making thing, but there are groups which take ENOG for their decision-making thing. What I will suggest that it is a clinico-radiological decision which might be backed by ENOG. So if there is less than 90% degeneration in 3 to 14 days, go for just conservative. Otherwise, go for EMG. And if it is still showing no response, then go for. So basically, it's your choice. You have to formulate your own way. But what I believe, it's only in trauma cases, it's a clinical radiological decision which may be complemented by ENOG findings. Reconstructions may be dynamic or static. Dynamic, which will give you movement also, and static will be giving you only the appearance. So for dynamic reconstruction, nerve plasties, various kind of nerve procedure, either direct anastomosis or interposition graft or hypoglossal anastomosis, sural anastomosis, or cross flow nerve suture, or muscle plasties, where you will use some adjacent muscle to give some movement to the particular area of the face. Static procedures is mainly like eye loading. They are just passive static things which will give you appearance. Angle of mouth can be managed by facial atta slings and other sling procedures. So they are static, but on movement there will be disfigurement. So based on they are only used when you can't reconstruct the primary nerve, and there are long-term facial palsies not recovering. So if it's a less than 1 centimeter, go for direct anastomosis. More than 1 centimeter, interposition graft. And if it's a chronic facial nerve palsy, then you have a lot of options available based on your expertise and experience. Now, in the end, a few interesting scenarios I would like to just talk to the PGs for them. So there, you might land up with a situation there when you don't find any landmark during an ear surgery. You don't find any landmark, neither annulus nor in the middle ear also it's full of granulations or disease status. In that case, the eustachian tube may be an important landmark to tell you that you are in the middle ear, medial wall, promontory is there. And you might get a case where you can just roll your cotton ball all around the facial nerve if it's a complete labyrinthine destruction by the disease. Or sometimes what we have found that it's a hanging facial nerve. You elevate the flap and you see a nerve-like structure hanging in the middle ear cavity. So you might feel tempted to cut it, thinking it could be a mucosal fold, but be aware, can be facial. Or recently we found a bifid facial nerve. So during stepidotomy, we exposed, and this is your oval window, one facial nerve and another branch of facial nerve on the promontory. So this also may be a difficult situation, and you might land up in trouble if you don't pay attention. Nerve stimulator was definitely useful in all these cases for us to know that, confirm that it is a facial nerve only, and it saved us from embarrassment all the time. So, take-home message for our residents is be friend with the nerve. It has to be delicately taken care of, but it is not to be scared of, actually. If it's an incomplete paralysis, you can just observe. Clinical radiological evidence you have to use judiciously. It may be supplemented by electrodiagnostic test. ENOG has a role in 3 to 21 days, and EMG has a role less than 21 days, it has a role complementary to ENOG, and more than 21 days, it is the only test which can tell you something about the possible recovery. So electrodiagnostic tests are basically prognostic tests. I don't say them diagnostic tests, they are prognostic tests which can tell you about the prognosis of the facial nerve palsy. If at all you end up in a surgical complication, take things head on and never feel hesitant in calling for help, and try to assess facial nerve as soon as possible in cases of trauma, especially roadside trauma, because this is the single most important factor in deciding for the management. Rehabilitation and reanimation are equally important for patients whom we cannot give full facial recovery. So this is a case where this interposition graft by greater auricular nerve, and 8 months later we could see her again smiling happily. So thank you all for your patient listening, and I'll be happy to answer any questions. I hope I could finish in time.
Thank you, sir. I'm sure the residents would benefit a lot from this presentation. Are there any questions from any of the faculty members?
Amit?
Yes, sir.
Ishwar here again.
Yes,
What
sir,
is this new, this thing, partial nerve grafting? Say if less than 1/3 of the nerve is damaged, or then it's better to observe that what you said in the carry home message. But in your workup, you said if it is there, then you do the partial nerve grafting.
So mostly, yes, so most of the centers, they just observe it, but few people have tried the partial thickness of the nerve. They peeled off the epineurium, they took a partial thickness of the nerve follicles and they just interposed in that damaged area. So, but there is not much literature I could find, but it is one of the things which has been used by few of the people. Most of the people, they would like to observe it if it is less than 1/3 of your total nerve area.
Just now I thought of another question. Should one use the glue to hold the nerve ends together? Will it not prevent the growth of axon?
Okay, the glue actually, it doesn't go inside the nerve. It's a very thick thing. So space is not much that it will go inside the nerve and prevent it.
Audio is not clear.
So what I am saying, this glue is very thick. It doesn't go inside the nerve. It will just hold the ends together. That's the main function. It won't go inside your anastomotic site. It's very thick.
Nice presentation.
Hello, Amit?
Yes, sir. Yes, sir.
Hello, Rathod this side.
Hello, sir.
Hello. Last time we met in BIS meeting.
Yes, yes, sir.
Not my question. Actually, just a few things for the postgraduates that we prefer greater auricular nerve, but if the damage is, the demand is of more than 10 centimeter, then you should go for a sural nerve. Sural nerve is another alternative, and only thing you should remember is you have to reverse the direction of sural nerve when you put in the mastoid cavity. So always take precaution to tie one end of the sural nerve when you are taking and reverse it in the mastoid cavity. And as such, we have Dr. Amit has given very detailed, detailed, extensive presentation. And what we prefer a transmastoid exploration first. If it is not serving the purpose, then definitely go for a middle cranial fossa. As such, we have a lot of approaches like translabyrinthine, retrolabyrinthine, and a mixture of middle cranial fossa as well as the transmastoid approach. So depending on situation that what are you getting, because facial palsy may not be due to the infection origin only, it may be due to the involvement of acoustic neuroma, some malignancies may be there. So once you go for facial nerve, you should be ready for all these consequences. This is my just take one sort of comments. Thank you.
Right, sir. Sir, rightly said, sir. The thing is that middle cranial fossa approach has been advocated mainly for Bell's palsy because the site of involvement is mainly labyrinthine segment there. So if in Bell's palsy, if you are going for transmastoid approach, then the results which have been shown, they are relatively inferior than middle cranial fossa. Although versus no surgical treatment is also got equivocal. But when you compare these two approaches, then middle cranial fossa approach has got some better results in terms of facial recovery they have shown. But if it's a traumatic case, then definitely depending on the site of trauma, we have to choose an approach. And most of the post-operative cases, we just go for transmastoid only, because we know where the problem might have been there.
Ready for all these countries. Is it nice to just take one sort of comment? Like you said, sir. The thing is that middle towards skinny fossa approach has been advocated mainly for Bell's palsy, because the site of involvement is mainly ligament and tegmental. So you see, Bell's palsy, if you are going for transmastoid approach, then the results which have been shown,
I think it's there's a loop. It's what I said that's being repeated, if I'm not wrong.
But when you compare these two approaches, then middle cranial fossa approach has got some better results in terms of facial recovery. But if it's a traumatic case, then definitely, depending on the site of trauma, we have to choose an approach. And most of the post-operative cases, we just go for transmastoid only, because we know where the problem is.
Your voice is not clear, sir. We are not able to hear you properly.
I think it was a recorded thing from what I said. That's one being repeated.
Doctor. I don't know what is happening.
Dr. Taneja has to mute, actually.
Mr. Dinesh,
yeah, I am muted.
Problem.
Sir, now it is clear. I am muted. There are multiple speakers, so I have muted all.
You please mute Dr. Taneja also. Mute Dr. Taneja also.
I think now it's fine, sir.
Dr. Vikram, please mute yourself.
I'm here, sir.
Yes.
Dr. Ravi, you are muted.
Okay, so now we are back. I think there was a good discussion about the approach of decompression. So in Bell's palsy, the area of involvement is actually internal acoustic meatus. So that area can be reached only via middle cranial fossa approach. And the fish actually described middle cranial fossa approach for decompression of the internal acoustic meatus. But normally, routinely, we are not doing any decompression surgeries for Bell's palsy. And most of the patients are actually treated by steroids and conservative management. Any comments, Dr. Ishwar, you would like to give? And Dr. Amit?
No, sir, it's rightly, you said rightly. So the surgery for Bell's palsy is basically, there are certain groups who are promoting this surgery, but frankly speaking, the literature does not support. Most of the groups, they have got experience that whether to operate or not, it won't make much difference in the long run. So
right.
What I believe, at least for 1 year, you should give a trial of medical management rather than jumping for surgery.
Bell's palsy should be treated aggressively in the beginning so that the patient improves. It's a golden period to, if the patient has to improve, it will improve in the beginning only. It will show signs of improvement. So it has to be aggressive medical treatment.
Right, sir. Right. I think we can go to the next speaker. Since we are running short of time, we have skipped the lunch part. So we'll straight away go to the next speaker. Dr. Vasan, please.
So now we move on to the next lecture, approaches to the internal auditory meatus. So now I invite Dr. Vikram Vatwa, Senior Specialist at Department of ENT MAMC, for the next presentation. Dr. Vikram, please.
Dr. Vasan, I'm audible?
Yes, sir. Yes, sir.
Okay. Is the slide full screen?
Yeah, definitely.
Okay. Thank you. Thank you so much. Thank you, Dr. Ravi, for giving me this beautiful presentation. Actually, my presentation today would be on approaches to the internal acoustic meatus. And here we go. The internal acoustic meatus actually is a very intricate structure placed in the deep in the petrous part of the temporal bone. As we can understand, it's a very small, tiny structure holding on to very important vascular and neurovascular structures. As we see, it's an internal acoustic meatus is about 8 to 10 millimeters in length, and diameter is about 3 to 4 millimeters. The middle end of the internal acoustic meatus, which is called the porus acousticus, transmits the facial nerve, the nerve centimeters which joins the facial nerve inside the canal, then the vestibulocochlear nerve with the labyrinthine artery. These travel into this canal, which is very constricted space, and then they terminate into the part of the meatus which is called the fundus. This is the fundus area, and it goes into the vestibule from here. So this is a very intricate area which has to be, which is very tightly packed, and this communicates further with the cerebropontin angle here, right? So this is the cerebropontin angle, also called the cerebropontin cistern, which has this gamut of neurovascular structures. The cerebropontin angle or cistern basically has the lateral boundary of the petrous bone. Then there is the pons and the medulla on the medial side. The superior and the posterior part are by the cerebellum, and inferiorly is the arachnoid space with the lower cranial nerves 9, 10, 11, 12. As you can see, the pons here, which is transmitting the facial, the trigeminal nerve to the Meckel's cavia. This is the facial and the vestibulocochlear nerve going to the porus acousticus of the internal acoustic meatus and the lower cranial nerves here. Right. So these are two intricately related structures: the internal acoustic meatus and the CPA. So we'll be dealing with them together. The lesions, as you can see, are there whole gamut of lesions which are there in the internal acoustic meatus and the CPA. But importantly, if you look at the 80 to 90% of the lesions are vestibuloschwannomas, and if you add on to them meningiomas and the epidermolysis, they make up about 95% of the lesions. So my presentation will be basically pivoting around the vestibuloschwannoma as such, because that's the most common tumor we encounter. And through that, we will be understanding when and how to manage the cases. Vestibuloschwannoma basically is a neuroectodermal tumor, which is a benign tumor arising from the Schwann cells. And these Schwann cells basically there's a transition zone between the glands and the Schwann cells. It's called the Obersteiner-Rayleigh zone, where this occurs, and it arises both from the superior and inferior vestibular divisions of the vestibulocochlear nerve. It can be unilateral or bilateral, as we understand. Bilateral basically occurring in neurofibromatosis type 2 kind of conditions, occurring in 4th to 6th decade in unilateral, and 3rd decade in the third decade. So we have to understand there are various stages of the tumor, which has classifications have been given from time to time. Recently, which are being followed are the Coos classification and the SAMI's classification. The Coos classification says that the grade 1 is the small intracanalicular tumor. The grade 2 is a small intracanalicular tumor which protruding into the CPA. The grade 3 is the tumor with the CPA protrusion which is touching the brainstem but not displacing it. And 4th, there is displacement of the brainstem, right? Then the facial palsy grading. We already come across 2 gradings already in the last lecture, but this is very vital to understand. Both the gradings actually what we come across is not too complex for day-to-day handling. So we have come recently we are using this rough grading system, which was suggested by Matau et al, and it's been internationally accepted. So the grade 1 has normal movements, grade 2 has slight paralysis, grade 3 has frank paralysis with eye closure, Grade 4 has frank paralysis without eye closure. Grade 5 has almost complete paralysis with only slight movements. And grade 6 is total paralysis. So this is a very effective system which is being used, and it is quite collaborative with the disease process. Then hearing loss is also being quantified by for the diseases of this region as by the Gardner and Robertson grading system. It's accepted by the American Academy of Otolaryngology Gauss and Head Neck Surgeons. The grade A is has hearing loss of less than 30 dB between for frequencies 0.3 to 0.3 kilohertz to 3 kilohertz, 0.5 to 3 kilohertz, and with a speech discrimination score of more than 70%. Grade 2 has hearing losses between 30 to 50 with speech discrimination scores more than 50. C has hearing loss more than 50, discrimination score more than 50. And if you have a discrimination score less than 50, then it becomes a grade D. Then we come on to symptomatology. Symptomatology basically is because of the cranial nerve compression and involvement, or of the compression of the cerebellum or the brainstem, or the ensuing intracranial pressure increase. Right. So the most common symptom is the high-grade retrocochlear progressive hearing loss, which can be sudden types in 12 to 22% of cases. Tinnitus is definitely a feature, but it's not. It's rarely a only symptom of the disease. Vestibular symptoms are definitely there in 40 to 60% of the patients, and mind you, the headache is definitely a feature in this disease process. Then other cranial nerve involvement can cause facial nerve paralysis, trigeminal paresthesias, or the involvement of the 9th and 10th cranial nerve can cause palatal paresthesia, hoarseness of voice, and dysphagia, as you understand. The cerebral compression can also be there in stage 4 diseases, and there can be incoordination or dysarthria, and there can be gait ataxia. Brainstem compression can cause pyramidal weaknesses and nystagmus, and lastly, there can be contralateral nerve involvement also. So the aim is to give a better quality of life. I tell you about better quality of life because there's a whole gamut of modalities which can be offered to the patient. Which one is to be successful depends upon the surgeon, the doctor concerned, and the patient. So the management strategies are basically 3. Very important on the left side, you can see is the wait and scan policy or the wait and observation policy. It's very, very important for this tumor because it's being a benign tumor. We have to consider this as a very important modality. Second is the radiosurgery, and third is the microsurgery, as we will see that. So first is observation and scan. When do we do that? If we see that the tumors are very small in size and the growth rate is very less. It has been defined recently that the growth rate is less than 2.5 millimeters per annum, and the size of the tumors are small, then these patients are the ideal candidates which can be managed by observation and scan policy only. But if there is a sudden increase in size, or if it's a cystic variant of histiocytoma, these are the patients which will not be managed by observation and scan policy. They require a step-up treatment. A step-up treatment would mean a rate growth more than 2.5 mm per year and a size more than 3 centimeters. Then we come on to the topic of stereotactic radiation. It's a new, not a new technique which has been recently been propagated in the last 2 decades, and they have found the proponents have found the results are good. For these are basically suited for patients who have sizes of tumors less than 2.5, and there are 2 modalities which are available with us: the stereotactic radiosurgery, which has a single dose radiation, and a stereotactic radiotherapy. These are very precise. They utilize very precise localization of the disease and give a very high resolution collimated beam to the lesion, and the precision is as less than 1 millimeter. And the modalities which are there at present, first is the gamma knife, and second is the cyber knife. Gamma knife basically requires 4 screws to be put on the scalp to stabilize the head, and the cyber knife uses a kind of a mass to stabilize the head. Right, these are on the left is the gamma knife holding screws, and on the right is the cyber knife. So stereotactic radiation basically earlier used to give 16 grays of radiation, but they found out that if you had high rate of radiation, the hearing loss associated with the modality was quite high. So they reduced the dose. Any dose less than 12.5 given, especially if fractionated, achieves a better success rate with lesser complications of hearing loss. Hearing loss still exists, and about 40% of patients with stereotactic radiation land up with certain amount of hearing loss. Second, a very important thing to understand is that if you give a radiation to a patient, the tumor starts to shrink after 2 years of radiation. It's not instant result. So the results have to be evaluated after 2 years. Advantages of the technique are there are few rates of complications. It's ideal for old and comorbid patients. And thirdly, if the tumor size is less than 3 centimeters, these tumors respond very well to the stereotactic radiation. Now I'll come on to the surgical approaches to the internal and posterior meatus and the CP angle. As Marcioni said very rightly, if you see long-term results of radiosurgery, they are less available. Over decades, we see that they are less available, but they require very long-term follow-up. Especially in young patients who require radiosurgery today, who have a choice of radiosurgery today, we cannot exclude the possibility of reoperation tomorrow. And these kind of patients will have higher complications once they get operated at a later stage. So what we have classically is that we had 3 classical approaches. The first, the translabyrinthine approach. The second is retrosigmoid approach, and third is the middle cranial fossa approach. The fourth one is a new approach which has been added on by Marcioni et al. In 2017. It's an exciting thing to occur, and I will be talking about it later. Still, debates continue, which is the best approach for busbar tumors. We're going to decipher this in our talk. So objective of surgical management are we have to radically excise a tumor, though it is not always the case. We cannot usually always resect the entire tumor, especially at the porous approach figures. I will be telling it later. Second is the conservation of hearing, very, very important. Thirdly is the preservation of facial nerve function. And fourthly is that we preserve the neighboring neurovascular structures. If you understand in surgical management, it's a very challenging process, challenging surgery and technically difficult. So there is a gradual learning curve, and there has to be a team of doctors involving a neurologist and a neurosurgeon who are competent enough to handle the entire case. So if we see what approach to see will depend upon these factors, like the size of the tumor. Second, what is the extension of the tumor in the posterior meatus? Third is the preoperative hearing loss. And fourth, very important, is the surgeon's experience. And keeping in mind, when we choose an approach, what we are aiming at is to reduce our major complications of risk to the facial nerve, hearing loss postoperative balance, headache. Headache, mind you, is very, very important. With certain approaches, headache is as high as 70%, and it's more important as a morbidity than facial nerve function and CSF leak. So we have come on to the approaches as such. The first is translabyrinthine approach, first described by Pansay in 1904, which provides the most direct access to the internal posterior meatus and the CP angle. Indications are very precise that if you have a poor preoperative hearing and you have a large tumor, this is an ideal approach to take. Other advantages, if you summarize that, it can obviously take any. We can take out any size tumor. The facial nerve identification is earlier in case of in this technique, and preservation definitely is better. There is no cerebellar retraction or temporal lobe retraction, so no problems with that. And there, obviously, you do have a cerebellar retraction. There can be post-operative balance and instability disorders. Obviously, we as autologists, we understand this anatomy quite well. And we can use this approach for other conditions like the Meniere's disease, for vestibulonerectomy, where the patients are not responding to medical management or non-ablative treatments, or in case of internal posterior meatus stenosis. Mind you, all new thing is that we are able. Some proponents are saying that we are able to preserve the cochlear function in translabyrinthine approach, hereby preserving the hearing. So this is possible. So it's all not lost if you are saying about hearing losses. Steps in the surgery, we, as you see on the, we give a post-Olker incision. The incision is 2 centimeters to 3 centimeters behind the post-oblique groove and extends above the pinna. Then we go on to do a complete cortical mastodectomy, and we identify the facial nerve, and we delineate the sigmoid sinus. One, we have delineated a sigmoid sinus, then we delineate the superior petrosal sinus above, and Then we start drilling over the semicircular canals, and we drill out the interlabyrinthine and retrolabyrinthine cells. And then we open up the semicircular canals. Firstly, the lateral semicircular canal is opened up by, then subsequently the posterior semicircular canal, and then the superior semicircular canal is opened, but the ampulla is preserved. Once we do that, the vestibule is exposed, and once we have exposed the opened the vestibule, we are actually lateral to the interacoustic meatus. Once we are lateral to the interacoustic meatus, we create troughs, superior and inferior troughs above the interacoustic meatus, and slowly the bone over the interacoustic meatus is thinned out and finally removed. And okay, that is exposure that we do. And once we have once we have done that, the posterior fossa dura is exposed, and it's excised gently by a cautery, and the tumor is seen. As if you see the tumor, it's a debulk usually by suction or ultrasonic cavitator. And once we are doing the debulking, we have to decipher that the facial nerve is not damaged. Usually, the facial nerve overlies the tumor bulk, and here a nerve stimulator can be useful. Once the facial nerve is removed away from the tumor, then we go on to remove the tumor from the supravestibular nerves. And the pudendus acousticus, that is the area where the tumor tends to be a little fibrotically attached to the area, and sometimes you have to do a sharp dissection and take out the tumor. Maybe sometimes you can leave, you have to leave behind a millimeter or so, or some small volume of the tumor behind, just to save the nerve. So once you remove that, then the entire gamut of the CP angle is in view, and the defect is closed properly in layers by using a fascia lata, using a Surgicel, and preventing any kind of CSF leak which can occur postoperatively. The retrosigmoid approach, which is actually a workhorse for the neurosurgeons, was started first by Peter Crosse in 1903, and it basically provides a very good, adequate surgical exposure to the tumor of any size, and directly controls the vessel and nerves of the CP angle. And it also has an early identification of the intracanalicular part of the facial nerve and the vestibular nerves, thereby reducing complications. But there are disadvantages very specific, that it requires a cerebral retraction, and this can lead on to problems of postoperative balance or instability. And there is a problem of headaches because of retraction, and this is much more common with the retrosigmoid approach. The steps of surgery, here you can see the patient is put in a supine lateral position, the 3/4 lateral position, Parkman position, and or you can put the patient in a supine position with head turned away. And we can see that there is a S-shaped incision which is marked here. Then markings are made over the area of the sigmoid sinus and the transverse sinus, and the probable site of the craniotomy is marked here, and the foramen magnum is here marked here. So the sites are the boundaries of the entire area would be like the anteriorly would be the sigmoid sinus, the superiorly would be transverse sinus, inferiorly would be the foramen magnum. So once we've done the craniotomy, we expose the dura and we start lifting the U-shaped flap. You can see this, the dura has been excised here, and we start lifting the dural flap from the underlying brain tissue. You see that flap has been elevated here, and then the subarachnoid space is entered, and the CS is allowed to drain a bit, because once you do that, the brain tissue starts to fall back, and our dissection becomes much easier. Once we have done that, again, the tumor comes into our view. It's a large tumor, it directly comes into our view, and we have to debulk the tumor here. And as I already said, suction can be used, or we can use an ultrasonic aspirator to do it. Then we free the tumor from the inferior cranial nerves, lower cranial nerves, sorry, and then superiorly we free it from the the fifth nerve here. Once you've done that, the facial nerve comes under the view with the vestibulocochlear nerve. These are dissected off, or they are basically preserved from medial to lateral direction, and the tumor is pushed laterally. Once we've done that, we are on the petrous temporal bone, and the tumor would be somewhere here, lying here. And what we do is that we identify the tubercle line here. This is a tubercle line where the vertical fold of dura becomes flat on the petrous bone. This is the tubercle line which is identified. And just cephalic to this is the area of the internal acoustic meatus here. So this area is then drilled out by removing the bone superiorly, inferiorly, and posteriorly. And we slowly just remove this area of bone, and we have the internal acoustic meatus on our view, still covered with the dura. Then the dura over this area and the posterior cranial fossa is cut off, and we see the nerves in the seventh and eighth nerve with the anterior inferior cerebral artery. These are identified; they're dissected off from the tumor, and then we move towards the porous acousticus. Mind you, in this approach, as we are going from posterior to interior, the approach to the fundus becomes even more difficult, and a use of a 30-degree endoscope may be important. And important to say here would be that the cochlear nerve, which is part of the anterior part of the porous acousticus, lying in the anterior inferior quadrant, that is at more risk as compared to other approaches in this retrosigmoid approach. And once we have done that, hemostasis is achieved and the closure is done tightly, obviously, to prevent the CSF leak, which is a common complication which occurs with these approaches. Then we come on to the middle cranial fossa approach. Middle cranial fossa approach basically is done for small, predominantly intracanalicular osteoschwannomas, or for, as Dr. Amit Goyal was saying, that for decompression of the labyrinth and segment of the facial nerve, or for vestibular neurectomy, as I said, you can do it for Meniere's disease, patients who are not responsive to medical or non-ablative management, and in case of repair of the superior seven canal dehiscence. Limitations are you have to retract the temporal lobe. Once you do that, the patient is at risk of having postoperative seizures and speech disturbances. Actually has a very limited window to work in, as you will see. And so there can be difficulty in seeing the facial nerve because the facial nerve actually will come into the view. If you have a large tumor, that comes into the view between the surgeon and it's actually stretched out by the tumor sometimes. So it becomes difficult to exactly see the facial nerve sometimes with the restricted approach. And then obviously there is a limited view to this cerebropontin angle. It is not well tolerated by elderly patients, and because the dura becomes adherent to the tumor, so it's not actually done in elderly patients as such. How we do it? We put the patient in a supine position, and we put a sandbag on the contralateral shoulder. Just to try to make the head horizontal with the floor of the floor. Basically, with the floor, we have to make it parallel, and an incision is made from zygomatic arch just anterior to the superior temporal artery, and go vertically towards the vertex just above the superior temporal line. Right. So we land up here, and then we expose the site of craniotomy. The size of the craniotomy is about 4 centimeters. The site would be just above the internal acoustic meatus, 2/3 anterior or 1/3 posterior. This is the site of the craniotomy which is required. And once we've done the craniotomy, we start elevating the dura. And once we start elevating the dura, we encounter first the middle meningeal artery. This is the middle meningeal artery here. And then which will be entering, we find it entering into the foramen spinosum, and this has to be coagulated and or ligated. Then further elevation will expose the greater suprachial petrosal nerve. This has to be identified, very important landmark. And then further elevation will give us an accurate eminence, which is obviously produced by superior canal. So these are the landmarks which are to be seen once you've done the elevation of the dura. And then the retractors are placed. Once you place the retractors, the petrous bone is here, and the retractors are placed, and the dura is retracted by the retractors, and we have to be careful that it does not slip and cause the dural tears. Then we come on to the localization of the interlocutory meatus. Very important structure that I said was the greater superficial petrosal nerve. So this is a nerve here, so you can imagine the nerve is here, and the superior seminal canal is here. So there is an angle of 120 degrees between the two, and the bisecting the two would be the area of the interlocutory meatus. So this is the area where the interlocutory meatus will lie. So the drilling is done around this area. The bone is drilled medial to lateral direction, and we straightenize the IAC into 270 degree direction in the axis. And we don't go too laterally because that might endanger the cochlea and the superciliary canal. And the dura over the interlocutory meatus is opened, and the structures are identified, and the tumor is removed thereby, and the closure is done tightly to prevent CSF leaks. So if you summarize the approaches, the translabyrinthine approach and the retrosigmoid approach are useful for any kind of tumor size, but the middle cranial fossa is restricted for the intramedullary tumors only. The retrosigmoid approach potentially is more versatile corridor for most tumors, but has risk of post-operative headaches and CSF fistula, though it has been it's controversial still. Finally, the total labyrinthine approach is associated with hearing loss, and it's only suited for patients who have large tumors and who have a poor preoperative hearing. Then we come on to a very exciting new addition to these kind of approaches, which is totally ENT, and I'm quite excited about this approach. It was started, as we understand, endoscopes have been used in the CP angle and interlocutory meatus since 1907 for various combinations with retrosigmoid approach. It was Daniel Marchioni in 2017 who pioneered this exclusive endoscopic transcanal. Exclusive meaning exclusively using the endoscope. Transcanal meaning going transmeatal, and then going transporomontorial for finding the tumors into the interlocutory meatus. So the indications basically are if there is a documented radiological documentation of a small tumor in the interlocutory meatus, which is of a grading 1 on 2 on Clue's grading system, and who has a hearing loss of class D, with a class D means a severe to profound hearing loss. So this is an indication as of now for performing our exclusive endoscopic transcanal transporomontorial approach. So what are the boundaries? The boundaries are superiorly, we have this facial nerve here, the jugular bulb here, and the carotid artery here. So anteriorly would be the carotid artery, inferiorly would be the jugular bulb, and the facial nerve above. These are the photographs courtesy from an article from Daniel Marchioni. He basically has described this approach. He says that we go transcanal as we do for the endoscopic meningoplasty or tympanoplasty, and we raise a very large tympanoid flap. We elevate the tympanoid flap entirely, and then we see the structures inside, identify the malleus, incus, the facial nerve, tympanic segment, the first, second genu, the vertical part, the jugular bulb, the promontory here, and then we remove the malleus, the incus, as he has done here, and the stapes is remaining here, and he has identified the carotid artery here, bulge here, right? Then he goes on to drill the, he goes on to remove the stapes from here and drill out the lip of the lower lip of the stape, the whole window, and enlarges toward towards the vestibule, and once we have done that, we identify the spherical recess inside. Then the cochlea is also drilled away, and once we have done that, the spherical recess will lie just lateral to the interlocutory meatus. As we can see here, the interlocutory meatus opening, the fundal opening of the interlocutory meatus has been identified. Then a horseshoe-shaped kind of a bony trough is formed, and the entire length of interlocutory meatus is identified, and we can get the entire length exposed with the dural covering here. Then we remove the dural covering from the interlocutory meatus, and we see the tumor. The tumor is removed piecemeal from the interlocutory meatus. So this is a very fantastic photo from that article only, which gives us the inner view from that tumor removal site, and we have gone on to the CP angle or CP cistern, and we can see the fifth nerve here, the facial nerve here, and the ICA here. So this is actually absolutely wonderful photograph going in from the ear into the cerebropontine angle. Already, there are modifications to the ETA approach. There's a Korean group which has given the Moons et al. Modification. They are able to do a tympanoplasty, a complete tympanoplasty with it, meaning that actually they are keeping the tal canal wall intact and not drilling away any posterior superior canal wall to get an extra exposure. Drawbacks, as of now, yes, drawbacks to the approach are basically it's a very difficult approach to learn. Secondly, is that if you're using endoscope, you have a single hand, as Dr. Ravi was prescribing about the endoscopic approaches. And thirdly, is a problem of the heat. Heat is definitely a problem as we are dealing with neural structures. We don't want any heat trauma to the structures to occur, and these approaches definitely have to be irrigation has to be totally be done. So ETA approach definitely is in, and I'm quite excited that there will be further modifications and advancements, and we can go on to these grade 2 and grade 3 tumors also. Mashoni says that the cochlear implantation definitely is not a factor in such kind of patients because single-sided deafness usually is a controversial issue. He says that. And lastly, I want to conclude that the ordinary brainstem implants can definitely be implanted in all kind of patients who had gone through these procedures, who have performed hearing loss post-operatively. Thank you very much for giving me time and space.
Vasun is there? Anyway, Dr. Vikram, it was a very nice presentation, and I am very excited about this new approach which you told me. I mean, I have seen Dr. Marcioni demonstrating this transpromontorial approach to the internal acoustic meters, and it's a fantastic approach, and all done endoscopically. And you can remove small tumors of the internal acoustic meters via this endoscopic transpromontorial approach. Regarding the approaches to internal acoustic meters, is another approach which is basically called as MIRA, that is minimally invasive retrosigmoid approach. And in minimally invasive retrosigmoid approach, we are actually using endoscopes. So it's a small incision, minimally invasive technique, and basically you would introduce endoscope through the retrosigmoid approach to reach the area of internal acoustic meters and basically to visualize the structure there and to remove the tumor. It can also be used to treat this intractable vertigo cases or patients with facial twitching in which there is a loop of inferior cerebral artery around the neurovascular bundle. So you can put Teflon, etc., between the neurovascular bundle and the inferior cerebral artery to treat intractable vertigo and facial twitching. Right? So I think a nice presentation, Dr. Vikram. If we don't have any more questions, I don't see any questions on the chat box, so we can straight away go to the next speaker. Thank you very much.
Thank you, sir. Thank you so much.
Hello, everyone. For those of you just joining now, welcome to 9th ENT Update online program. Moving on to the next session, Management of Thyroid Nodule. I would like to invite Dr. Ashish Varghese, Professor and Head of Department, Christian Medical College, Ludhiana, for his talk on Management of Thyroid Nodule. Sir has a special interest in thyroid surgery. Sir, please.
Welcome, Dr. Ashish. Please unmute yourself.
Yeah, thank you, Dr. Ravi and team for the opportunity given to me to speak on a topic which is very close to me. And every time I go for a talk or present a talk, it's not only the delegates who are learning, I myself learn more new things in this field, because every day something or the other is, being added to this specialty. So management of thyroid nodule is the topic given to me. And my aim of this talk is to give you an overview on this, the management. So every thyroid nodule that we see must have a clinical diagnosis, an anatomical diagnosis, and a pathological, that is CAP. Every nodule must have this clinical diagnosis, an anatomical diagnosis, and a pathological diagnosis before you plan a management. And this clinical diagnosis, anatomical diagnosis, and pathological diagnosis is achieved by a good history, examination, and investigation. So the aim of my talk today is how to integrate the clinical evaluation with the thyroid function, the imaging. Mainly I would be talking on ultrasound, and in select cases, which are the select group of cases which would need additional investigation, and I would be talking on cytology. Cytology in those select patients who have pointers in the imaging which would need a cytological examination. I would also be talking very briefly about the anatomy and embryology for a safe and complete thyroidectomy. I'll be touching on steps of safe and complete thyroidectomy. So it's going to be a vast area that I'm going to cover. So let's see how much we can do in this time given. So if you are sitting in a ENT OPD or a clinic and you see a patient like this, what are the things that goes to your mind? An elderly old lady with a huge swelling in the region of the thyroid swelling, thyroid area, presenting with a sudden increase in the swelling, what comes to your mind? Or you may see a lady who is staring at you with a swelling in the region of thyroid. What is that goes in your mind? Or an elderly lady who comes to you with presbycusis and suddenly you notice a swelling in the region of thyroid. What would you do for these patients? Or you see a pregnant lady who suddenly notices the swelling which she had in front of the thyroid increasing in size, and it's an asymmetrical swelling. What goes in your mind? Or an elderly male patient who's never had a swelling in front of his neck suddenly notices a swelling which is rapidly increasing. So you may get these various clinical scenarios, and each one has different implication. So let's see how to work up this thyroid nodules or thyroid swelling. It's an extremely common problem. Majority of the thyroid swellings, they are benign, and it's more common in women because of the estrogen. And now recently with a lot of women post-menopausal taking hormone replacement therapy, there you get more thyroid nodules and increased size of the gland. Also with the increasing age, you see more thyroid swelling, especially in women. So the nodular goiter is commonly seen in the iodine deficient region. But a small word on that, our salt is iodized post-independence. So most of the areas are fairly covered, and we hardly have any area of iodine deficiency as far as the distribution of the cases are concerned. But what is happening is the iodine, how they are preserving, the container, if it is loosely, it's not tightened properly, or if it is, while cooking, if it is put early and it all evaporates while cooking. So that's a case where, you lose the iodine. If you see in your OPD, you have an ultrasound machine kept outside your OPD and you start doing scans for all the patients, 50% of the patients will have a, thyroid nodule, 50% of your OPD patients. That doesn't mean all need a thyroid surgery. All don't need thyroid surgery. Which are the select group of patients that would need a surgery? That's what we are going to see. So how do you get a clinical diagnosis? In clinical diagnosis, all you need to know is whether the patient is hypothyroid, hyperthyroid, or euthyroid. How do you check this? On history, weight gain in spite of loss of appetite. Okay, weight gain in spite of loss of appetite is a very good indicator for hypothyroidism. Or patient having weight loss in spite of increased appetite. Again, it tells you that patient is having hyperthyroidism. Constipation and diarrhea. Now, as ENT, we see lots of patients with sleep disorders. So here you can have hyperactivity, patient unable to sleep, difficulty in sleep, or patient may have excess sleep. Again, unable to sleep or hyperactivity is because seen in hyperthyroidism, and excess sleep would be seen in hypothyroidism. Protrusion of eyes, eye signs, and tremors or increased pulse rate. All these are pointers for hyperthyroidism. The second is anatomical diagnosis. So first was a clinical diagnosis. You need to get whether the patient is hypo, hyper, or euthyroid. And second is whether the patient has a multinodular, a solitary nodule, a retrosternal goiter, or a diffuse goiter. So ask the patient, when the patient saw the swelling first, was it on one side or both sides? Is it associated with breathing difficulty, dysphagia, change in voice, or cough? Ask patient whether the collar size has changed at any point. How do you palpate a thyroid nodule? Stand behind the patient and palpate for the cricoid cartilage and ask the patient to have a swallow. Okay. So what happens is, don't keep on asking him to repeatedly swallow. Give him a glass of water. Every time you want him to swallow, give him a glass of water. Ask him to swallow. And as the patient swallows, the thyroid would come and pulp of your finger. Okay. And you can, palpate for consistency, fixation of the mass to larynx or trachea. Check for the thyroid notch, anterior arch of the cricoid. Check for any tracheal deviation. Check for lymphadenopathy or any previous surgery. Every patient with thyroid swelling must have a vocal cord examination. Patient's voice may be normal in 3.5% of patients with a recurrent laryngeal nerve palsy. And this is more important if there is a recurrent laryngeal nerve palsy and you miss it on your examination, and the patient has a contralateral, the other side also getting paralyzed during your surgery, you would end up with a tracheostomy. So it's very important that these patients have an examination of the vocal cord. All patients with thyroid swelling must have a vocal cord examination. How does retrosternal goiter present? Why does the thyroid go retrosternally? Anteriorly, it has the strap muscles. It prevents the growth towards that. Medially, it has the trachea. Posteriorly, there is vertebra, and inferiorly there is no space. Nothing is there. So it's just the empty space. There is no obstruction there. So what happens with every deglutition and every time patient breathes because of the negative intrathoracic pressure, the thyroid gland would be sucked in, and the gravitational force. So all these forces together pulls the thyroid inferiorly where there is no obstruction to the gland. Now, check for obstructive symptoms. Ask the patient to do a simple Pemberton test, and patient would become breathless, and that would tell you that the thyroid is going retrosternally. Also try to palpate the lower end of the gland. If you can't palpate, you must perform a Pemberton sign, because that would tell you that the gland is gone posteriorly. Especially patients who have dysphagia and dyspnea, you must do a Pemberton sign to check for the retrosternal goiter. Okay, so I don't know if you can see this CT scan here. Okay, it's not showing up. So it was one of our patients who had a small tiny swelling in front of the thyroid, but he had a huge retrosternal component. So, every patient must have a, Pemberton evaluation done, especially if they have dyspnea and dysphagia, and evaluate for that. Next is a pathological diagnosis. Every thyroid nodule that you see, you must have at your end of examination and investigation, you must know, you must have an idea whether it's benign or malignant, clear cut. But sometimes it will be, a suspicious nodule. So thyroid swelling in a child, okay, have a high degree of suspicion of malignancy. Young female, not so. Swelling in a male, especially a new onset swelling, you would think in terms of a malignancy. Change in voice associated with a lateral neck swelling, okay, think in terms of a malignancy. Rapidly growing tumor, okay, rapidly growing thyroid swelling, again you would think in terms of a malignancy as compared to a slowly growing tumor. Painful thyroid swelling of recent onset, you would be thinking in terms of a thyroiditis. Consistency is very important. Hard consistency, okay, fixed to the surrounding structures, must have a laryngoscopy, goes without saying. Now, this is another important, feature which tells you it's malignancy. Swelling that does not move on swallowing. Swelling in the region of thyroid which does not move on swallowing means there is fixation of this swelling to the surrounding structures, and it would, point towards being a malignancy. Or recently we saw 2 days back tuberculosis of larynx. Again, it was fixed to the surrounding structures, not moving on deglutition, and ultrasound didn't show any features of malignancy. We did a true cut, it came out as tuberculosis. What are the red flag signs for a thyroid nodule? When you see a thyroid nodule with this red flag signs, have a high index of suspicion. Family history of patient who has a family history of thyroid cancer, patient who has had irradiation or exposure to high environmental radiation, child with a thyroid nodule, you need to disprove that it is not a thyroid cancer, especially if it is an asymmetrical thyroid swelling which is rapidly increasing. Patient having unexplained hoarseness or stridor associated with a goiter. Painless thyroid swelling enlarging rapidly over a few weeks. Again, have a high index of suspicion. Patient having palpable cervical lymphadenopathy. I said palpable cervical lymphadenopathy. You may see subcentimetric lymph nodes in patient with thyroid swelling in Hashimoto's thyroiditis. They may all be reactive lymph nodes. But if you have a palpable cervical lymphadenopathy, have a higher degree of suspicion that it may be a malignant. Insidious or persistent pain lasting for several weeks. So all these are, features of malignancy, suggestive of malignancy. Investigate these patients thoroughly and, rule out there is, rule in or rule out there is malignancy. So what are the investigations that you need to do to confirm your CAP, clinical diagnosis, anatomical diagnosis, and pathological? So in the thyroid function test, we do the basic test, that is of the 3 things that you are asked, in the most important would be TSH, because any little variation in T3 and T4 would have a massive change in the TSH. So that is the first thing that we want to do. Okay, so when you do a TSH, you can have 3 possibilities, and we ask for T4 and not T3. T3 is, it is very unstable, and the half-life is just few hours. So it depends on the availability of T3, and it keeps fluctuating throughout the day. So we don't do T3. What we do is a T4 and TSH. The first thing is TSH, and if we have some suspicion about hypo or hyper, we would add a T4 with it, free T4. Okay, so when you do a TSH, you can either have a raised TSH, or you can have a normal TSH or a suppressed TSH. Same with T4, you can have an increased T4, or you can have a reduced T4 or a normal range free T4. So with this, you can have 8 possible pathological combinations. Okay, so the 8 pathological possible combinations would be one, where TSH is increased and T4 is reduced, and we call this as primary hypothyroidism. Second is TSH is raised and free T4 is same. Okay, it's within the normal range, and we call this as a subclinical hypothyroidism. Or we can have a TSH which is reduced and T4 is increased. We call this as a primary hyperthyroidism. TSH is suppressed and T4 is within normal range. We call this as a subclinical hyperthyroidism. So with TSH and T4, you can get these 4 clinical conditions. Okay. Now, when you look at a TSH, it will give you some idea, whether I am dealing with a cancer or not. But it is not a sure shot. Just keep this data in the back of your mind. So if it is a suppressed TSH, the chance of malignancy is very less. As the TSH keeps going up, the chance of malignancy also increases. So therefore, a suppressed TSH, being it a malignant, is very less. Okay. The next investigation that we all do for a thyroid swelling is ultrasound. Now remember, here seeing this image, to have a thyroid cancer in a suppressed TSH is very rare. In a patient who has a suppressed TSH, the investigation that we do next is an isotope scan and not an ultrasound. We would do ultrasound if there is all those red flags. One of those red flags, if it is there, then we would go for ultrasound. But in a clear-cut suppressed disease with no red flag signs, you would go on to do a isotope scan in a suppressed TSH. So the next investigation is, like, patient is euthyroid or hypothyroid, not a suppressed TSH. The next investigation is an ultrasound machine. They say the ultrasound machine to a thyroid surgeon is similar to a stethoscope of a cardiologist. It's so important for every thyroid swelling who are, euthyroid or hypothyroid. They must have an ultrasound, and ultrasound has to be done by a person who has, interest in doing thyroid ultrasound, because you need to have information which would point towards the possible pathology. So what are we trying to do with the ultrasound? We would evaluate the size of the nodule, the number of the nodule, okay, which we would have, roughly seen on palpation. We would check for the cyst. If they are complex cyst, we would assess the contralateral lobe. Always look for the contralateral lobe when you are doing an ultrasound of the thyroid. Also assess the neck, okay, and ultrasound would facilitate the FNAC. Now here, let me tell you, assessing the lymph node in the central compartment with ultrasound is not very useful, because central compartment is paratracheal, carotid to carotid, and the central compartment, the tracheal air column, does not give clarity for the tiny nodes to be picked up in the paratracheal space. We'll talk how would you evaluate the paratracheal lymph node in thyroid disease. So when you order an ultrasound, what you would be seeing is whether it is a benign nodule or a malignant nodule or a follicular lesion. These are the features. So mainly you would be ultrasound would give you some idea whether you are dealing with a clear-cut benign nodule or a malignant or suspicious nodule. So purely cystic lesion, eggshell, gross, big calcification, all would tell you that it is most probably a benign nodule. Microcalcification, taller than wider, solid, hypoechoic nodules, those will be a malignant, towards a malignant, pathology. So whenever you get an ultrasound from a radiologist, ask them, when you fill the ultrasound form, write it there, please give us TIRADS report. Unless you ask for a TIRADS report, don't expect them to write a TIRADS report for you. Most of the time, if the ultrasonologist is not very well versed with thyroid, what he would do is he would say, there are multiple nodules in that you have already palpated with your finger. What you need to know is whether it is a benign, clear-cut, suspicious, or it's towards malignancy. Okay, So thyroid scoring, you must ask. Thyroid 1 means there is the ultrasound doesn't have any nodules. Thyroid 2 means there is a nodule and it is certainly a benign nodule. Thyroid 3 is, mostly benign. Thyroid 4, A, B, and C, you have undetermined nodules, suspicious and highly suspicious nodule. 5 and 6 are towards malignancy. So thyroids 1 and 2, if your sonologist is good, please don't put a needle into the thyroid. Okay, if your sonologist is good. 1 and 2 can be left on its own. Don't do anything. 1 doesn't have any nodule. It's a normal thyroid. And B is very confident that, it's a clear-cut benign. And always keep those things in your mind. The history and the examination also. Check for any red flag signs. If they are contradicting, go ahead with the further investigation. Okay, now what are the other imaging that you would need? CT scan, MRI, we don't routinely do it. We do it only in select group of patients. We would do in a retrosternal goiter. We would do when there is extrathyroidal extension. A word on extrathyroidal extension. When would you suspect on ultrasound that the patient may have an extrathyroidal extension? The nodules which are there in the thyroid, if the nodules are closer towards the capsule, think there is, extrathyroidal extension. Less than 1 centimeter, close to the nodule, capsule of the thyroid gland, think there is extrathyroidal extension and, ask for an imaging, either a CT or an MRI. Even if you give contrast, it doesn't matter because 6 to 8 weeks, you have to wait for your iodine TSH to rise. And by then the iodine would get washed off. Now, central group of lymph node, the mapping, CT scan is the imaging of choice because ultrasound may miss the central compartment lymph nodes. So you must, do imaging if you're suspecting malignancy. All malignancy patient must have a CT scan to not only check the central compartment, also to check the central viscera. When you see a nodule, is it close to the, tracheoesophageal groove or is it, close to the trachea? Is it involving the tracheal wall? All those things, details you would get when you do a, imaging, CT imaging to your ultrasound. Now, FDG PET is useful for follow-up patients with thyroid cancer, in select group, and it's not routinely done. So what is the action taken? Thyroids 1 and 2, I would say you don't need even a FNAC unless they are high-risk group and your sonologist has done a good job. Thyroids 3 and 4, you go for ultrasound-guided FNA. And thyroid 6 is obviously, it's a malignancy, so you have to go ahead with the surgery. So thyroids 3 to 5, you do a FNA with ultrasound guidance. You want to go exactly into that space where there is, the suspicious nodules. Okay. And if there are abnormal nodes, go into that and get the cells. Any follicular cells seen there in the lymph nodes, again would tell you that it is a malignancy. Okay. So here you can see the needle is been put in with the ultrasound guidance. Okay. So this tells you what are the various, thyroid staging and what is the cytology and what is the action to be taken when you see such a nodule. Okay. So when you have thyroids 1, we call it as, non-diagnostic, or if it on cytology it is non-diagnostic, we repeat after 6 months. Okay. Or some people tend to do within, 2 to 3 weeks also. Or you have a thyroids 2, and again it is non-diagnosed, non-neoplastic, clear cut. Then correlate with clinical findings. Thyroids 3, it's in cytology you may get a AUS, you do a diagnostic, and as it goes up, so 3, 4, and 5 you do a diagnostic lobectomy, and if it is involving both the lobes, you talk to the patient and then decide for a total also it may be needed. So whenever you are planning a diagnostic lobectomy, keep in mind, check the other lobe and take consent for a completion if it is a diagnostic lobectomy. Okay, if it is you're planning a total, then there is no problem. But keep the complications in mind and explain those things also to the patient, and the need for thyroxine replacement. And in select group of patients, they may need even calcium supplementation. Okay, so here is a thyroid nodule. You've done a thyroid function test, you've done an ultrasound and FNAC, you know it's malignant, clear cut, you go with a surgery. You think it, you get a report as follicular neoplasm or ATP of unknown significance. Again, you do a diagnostic, surgery, and take a consent for a completion. If the report is, it has poor histopathological features, you need to do a completion. Take consent upfront, or talk to the patient for a total upfront. Benign, you can watch. But in this benign group, also select group of patient, if it's a big goiter, for cosmetic reasons, they may want this thing. If sample is inadequate, or it needs to be having a repeat test. So managing a thyroid swelling, it's not only a surgeon's job alone. You need a good ultrasonologist to give you a good report, which is reliable. And you can say, my ultrasonologist is saying it's a clear-cut benign report, and you can wait. You need a good cytologist to back you up with a fine needle cytology. A nuclear medicine in select group of patients, or post surgery you would need them to be having iodine ablation, and an endocrine physician to help you with the some complex cases. This is the thyroidectomy checklist which we have in our place for every patient. We have this checklist so that these things happen on a default mode. So you can see here we get a TSH and free T4 and T3 also in some patients, and the other the ultrasound neck, FNAC, and all those things. So thyroidectomy is the standard procedure, total thyroidectomy. It's a safe, efficacious procedure with minimal complications, and it has improved outcomes. It's good for multinodular goiter. We do for Graves' disease or papillary thyroid cancer. And you have to be sure about the indications when you are doing this total, and explain to them. So let's see quickly the steps for thyroid surgery, starting with the marking of the incision. We do marking of the incision of the patient in a sitting position on the OT table. In fact, when the patient is walking in, we would see whether there are any prominent skin lines on the neck, anterior neck, so that you can match the incision on that. So we do in a sitting position with neck flexed, we mark the incision, and then only we position the patient and proceed with the markings of the neck other than the incision. So here you have the sternocleidomastoid on both sides, the thyroid notch, the sternal notch, and your incision would be somewhere in the just below the cricoid. If you keep the incision closer to the cricoid, you can get away with a small incision. You can get a good access to the superior pole on both the sides, and you can get a small incision. But be sure that you can do the complete thyroidectomy or a hemithyroidectomy easily with that incision. Incision should not be an ego issue. If you need good exposure, always increase the incision rather than struggling and giving complications. So once you give the incision, traction, counter traction is the rule there. You give a good traction to the flap, and the operating surgeon would be giving a counter traction. See that nice silky white plane and dissect in that area subplatismally. Midline platysma is absent, so you start dissection from the lateral, get the platysmal plane and elevate. It's a nice avascular plane. If you stray away from the plane, patient may have more bleeding. So it's very important that you stay close to that. The flaps are elevated superiorly till the thyroid notch. That is good enough. Or if you have a large nodule, you may need to have a larger exposure. And inferiorly, we go up to the suprasternal notch. And remember, splitting the midline is easy if you are close to the midline to the suprasternal notch, because both the muscles, the strap muscles, would be inserting in the suprasternal area, so that you can see that the linea, the midline raphe easily towards the lower end, and separating the midline becomes easy, especially if it's a large goiter where the midline is shifted away. So we do a capsular dissection. So as we start the capsular dissection, we need to identify the middle thyroid vein. Otherwise, when you are rotating the gland, you may avulse it. And remember, the middle thyroid vein gets drained directly into the internal jugular vein, and there would be a mess there. It's very important that we preserve the blood supply of the thyroid. The blood supply of the thyroid is mainly from the inferior thyroid vessels. So keep the inferior thyroid artery onto the gland and clip it. You can see here the inferior thyroid artery, the branches are dissected on the gland, so that the branches which are supplying to the parathyroid are intact to the parathyroid, and the parathyroid is dropped down from the gland into the paratracheal space. So it's very important to preserve the parathyroid, not only anatomically, but its physiological function also should be maintained. And that is only possible if the blood supply to the parathyroid is preserved. Recurrent laryngeal nerve hardly gets damaged, okay? But it's the parathyroids which causes patient a problem, long-term problem. And taking tablets, calcium tablets, 2 grams every 8th hour, and vitamin D3 is a very big task for the patient. So make sure that you preserve the parathyroid blood supply and preserve the glands. Consider each parathyroid as the last gland and preserve all 4. Actually, you need only 1 gland for the calcium hemostasis, but preserve all the 4 glands. So till the strap muscles, you can use your cautery. Beyond the strap muscles, don't use a unipolar cautery. And once you are rotating the gland, that's the most important area for dissection, because you have the parathyroid, both superior and inferior, and the recurrent laryngeal nerve, which is on the posterior surface. So spend most of your time on the posterior dissection, because that's the area where patient will know that you are a good surgeon, or you've given patient some problems. So as you rotate, you can see the superior parathyroid, inferior parathyroid very clearly in this, and the recurrent laryngeal nerve. Okay, so I trace usually recurrent laryngeal nerve at the laryngeal entry point, and I keep the capsule intact all over the nerve there. So encountering recurrent laryngeal nerve, the danger area for recurrent laryngeal nerve is the area of ligament of Berry, where it would be very close to the nerve. So be careful as you're dissecting there. Tracheoesophageal groove, it can be seen, but damage is mostly seen close to the ligament of Berry. Don't be careful when you're retracting the stretching the gland. When you're trying to see the posterior surface of the gland, your assistant over enthusiastic retraction can cause traction injuries to the recurrent laryngeal nerve, and patient can have a temporary paralysis of the recurrent laryngeal nerve. Every patient who has a normal recurrent laryngeal nerve pre-op you must make every effort to preserve the nerve. Post-op also it should be preserved. A paralyzed recurrent laryngeal nerve on one side, and the other side, if it's normal, operate the normal side first, so that when you are starting the surgery, you are fresh. You can make all your efforts to preserve the normal side first, and then go to the paralyzed side. Okay, here again you can see the recurrent laryngeal nerve, and as it's entering into the laryngeal entry point, the cricopharyngeus muscles, you can see there. Okay, this is for your Viva question. So there are 2 nerves. We all know that recurrent laryngeal nerve and the external branch of superior laryngeal nerve. There is one more nerve, which the examiner may ask you just to confuse whether you know the thyroid properly, is SILAB. That is sympathetic inferior laryngeal anastomotic branch. What is this? This is a connection between the cervical sympathetic ganglia with the recurrent laryngeal nerve. SILAB is sometimes missed as a non-recurrent laryngeal nerve and it may be at risk of getting injured. So this is a picture taken from Randall's book, Surgery of Thyroid and Parathyroid, and you can see the cervical sympathetic chain and the anastomotic branch, which is appearing like a non-recurrent laryngeal nerve there. Okay, so the next nerve is the nerve for the singers. Okay, because this is the nerve which gives the pitch and the tenor to the voice. Okay, so it's very important that you preserve this nerve. Very tiny nerve seen at the superior pole of the tonsils. So what you can do to preserve this nerve is identify the blood superior pole and dissect, skeletonize those vessels, tiny vessels, and ligate it onto the superior pole, close to the gland, so that you don't injure the external branch of superior laryngeal nerve. You can see here it entering into the cricothyroid muscle. Okay, so this nerve is very thin, like a fine thread. Be careful, you identify this, and don't do mass ligation of all the vessels together. Skeletonize those vessels, let it go to the gland, tie it close to the gland, so that you preserve the the external branch of superior laryngeal nerve. And also sometimes you have some anastomotic branches going to the parathyroid, posterior circulating branches to the parathyroid from the superior thyroid artery also. Okay, so you can have these three variations. Sarnia had given these three classic types. One is it's quite far away from the superior pole. The type 2A is close to the upper pole, and 2B is on the gland. So always you can see what you need to do is clip this. Can you see this pointer moving there? Clip onto this the tiny vessels, the branches close to the gland, so that you never even if it is a 2B on the gland, you have not taken the nerve in your ligature. Okay, so briefly about the the embryology and anatomy of this. So you can see here the foramen cecum, and the gland would be descending, and you can see sometimes a thyroglossal cyst here, or migrating below the hyoid bone, or you can see a long pyramidal bone. It's pyramidal lobe. It's all important that you remove the entire remnant of the thyroid gland. Otherwise, these patients go for an iodine ablation, you would be seeing this thyroid tissue in the scan there. Tubercle of Zuckerkandl is another important landmark, which is good for identifying the recurrent also, and make sure that this thing is completely removed, especially in patients with Graves' disease. You leave behind this tissue, and patient may have a recurrence of the symptoms. Thyrothymic rest is another area which needs to be addressed. As it may be, you may have a protrusion just from the gland, or you may have it as a bridge, tiny bridge connecting both, or it may be a disconnected one. So check for thyrothymic rest in the lower pole always, and if it is present, remove it. We discussed about the tubercle of Zuckerkandl. The most of the time, tubercle of Zuckerkandl, it usually enlarges lateral to the recurrent laryngeal nerve, and the recurrent laryngeal nerve is medial. It's a safe, that is the safe thing. But sometimes, in rare cases, you may have the opposite. That means recurrent laryngeal nerve is lateral to the tubercle. At that point, the nerve can get injured, and be careful, to identify the nerve properly and preserve it and dissect out the tubercle from the nerve. Now, parathyroid preservation, I said, as we were, I was showing the posterior dissection, the blood supply to the parathyroid is the most important thing. The unrecognized ischemia or thrombosis, of the parathyroid will cause it, will give a devitalized parathyroid. So it's important that the blood supply is preserved, and every effort is made to preserve that. Look for any change in color of the gland. And if you see there is a change in color, remove that gland, confirm it, put it in a saline, and see whether it is floating or it's sinking. And if you are dealing with a malignancy, make sure it's not a lymph node. Send for a small frozen, from there, and you can auto transplant it once you are sure that it's not a malignant node that you are auto transplanting back. So if the parathyroid becomes bluish, take a 11 number blade and just give a small nick. If there is a hematoma, it would just come out, and the parathyroid would get back its color. That's called as a knife test. Okay. Right. So these are some of the pictures where you can see the recurrent laryngeal nerve, the trachea, the laryngeal entry point. So here you can see the preserved parathyroid there. and this nerve entering into the larynx. And again, the recurrent laryngeal nerve, parathyroids, preserved both. Always make sure that, once you drop the parathyroid down, look where exactly it is there and see for any change in color. Okay, here you can see the recurrent laryngeal nerve getting branching as it is entering into the laryngeal entry point. Make sure sometimes you may have more than one nerve, and make sure that you don't ligate any of those nerve branches. And don't think that I identified one branch that is good enough. You may have branching also, so be careful. Here you can see the common carotid, recurrent, the trachea, and it's entering inside the nerve. So closure of always leave a weeping window. Don't close the strap muscles tightly. Leave some, leave the lower part of the strap muscles open, and the top one also you can just approximate very loosely, so that in case of a bleeding, it comes down. And when you are closing the strap muscles, remove the shoulder roll. If there is some vessel, which was, not bleeding because of a stretched strap muscles, on, removal of the shoulder roll, it may start bleeding, and you can pick up and you can seal those vessels before you close the wound fully. Do a head low position and ask the anesthetist to do a Valsalva also. So any tiny bleeders which are there, it would all open up in a head low and Valsalva, anesthetic Valsalva, those vessels would bleed. Let it bleed when you are closing the wound. Close those, seal those vessels, and then go ahead and, close the wound completely. Close the, skin with a monofilament so that they don't have to come for suture removal. So again, coming back to this old lady, she had a long-standing multinodular goiter which had turned malignant and it was growing fast. She was a Graves lady. We made her euthyroid with medication, and we went ahead and did a total thyroidectomy for her. She's an old lady who came with presbycusis. We said, you lived with this and it doesn't give you any compressive symptoms. Leave it alone. We didn't go ahead with anything. Thank you very much for your attention. And if there are any questions, I'll be happy to answer.
Thank you, sir. I'm sure that our delegates have benefited a lot from this session. I would like to invite comments or questions from the faculty now.
Ashish.
Yes, sir.
Very well presented. In your initial workup, you said there is no need to work up T3, but in your protocol, you said...
yeah, that was an old this thing. We don't do it. We don't do it. That was an old one.
It was mentioned there.
Yeah, it was mentioned. Yeah, that was an old this thing. We don't do that. We don't do. We just see the T3 is, within 7 to 8 hours, there is a turnaround. And it keeps fluctuating. T4 is a more stable, it's a storage form of the, hormone. So when you do a T4, it gives you a more, accurate function. Yeah.
Dr. Ashish. Dr. Ashish.
Yes, Dr. Ravi.
There is one question from Dr. Anand from Sonipat. He is asking about the management protocol according to isotope scan. So
okay, so yeah. This is a very important question. Thank you. Yeah, I know, Dr. Anand. Thank you for that. Yeah. Thank you for that question. And it's very important. There is no role of isotope scan. We don't look for cold and hot nodules anymore, except in patients who are hyperthyroid, where we want to see whether it's a solitary thyroid nodule or it's the entire gland which is lightening up in the when you do isotope scan. That's the only indication. If the patient has a suppressed TSH, patient is hyperthyroid, only you do isotope scan. Otherwise, we don't do routinely. And one more condition, let me add. If the patient, you're suspecting a thyroglossal cyst and you can't see a thyroid gland, you would go ahead and do an isotope scan to check for any lingual thyroid there. Okay, so those are the only two indications for isotope scan. Otherwise, please don't send any patient for isotope scan. Ultrasound is the workhorse for thyroid gland.
Right, absolutely correct. So this is a very important point which has been brought by Dr. Ashish, that there is no much role of thyroid scan nowadays. And another indication which I think for this scan is the systemic scan for parathyroid adenomas.
Yes, localization.
Localization of parathyroid adenomas, it might be sometimes very difficult by ultrasound. And
Yes.
even you can have ectopic parathyroid adenomas in mediastinum and in the other part of the neck.
Yes,
So
very true.
those cases, scan is advisable. Otherwise, routine use of thyroid scan is not
Absolutely,
needed now.
absolutely. That was thing
Thank you
of the
very much.
past when we didn't have ultrasound as a robust, tool to evaluate the thyroid nodule. So it should be
Right,
TSH, yeah, TSH, euthyroid or hypo goes for ultrasound. Hyper would go for isotope scan. Okay, thank you.
Right. So I think after nice interactive session, we move ahead to the next talk because we are running short of time. Yes, Dr.
No,
Ishwar,
go
you
ahead,
want
go
to
ahead.
say something?
Sorry?
And we go to the next talk, Dr. Riaz.
Thank you, sir, once again. Moving on to the next session, angiofibroma. I would like to invite Dr. Ripudaman Arora to enlighten us on this topic. He is assistant professor at ENT Raipur. Sir has special interest in endoscopic nasal surgery. Sir, please.
हो गई थी और फिर मैंने इसको उसका बायोडाटा भी दिया हो गई थी
Very good afternoon, sir. Am I audible?
Yes, Dr. Ripudaman, you are audible.
Sir, I am trying to share the screen. Is it visible? My share screen?
Make it full screen, please.
Now it's clear, sir?
Yes, absolutely correct.
Very good afternoon, sir. So greetings from AIMS Raipur. My topic for presentation is today juvenile nasopharyngeal angiofibroma. Sir, first of all, I would like to congratulate all the team of Maulana Azad Medical College for continuing their tradition of this annual event. And my special thanks to Dr. Ravi Meher, sir, for giving me an opportunity. Thank you, sir. Today, objective of my class is when a postgraduate appears for an exam, you should have a general idea about how to write about the juvenile nasopharyngeal angiofibroma. It's going to be a question or short question, long question, or maybe some MCQ on it. Second important point is when a patient walks in an OPD with an angiofibroma, they should be able to diagnose it, order a good investigations on it, and hopefully to get a diagnosis because we are not going for biopsy. And the third point is when we are and they're deciding about the surgery, they should have an idea which approach to be taken for surgery. So these are the topics I will be covering under, I will be using my headings. So I have, sir, make it little simplified this time. First, I will be asking a question, then explaining it, then coming to the answer. The first thing is nasopharyngeal angiofibroma is also known by the following names except. So JNA, juvenile angiofibroma, bleeding fibroma of the adolescence, granulomatous angiofibromatosis, and fibroangioma. So these are the synonyms: nasopharyngeal fibroma, bleeding fibroma of the adolescence, fibroangioma, juvenile basal fibroma, basal fibroids, myxofibroma, and fibroma of the nasopharynx. Hippocrates first described the tumor in 5th century, but Fredberg first gave the term the angiofibroma. So going back to my question, the answer of the question is granulomatous angiofibromatosis. So the point is such MCQs can come. This is the old MCQ from 1990, some exam from the All India exam. So overview of the condition. It is the most common benign neoplasm of the nasopharynx, seen almost exclusively in male adolescents. Histologically benign, locally aggressive, non-capsulated, vasoformative neoplasm. Although it is locally aggressive and has a high recurrence rate, Up to 0.5% of the head and neck tumors are angiofibromas. Reported incidence varies from 1 in 5,000 to 1 in 60,000 in the otolaryngology patients. And the commonest age is the second decade of life, between 7 to 19 years of age. Although it's rare after 25 years of age, but it is still known in the extremities, both extremes of age, it has been seen. Now, next the question may come like, what are the various theories of origin of angiofibroma or the suggested tissue of origin for the nasopharyngeal fibroma? So there are various theories proposed. The few common ones are, as the Ringer said, always arose from the periosteum of the skull base. Ganesh, has Emming said, it's an embryonic fibrocartilage between the basi occiput and the basi sphenoid. Brenner gave a theory of its arise from the conjoint pharyngobasilar and the buccopharyngeal fascia, while Martin said it's because of deficiency of the androgen or overactivity of estrogens. Sternberg believed it's a hematoma, and Osborne again gave a theory of hematomatous origin, while Kirky and Fehmi believes it's a type of paraganglioma because of its pathological histology. And then Mollis and Morris gave a origin from the midline erectile tissue and androgen dependent hematoma. So among these lot of theories, there are two things which are clear. It's a vascular origin, which is androgen dependent, and thirdly, there is something related to the base of skull, periosteum is associated with it. Now coming to the tissue of origin, again Vernon and Benesch believes it's arise from the embryonic cartilage, fibrocartilage at the base of skull, while Connor believes it arises from the, it's a tumor, is a fibroma is a tumor of bone in which the chondrocranium forms the matrix. Ringers believes it arises from the ventral periosteum of the skull. By Somm and Nefson give a theory of inequality of growth of the skull bone, the periosteum became unable to produce normal bone, and hypertrophy is in response to the increased endocrine activity. Hicks believes a remnant of craniopharyngeal duct that may be the origin of tumor, while Werner thinks a tumor arises from the facial basilis, which is formed by the fusion of pharyngeal aponeurosis and buccopharyngeal fascia at the base of skull. So as I go back to my question, what are the various theories we have explained? And the suggested tissue of origin, it can be from the periosteum of the nasopharyngeal wall or from the conjoined pharyngobasilar and buccopharyngeal fascia or the embryonic fibrocartilage. So answer is all of the above for the same. Now coming to the pathology of the tumor, grossly it's a well circumscribed lobulated purple red mass covered by the intact mucosa on their nasopharyngeal surface, and cut surface shows the fibrous appearance, often with the blood vessels on it. Histologically, there are two main components: a fibrous stroma consisting of a spindle cell or stellate-shaped cells in a dense collagen matrix, and rich network of irregular shaped blood vessels. Myofibroblast cell is the cell of origin. There is a presence of zelbelin cells which are seen, that again indicates it may be something related to the paragangliomas. Pseudocapsule of fibrous tissue, or it's not a very well capsulated tumor. And blood vessels lack a complete muscular layer, which explain why there is a lot of there's a high grade of epistaxis in that. So what are the various growth factors associated with the JNA? This incidence is higher seen in the familial adenomatous polyposis. So there may be a suggestion of the adenomatous polyposis coli as a marker. Then there is a more increased factors of transmembrane growth factor beta 1 and insulin-like growth factor 2 has also been detected in JNA. Then other expression may be of beta catenin, c-KIT, and NGF are higher or more frequent seen in stromal cells. So now coming to the origin of the tumor. What is the commonest site of origin? Now we all know that it arises from the region of sphenopalatine foramen. What about this? From which part of sphenopalatine foramen it arises? We will discuss it in the due course. It arises from the posterolateral wall of the nasal cavity in the nasopharynx. Superior margin of the sphenopalatine foramen is the site of origin. At the junction of the palatine bones, vomer and the sphenoid bone is the origin of the tumor. Why origin is so important? It determines the pattern of tumor spread and influences the decision making for the surgical access. So going back to my second question, from which part of sphenopalatine foramen, primarily nasopharyngeal angiofibroma arises? So it arises from the upper end of the vertical plate of the palatine bones at the trijunction of palatine bones, horizontal ala of vomer bone and root of alveolar plate. Now coming to the blood supply of nasopharyngeal fibroma. The main contribution comes from the internal maxillary artery, which is a branch of external carotid and ascending pharyngeal arteries. Contralateral supply comes from the ascending palatine or terminal branch of maxillary artery. If it's a GNA has extended to orbit, it takes its supply from the posterior ethmoidal artery also. And if it goes intracranial, the internal carotid also give branches via the dural branch and the cavernous branch. So main supply is external carotid, internal maxillary artery and ascending pharyngeal. If it goes intracranial, then comes in picture is the dural branch and cavernous branch of ICA. Now coming to the very important question, what are the various routes of spread of GNA intracranially? As we know, the site of origin around the sphenopalatine, superior part of sphenopalatine foramen. So it is directly, easily spread to the nasopharynx, nasal cavity, goes down into oropharynx, or comes to one of the sinuses, sphenoid or ethmoid sinuses. So this is the first route of spread. If it is there, the tumor usually lies in stage 1 of the first stage. Now if the tumor starts extending laterally, it goes into pterygopalatine fossa, inferior orbital fissure. From there it can go to orbit, or from the pterygopalatine fossa it may lead to the pterygomaxillary fissure. It may reach to infratemporal fossa and present as a cheek swelling. It's a lateral part of it which comes into fist type 3 staging. It may reach to the pharynx or anterior to the vertebrae via the sinus of Morgane also. Now how it comes to the cheek? It can usually come via the infratemporal fossa, eroding the lateral wall of maxilla or around the pterygoid plates. Now, intracranial spread of tumor is very important. It goes into anterior cranial fossa as well as middle cranial fossa via different routes. It erodes the pterygoid plates, which is the pterygopalatine fossa, infratemporal fossa. Beneath the zygoma, it may reach to middle cranial fossa. Or it may go to inferior orbital fissure, superior orbital fissure. From there, it can reach to middle cranial fossa. The difference is here it lies lateral to the internal carotid artery and cavernous sinus, which is important because it decides your approach to the tumor in due course. While from the roof of sphenoid, it can go to the medial to the internal carotid artery and lateral to the pituitary gland. Direct extension along with through the horizontal lamina of ethmoids and lamina is also seen, but which is rare. And through the foramen lacerum, again it can reach to middle cranial fossa. So this is the route of spread we have to through the origin. Now coming to the diagnosis. Now suppose a 14-year-old boy comes present with a recurrent epistaxis to EROPD with a nasal obstruction and chronic anemia. What is your possible diagnosis? So among this, we easily point out it can be a nasopharyngeal fibroma. Now why? These are the various differential diagnoses: nasal polyp, centroconal polyp, teratoma, encephalocele, dermoids, inverted papilloma, rhabdomyosarcoma, squamous cell carcinoma, so forth and so on. So when we are diagnosing a case of nasopharyngeal angiofibroma, the history is very important. Physical examination followed by it, then a good radiological investigation will lead to it. It's almost always seen exclusively in males. If it is seen in females, as the few case reports suggest, we should go for chromosomal studies in these patients. Age incidence is usually in the second decade of life, most commonly seen in the 17 to 19 years of age. But as I said earlier, it is seen in extremes of age also. So when a teenage or young adult male is commonly seen, recurrent epistaxis and nasal obstruction are the commonest symptoms in almost 80% of the cases. Another symptoms are nasal discharge, proptosis, decreased vision, headache, earache, difficulty in swallowing because of intracranial nerve involvement, swollen cheek because of infratemporal fossa involvement, cranial nerve paralysis because of skull base involvement, swollen nose, maybe Frogner's deformity, hemiparesis, conductive hearing loss because of eustachian tube dysfunction, and rhinolalia, hypoxia, and anosmia. Now, this picture we see is a patient with a mustache. It's a patient of age 29 years. This is the case of recurrent GNA. We have operated here. Already somebody has done orbital exentration, already operated 3 times. Patient was 29 years, and when we operated, it came out fibroma. Now, what is the appearance of the tumor? It's a smooth, lobulated mass in the nasopharynx or the little nasal wall. When we see through the nasal endoscopy, it's a pale, pulpish, red gray or beefy red color, which is compressible, and it bleeds on touch. So diagnostic nasal endoscopy is an important finding which gives an impression of angiofibroma. So biopsy is almost always contraindicated. For postgraduates, it's not recommended. But still, if there is a confusion, it can be done under the guided circumstances in an operation theatre. So investigation of choice, if it comes, it's a contrast enhanced CT scan. MRI is a useful investigation for intracranial extension, orbital extension, infratemporal fossa extension. Carotid angiography with embolization is again a pre-surgical thing if the facilities are available. Now coming to a contrast enhanced CT scan science. Science which we see can see in the JNE. The commonest find in books is the Holman-Miller sign. What is it exactly? It can be seen on even simple X-ray or a contrast enhanced CT scan. Whenever there is a tumor pushes the posterior wall of the maxillary, posterolateral wall of maxillary sinus, it gives a bulge. This is a sign which is known as Holman-Miller sign. Another is Handose sign. What is it exactly? It's the widening of the sphenoidema, widening of the foramina because of gap between the ramus of mandible and maxillary body occurs. Then there is a Ram-Heron sign. It is a quadrilateral appearance of pterygoid wedge. Then a chopstick sign. It is in the post-op appearance of the medial and lateral pterygoid laid as two separate sticks due to drilling and removal of the pterygoid wedge. So there are four signs we see in the on the CT scan. So exactly what we have to look for when we are getting a contrast enhanced CT scan, because we are not going to for a biopsy. It's a clinical as well as radiological diagnosis which we have to believe. We have to look for the erosion of the root of medial pterygoid, widening of the pterygopalatine fossa, widening of the sphenopalatine foramina, erosion of the hard palate, erosion of the medial wall of maxillary sinus, nasopharyngeal mass, condition of the widening of the median canal, erosion of the medial wall of maxillary sinus, displacement of septum, and intracranial intraorbital extension we have to look in the CT scans. Now, what is the role of MRI? If we have facilities, always go for a good contrast enhanced CT scan along with the MRI. It gives a useful information, especially an extension into orbit, intracranial component, and the infratemporal fossa extension. And it gives a good picture of involvement of the cavernous sinus as well as. And on MRI, we should be able to differentiate a tumor from the secretion as well. Now coming to the role of carotid angiogram in nasopharyngeal fibroma. It's always what do we do is a 4-vessel distress subsection angiography with or without embolization. Indications are, it gives us about the feeding vessels, would give diagnosis, intracranial extension and the supply of the intracranial tumor part. We can have a therapeutic embolization as well as to find the coexistent vascular malformations. Commonest feeding vessels is internal maxillary artery. In a large tumor, we can have a ascending phalangeal artery supply, contralateral ECA branches and branches from the internal carotid artery, especially in the extension from intracranial extensions. Coming to the embolization, it should be planned 48 to 72 hours before surgery to avoid any revascularization and should be done under a DSA guidance. Advantages being reduction in the blood supply, blood loss, less operative time, and improved visualization of the tumor margins. Disadvantages being the kind of complication patient can have, like a neurological complication of stroke, cranioparesis, blindness, recurrence rates are high, the tumor becomes tribal, and obscure tumor from fronts and cracks and crevices. Now there are two types of embolization. One is transarterial embolization directly, which is done through the transfemoral route. Another is the direct percutaneous embolization, which solidifies slowly and infiltrates vessels with excellent penetration of parenchyma. In our setup, we are always going for the transarterial embolization with a PVA. So what are the various staging systems used in a JNA? The few systems are Andrew staging, Chandler staging, Session staging, Onsay, and few Indian stagings like PGI and Janki Ram et al. Given their stagings. But the commonly used stagings are Brodesky staging and the Fish staging, which I will be covering. In this staging, it's always difficult to remember when we see about the staging. When we go from up to down, it's always increase in the tumor goes either from central to the lateral or intracranial extension. Like tumor is limited to the nose or nasopharynx. If it extends one of the sinuses, become one. Stage 2, if there is a minimal extension to the pterygopalatine fossa, then again if it goes to a complete occlusion, it becomes 2B. If it reaches to infratemporal fossa, it's 2C. The first two stages are enabled by the endoscopic excision is possible. While for the 3A and 3B, it requires a lot of skills. In 3A, it's an erosion of the skull base, while in 3B, it's an erosion of skull base with intracranial extension with or without cavernous sinus involvement. Now coming to the fifth staging, which is more acceptable. Stage one is when tumor is limited to the sphenopalatine foramina. Stage 2 is when from sphenopalatine foramina to extend one of the sinuses along with the bone erosion. Stage 3A is without intracranial involvement, extension to the infratemporal fossa or orbit. Stage 3B is with intracranial extradural involvement. In stage 4 in A, it's the involvement of the cavernous sinus, pituitary fossa or optic chiasma without infiltration, while in B, there's an infiltration of cavernous sinus, pituitary fossa and optic chiasma. So now coming to the important part, that is treatment. Surgery is the treatment of choice. The other option we have radiotherapy, hormonal therapy and chemotherapy. Earlier there was a concept of spontaneous regression which was controversial. So current concept is there is no spontaneous regression and no postponing of surgery to wait for spontaneous regression. So next we will be dealing with the surgery. Coming to the basics or principles of JNS surgery. Always analyze your scans well, especially your coronal CT thoroughly and plan your approach. JNA may be resected by endoscopic, open or a combined endoscopic as well as open technique. It depends on many other things which I will discuss in due course. There should always be the adequate tumor exposure. Don't touch the tumor until feeding vessels are controlled, and drilling of the pterygoid wedges must. What is the common approach for surgery for nasopharyngeal angiofibroma? Is it a transpalatal, transcentral, transpalatal along with the lateral rhinotomy, transpalatal and transzygomatic, lateral rhinotomy only, or endoscopic approach? This is very important question. I will come back after discussion of the approaches. Continuing with the principles of JNS surgery, always complete your bony work first. Ensure a good access to the tumor before attempting the resection. Because once bleeding is encountered, the surgery may become very difficult and hazardous, and hemostasis may only be possible only after completing the tumor dissection. In young patients, avoid excess soft tissue dissection and bone dissection of the midface to minimize the risk of causing growth abnormalities. Coming to the anesthetic concentration, position is the reverse Tendelberg position. A good hypotensive general anesthesia. Please maintain a BP around 60 to 70 millimeter of mercury. And always arrange 5 to 6 units of sufficient blood and keep at least 2 units in your OR. Continuing with the surgical approaches, we can have an endoscopic approach or open approach. The surgery depends on the approach, it depends on the location of the tumor, pattern of the vascular supply, effectiveness of the embolization if done, facial skeletal maturity, and experience of the surgical team. So now these are the various approaches we have seen. Approaches can be divided into 3 parts. One is endoscopic approach, another is inferior approach, anterior approach, and the lateral approach. Other than the endoscopic approach, it can be a transpalatal or transpalatal with a soft transpharyngeal as well as a lip or involvement. This is inferior approach, transpalatal, which is only good for the tumors limited to the nasopharynx. Now coming to the anterior approach like lateral rhinotomy, facial translocation, infratemporal fossa with or without craniotomy. These are all anterior approaches or anterior lateral approaches they are called. Or sometimes we go for lateral approach for like preauricular or preauricular subtemporal approaches also. So I will be mainly dealing with the endoscopic approach association with the lateral rhinotomy approach in this, and what are the indication for different approaches. So if tumor is limited to the nose and nasopharynx, either we can go by endoscopic approach or transpalatal approach. If tumor is limited to the nasopharynx, maxillary antrum or pterygopalatine fossa, which is kind of a fish 2, we can go with the lateral rhinotomy along with the medial maxillotomy, endoscopic approach, or Lefort 1. If there is an extension association with these to the infratemporal fossa, we can extend the lateral rhinotomy or add on to the sublabial approach or maxillary string approach. If there is again cheek extension, it's the extended lateral rhinotomy only. Or if there is an intracranial approach, we can combine this lateral rhinotomy approach or endoscopic approach along with the intracranial extension. If there is a residual or recurrent diseases, we can go for observation or repeat surgery or the radiotherapy associated with it. So endoscopic approach is good for fish 1 and 2 tumors and fish 3 tumors with limited medial invasion of the infratemporal fossa. Relative contraindications are, there is no absolute contraindication nowadays. It's all depend on the expertise you have for the expertise of the surgeon and the instrumentation available. Relative contraindications are lateral infratemporal fossa involvement, extensive paracellular extension, encasement of the optic nerve, and intradural extension. So it's the binostril four-handed approach which is used. It's first described by the May. What we do exactly, we do the posterior septectomy. It requires two surgeons. One surgeon holds the endoscope at 11 o'clock position and do the irrigation. Another surgeon uses suction small nostril instrument. And one is the primary surgeon which uses all the instrumentation from one nostril. So what we exactly do is we prepare our cavities well using the xylocaine ADR. The section of the anterior end of the middle turbinate or complete it can be done. The next step is doing the anterior ethmoidectomy, removal of the medial wall of the maxillary sinus, removal of the posterior wall of maxillary antrum to achieve the complete lateral exposure of the tumor. Now go for ligation of internal maxillary artery, removing the posterior wall of maxillary sinus. Now dissection continues till the rostrum of sphenoid with the sphenoidotomy. In our practice, we do a lot of angiopharyngeal. What we have seen, rarely there is a tumor almost always extend into sphenoid, but rarely infiltrates it. So once you do the sphenoidotomy, it comes down. Now using your blunt instrument, good Freer's cobblator and with the help of cautery, just dissect the tumor all around and then go to the last part of the cutting of the tumor. After removing the tumor, always do the drilling of basosphenoid and pterygoid vest to remove the residual tumor. When I'm talking about the endoscopic endonasal approach, it can be a four-handed approach. There is another approach which is given by Baruda madam. What they does, there is a small canine fossa. What we do, we can use the drilling like small caldwell leg can be done from the canine fossa also. Another is modified Denker approach, which can also be used. So post-op management is back removal after 48 to 72 hours. Routine saline irrigation, endoscopic cleaning usually done. And CT scan is done after 48 to 72 hours. That means after removal of the pack to rule out for the residual disease. Complication are standard risk of complication like any endoscopic sinus surgery where we go at the endoscopic skull-based surgeries. Endoscopic examination should be done every 3 months and routine CT scan after every 3 years in our center, what we are doing. Now coming to the open approaches, as I had discussed earlier, it's basically a transpalatine approach or anterior approach, inferior approach, and combined with the different approaches what we do. So Wilson transpalatal approach is a good approach with the fish one tumors which are located only to the nasopharynx or the nasal cavity. Commonest thing is what we do here is make a flap in the palate, or maybe incision may be extended to the soft palate also, or we can use the Legius incision also in these approaches. Nowadays, we are not doing the Wilson transpalatal approach. If such tumors are present, we go for endoscopic approach only. Now coming to the lateral rhinotomy approach along with the medial maxillectomy. It's suited for the growth in the nasal cavity extending to maxillary sinus, pterygopalatine fossa, medial part of infratemporal fossa. If we combine with the sublabial approach or the Weber-Ferguson, we can have a wide exposure even to the infratemporal fossa or the intracranial arch also. So somewhere I read about the disadvantage being scar bleeding. I don't think in our practice we do a lot of lateral rhinotomies. Scar is an issue or bleeding is an issue with these point patients. So it is a preferred approach in our practice because it allows a swift, direct and wide exposure of the tumor. When extension of growth makes exposure lateral to the infraorbital foramen is described, the incision can be extended through upper lip and along the superior and buccogingival sulcus. Lateral rhinotomy and its variations permits removal of tumor from the nose, nasopharynx, paranasal sinus, pterygopalatine fossa, infratemporal fossa, and orbital tumors and middle cranial fossa tumors also. So this is the one patient we operated, and you see how good the scar comes after this. So another is the mid-facial decurving incision. Here the advantage being there is no facial incision we see. What we do is the bilateral sublabial incision, intracartilaginous incision, transfixation, and then we combine all these incisions. This is again a good approach for the central lesions. Then again is the Lefort 1 osteotomy. What we are doing basically is we are disconnecting the skull from lower part of skull from the upper part, and again it's a good approach from the central midline only, but not very good approach for the lateral part, but can be combined with the lateral rhinotomy along with the Weber-Ferguson. It gives a good exposure. Now coming to maxillary swing or a facial translocation, the approach is also known as B's approach. What we are doing, giving a Weber-Ferguson incision, then putting a osteotomy lateral and in the central and the palatine part also. And we completely take off the whole of the anterior part of the maxilla, and then directly exposure of the tumor is there. Now coming to the, when you are going by the either endoscopic approach or a open approach, there is a significance of pterygoid wedge, which is the most common cause of recurrences. It is defined as the anterior junction of the medial and the lateral pterygoid plates. And it is involvement seen in almost 99% of the cases if we remember how is the origin of the tumor. And it is the epicenter of the tumor. And it is the most common cause of residual or the recurrent diseases. So the most important step of JNS surgery is to prevent the recurrence and drilling of pterygoid wedge. Now coming to the complications, how to achieve hemostasis, there are few important steps. Keep patient in reversed angle block position. It improves venous drainage. Direct pressure of the tumor. Keep your Liga clips ready. Use a good bipolar forceps. Warm saline irrigation at 40 degrees Celsius. Good xylocaine ADR or saline ADR irrigation. Surgicel. Now, what is one of the most treated complications is management of IC injury. How it is prevented? Don't panic, don't pack. Always keep 2 suctions. Use a 1 to 2 centimeter muscle harvested from thigh or facial lata or abdomen. Crush and place over the bleeding point for at least 3 to 5 minutes and activates the platelet and fibrin plug. Clean for the Surgicel. But if still bleeding is not controlled, if you have options, always go for endovascular intervention by angiography. Early post-op care in the form of nasal crusting, orbital hematophytic occurs, infraorbital nerve paresthesia. I will just skip the complication part. Now coming to the recurrence. It is defined as a subsequent tumor after negative immediate post-op scan after 48 hours. Incidence is around 32%, and the factors responsible are extensive disease, young age, pre-op embolization which has been implicated, inexperienced surgeon, and most important step, as I discussed earlier, drilling of the cancel bone of the pterygoid wedge. Now coming to what are the indications of radiotherapy in nasopharyngeal angiofibroma. It is used for the extensive primary disease with intracranial extension, unresectable residual disease, medically unfit patient. It can be given in the form of external beam radiation, IMRT or gamma knife. So dose is around 30 gray to 50 gray. And the complication as are the other complications of we see in the routine with the radiotherapy. Hormonal therapy, I don't have any personal experience with it, but flutamide is a drug along with the dithylstilbestrol which has been used. Chemotherapy in the form of doxorubicin, dicarbazine, vancomycin, dactinomycin, cyclophosphamide or cisplatin, especially in the cases which are recurrence or unresectable. So in conclusion, there is a good understanding of anatomical and endoscopic anatomy of skull base is essential for all the JNS surgeries. The advancement in preoperative imaging provides a good insight of the tumor extension and behavior. The introduction of embolization in interventional radiology and controlled hypotension in anesthesia reduced blood loss and improved visualization. Better availability of good endoscopic camera system along with the power tools like coagulator and navigation makes surgery comfortable and makes surgeon confident. And surgical approach should be based on adequate exposure, direct visualization and surgeon experience rather than the just going by endoscopic, the thing which is going on nowadays. These are my references. And my special thanks to my teacher and mentor, Professor Nitin Nagarkar sir. My sincere thanks to all the junior residents, especially Dr. Megha, and thanks for all the patients and Department of Radiology. Thank you.
Thank you, sir. Thank you. It was a very informative session on angiofibroma. Now, I would like to invite comments from the faculty. Okay, we don't have.
No. Hold on. Yes, Doctor, very well presented. I want to know what is the role of any tumor marker or what you say this testosterone or androgen markers, hormone markers.
As I stressed about the markers in the, as I stressed earlier, also there are markers like APC, KIT1 and TNF. But sir, in our setups routinely we are not getting it done. But there are definitely tumor markers has been implicated. There are tumor markers which are there, but I don't think we are getting it routinely done in our kind of setups.
I think, sir, we can.
Recently, I was going through some answer sheets in one of the places. I came across a Hiranandani approach incision. Okay.
Sir, I think we can leave the discussion here because we are running short of time. We can start with the next speaker, Dr. Kapil.
Ravi, go ahead.
Thank you, sir.
Right, sir.
Thank you, sir. Yes, sir. Moving on to next session on fungal rhinosinusitis. I request Dr. Kapil Sikka, is additional professor at AIIMS, New Delhi. Sir has special interest in functional endoscopic sinus surgery. Sir, please.
Good afternoon, sir.
Good afternoon.
Hope I am audible and you can see my screen also, sir.
Yes, we can see. Please make it full screen. Yes.
So thank you so much for invite and thank you all. I have been following your session for a few hours now. It was really wonderful, sir. Great, Ravi, sir. Good choice of topics and very good discussion going on. Really enjoyed it and learned myself a lot. So thank you for the topic. I have been told to present on fungal sinusitis, which we all know it's a disease of our subcontinent. We all see a lot of patients of fungal rhinosinusitis in our area, and if you even go by any international textbooks, they will classify it as South Asian and our subcontinent disease. So onus on making guidelines and classifications and treatment guidelines, it lies a lot on us, and that's why it's a very, very important topic for our postgraduates, our consultants, and even after you pass out in our practice, we'll see a lot of patients on fungal sinusitis. So my sincere acknowledgement to my Chief of Department, Professor Alok Thakkar, all faculty of ENT department. I have used a lot of photographs and scans and images in my slides. Few of them are my own patients and few of them I have taken from my other faculty colleagues, and I am sincerely thankful to them. And also my sincere acknowledgement to Dr. Prangpur Verma, who was our ex-resident, who has worked very sincerely and very hard in gathering some information which I'll be sharing with you on fungal sinusitis. Fungus forms a major part of our ecosystem. There are bacteria, there are viruses, which we are facing a challenge right now, but the fungi are also a major part of our ecosystem. And there are around 20,000 species known in fungus, but only 250 odd cause human infections. If we look at last few years, they were probably not much known if you look at 1950s, 1960s. But last few decades, they have shown a rise. It's a rapid rise. And rapid rise in literature has been attributed to use of cancer chemotherapy, organ transplantation, some bit contributed by HIV and broad spectrum antibiotics. So if we talk about fungi, they are eukaryotes. They are not prokaryotes, unlike our bacteria, and they are not considered as viruses because they are structurally very different. And there are three mechanisms by which fungus causes disease in humans. They elaborate sometimes very potent toxins, and these toxins, they harm our body. Then they can cause direct invasion. And what is very common to understand, it's very important to understand, is some of them cause disease by inciting host immune response, which we'll be discussing in our subsequent few slides. We all have encountered these problems in our day-to-day practice. These are the photographs of otomycosis. If you see this here, there are small blackish spores seen with interspersed whitish hair-like structure, and this is a pure white spore-like material. So this is a candida infection of the external ear canal called as candida otomycosis, and this one is the aspergillus otomycosis. So if you look at the most common fungal infections in ENT, fungal ENT diseases, they are otomycosis and oral thrush, which you see here. Very frequently you see this oral thrush. I won't say you see it very frequently, but it's most commonly seen in patients who are significantly immune compromised. And this is also caused by Candida albicans. So these are the very, very common ENT conditions which we do encounter caused by fungus. But what interests us is in paranasal sinus infections, these three fungi, they are more relevant, they are more important in causing PNS infections. Candida, of course, can happen, but more commonly which interest us are the aspergillus and the zygomycetes fungi, which will be further classified into septate and aseptate, meaning septate meaning aspergillus, and your aseptate meanings are mucor. we all know that fungal sinusitis is not an isolated disease. It's not one disease. You cannot say that this patient has fungal sinusitis. That will be a wrong diagnosis. It's actually a spectrum of diseases. This spectrum of diseases includes one of the most benign disease of paranasal sinuses. We call it mycetoma. And few of the diseases, they are so deadly lethal that they cause mortality that has been reported in as many as 50% of infected patients. So they cause some of the most benign infections, that is the fungal mycetoma, and they cause some of the most malignant or most deadly infections, that is the acute necrotizing fungal rhinosinusitis, which we also called as mucormycosis. At times they are used as synonyms. And all that contributes to this invasion or pathogenicity or the deadly nature of this fungus is the immunity. As the immunity goes down, the fungi, they tend to cause more deadly and more erosive disease. So this I have already mentioned. If patient is receiving prolonged antibiotics, there is poor ventilation, environments are dark, poor ventilation, you can see the lung that has collapsed. It is more propensity to develop that fungal pneumonia. Immune compromised conditions, most commonly being diabetes, and there are other conditions like cancer, chemotherapy, hematological malignancies, bone marrow transplant, and so on. These are more for theoretical usage. Common genera causing fungal infection. I already mentioned about zygomycetes. You have mucor and rhizopus predominantly causing fungal disease in zygomycete groups. Then there are hyaline molds, predominantly responsible for invasive as well as allergic fungal sinusitis. If you read our Western textbooks, they say dematicious molds are more common cause for our AFS, but there have been some Indian studies which say that at least in our subcontinent, Aspergillus is more common. It's easy to remember dematicious molds. They are A, B, C, Alternaria, Bipolaris, and Cladosporium or Curvulinaria. And then there are Candida, and then there are Basidiomycetes. I'll be only covering the common fungal infections here in this talk because we have been assigned only 30 minutes. This used to be an old system of classification. If you look at classification maybe 30 years back or so, they were only classified as aspergillosis or mucormycosis based on what fungus has been isolated from those sinuses. If it was aspergillus fungus, they used to call it aspergillosis. If it was mucor fungus, they used to call it mucormycosis. But there have been evolution of newer systems of classification, and by and large, you can subclassify fungal sinusitis into invasive and non-invasive. We'll discuss what is invasive and what is non-invasive in subsequent few slides, but that is a by and large overall classification, that is newer system of classification which is used more recently. So we see it's a fungal sinusitis. It can be invasive, it can be non-invasive. And if we see further classification, then there are 3 subgroups of invasive sinusitis and 3 subgroups of non-invasive sinusitis. I have deliberately colored this black because they are more deadly, they are more lethal, and these are relatively benign conditions. If you look at non-invasive, you see saprophytic fungal manifestation. We'll discuss them one by one. We see fungal balls, and we see allergic fungal sinusitis where they are non-invasive. They do not have any tissue invasion. They will be present in mucosa or at the most some degree of mucosal invasion. But if there is evidence of mucosa, bone or cartilage or orbit or dural invasion, we label it as invasive sinusitis. And somewhat towards invasion, allergic fungal sinusitis is called as chronic granulomatous, and aspergillosis is mostly causing chronic invasive and acute invasive. And how do you categorize acute and chronic? Literature says if it is more than 4 weeks, you call it chronic invasive fungal sinusitis, and if it's less than 4 weeks, we call it acute invasive fungal sinusitis. So as we classified it, we first mentioned about saprophytic fungal infestation. Saprophytic is that patient came to you with some complaints, maybe similar to sinusitis. He had some crusts. You took out this crust, send it for fungal smear, and your fungal smear is showing some fungal elements there. So this is a saprophytic fungal manifestation. We cannot call it a disease. We don't know whether this was causing the problem or actually this crust was causing the problem or that fungus was causing the problem. So it's a query disease. I don't know whether it's disease or not. Some studies say that it is possibly a precursor to fungal ball. If you let this crust be here, so this is a patient who has underwent some surgical procedure, endoscopic sinus surgery. I don't know what it was for, but you can see some crust lying there and they were sent. You can see some hair like projections there. If you send it for fungal smears, you might they might send it back as fungus positive or aspergillus positive. They're generally seen post-surgery. If it's extensive PES or extensive septal or turbinate surgery, you do encounter these crusts and you send them for smears, and they may be returned as positive. As I said, we don't know whether they are causing symptoms or crust are causing symptoms. But if you have this, then no treatment is required. You just remove these crusts. That can be a minimal invasion or surgical treatment, or you tell the patient to just lubricate it, use a nasal wash or something, and these crusts come out. The patient will be cured of disease. So you need not intervene to great extent. You need not worry. You can tell the patient the prognosis is very good. If you go at next stage, a stage next to your saprophytic fungal manifestation, it's a sort of bigger, slightly more expanded fungus in the sinus. It's called as fungal ball. Typically, it's a one sinus infection. So what is fungal ball? There is a lot of expansion of all the walls of one sinus. Most commonly it is maxillary sinus, but sometimes, more than 90% they occur in maxillary sinus. Sometimes they can occur in sphenoid also, almost 9-10%, and they are practically unknown in other sinuses. So they are densely matted collection of fungal hyphae which exist extramucosally. Mind it, we are still talking about non-invasive. This does not invade the mucosa, and it is extramucosal disease for theoretical concerns for our postgraduates. Middle-aged female, it is most common. Why it happens, we don't know. As I said, that we have previous surgery and there can be some saprophytic fungal manifest or fungal infection, and they can expand and they can lead to mycetomas or fungal balls. That is one etiology that is proposed. Another etiology, they have very interestingly, I did not know that, but they have found that at times 88-90% association with previous dental fillings. So once they have dental fillings, they are known to contain some metal salts and they promote fungus growth in the sinuses. That is one etiology that has been mentioned. And some say that there are some anatomical variations at the osteometal complex. They are contributing to the pathogenesis of fungal balls. But clear etiology is not known. There is no clear established etiology or pathogenesis. Symptoms are non-specific. They will generally come to you with symptoms that are similar to your rhinosinusitis, maybe bacterial or cold or nasal blockage or cacosmy or nasal stuffiness. CT scan is good enough. If you get a CT scan and you encounter something like this, there are large expanded sinus, some concretions, some hyperattenuations. It has a sensitivity of 62 and specificity of 99%. That's according to our textbook or recent literature reviews. So once you operate them, surgery is the mainstay of treatment. Just open this sinus, take out these secretions. You will find classically there will be clay-like inspissated secretions on endoscopy. I'll show you in a photograph in next slide. Histology will show dense mat of fungal hyphae, but you should biopsy the mucosa that is surrounding and you should demonstrate there is no invasion. Invasion means that there is some degree of invasive fungal sinusitis, and cultures, mind it, are not reliable. You will very frequently send them for cultures, but most commonly there will be dead fungi. So dead fungus will not grow on cultures, obviously. So cultures will not have very high reliability. Even if culture comes negative, but you can demonstrate fungus on histology or on smears, that is a good enough for diagnosis. They will appear something like this in the middle meatus. And if you enlarge that meatus, your sinus will be filled, as I said, with the clay-like inspissated thick secretions. You just clear them with any instrument you like. Just wash the sinus adequately, and there is no need for medical treatment. You don't need to treat these patients with steroids, antifungals, or any medical treatment. A second in our spectrum will be allergic fungal rhinosinusitis, a disease very, very common in our subcontinent. We very frequently see this. It is in fact one of the most common sinus fungal diseases. It's commoner than the invasive fungal. There are overlapping features to CRS. Many Western literature, they have discussed them simultaneously. Chronic rhinosinusitis, polyps, and AFS, they have been discussed together. And how this disease was diagnosed and initially found out was because of its striking similarities to allergic bronchopulmonary aspergillosis. Typically occurs in young adults. It's 21 to 33 years population, which is most commonly involved, and you will rarely find these patients immune compromised. It's typically immune competent patients and maybe hyperimmune patients. So as I already mentioned, it is a disease of hyperimmunity. It's probably a response to fungi rather than direct involvement by fungi. And these are the criteria. It's not given in all textbook. I was surprised our Cummings textbook does not mention this criteria. But whatever literature I have reviewed, they are still mentioning Bent and Cohen diagnostic criteria for AFS. Major criteria, evidence of type 1 hypersensitivity, that is IgE mediated. They say IgE levels should be more than 500 odd or something. Nasal polyps, another major criteria. Very characteristic CT findings. I'll show you in one slide. Eosinophilic mucus and positive fungal smear, minded smear, not culture. And then there are 6 minor criteria: eosinophilia, asthma, unilateral predominance, radiographic bone erosion, fungal culture, and Charcot-Leyden crystals. They are the minor criteria according to Bent-Templeman. Pathogenetic mechanisms, they have been extrapolated from ABPA. They are not very clear what happens exactly in allergic fungal, although there are some genetic and HLA studies going on. It's not a true fungal infection. As I already mentioned, it's a reaction to fungal antigens. This fungal antigens, they produce 2 types of reactions: IgE mediated type 1 reaction and IgG mediated type 3 reaction, which is an antigen antibody complex. What happens is, when this antigen antibody complex deposits, it leads to intense mucosal reaction. There is a lot of eosinophils that are recruited in that area, and these eosinophils, they break down those fungal elements, they break down the cells surrounding, and they create a lot of muck and the fungal debris, which are very rich in eosinophils, and they are very rich in Charcot-Leyden crystals. That is how this allergic fungal sinusitis causes disease. Always suspected in unresponsive CRS patients. Even if you don't see that typical radiology and your CRS patients, they are not responding to your usual treatments, they are needing repeated surgeries, and they are responding to steroids, always suspect AFS, benign expansion of sinuses. But they can have orbital features like proptosis and vision loss. And also, sometimes in our experience, we have seen that large ethmoid AFS, it can cause secondary mucocele of other sinuses, which can lead to the orbital symptoms. So that's one of a typical patient. It lacks the features of classical invasive sinusitis, which I'll be showing you in subsequent slides. There is a proptosis, it's axial, and if you see, there is a ballooning and expansion of sinuses. The bones are not typically eroded, but they are somewhat rarefied, or some degree of rarefaction because of chronic expansion of these sinuses. And you can see there are 2 intensities seen. It's called as double intensity sign. The outside is the thickened mucosa, and inside is because of heavy metal salts of fungus, and it is because of the fungal debris deposition. Already I have made it clear, fungal cultures are not to be relied on. It's the fungal smears and clinical and radiological features. And this is just for theoretical sake. You need to at times differentiate between chronic sinusitis with polyposis and AFS. I got this from this very interesting article. I must recommend this article should be read by everyone. It's a current understanding of AFS. Very recently came. Nasal polyps are present in both. It's not a differentiating feature. Age is generally, as I said, it's around 20 to 30 years of age. Serum IgE, they are very high in AFS, but they are not diagnostic of chronic sinusitis with polyposis. They are dependent on atopic status. But here you will often find them more than 1,000. Peripheral eosinophils, they can be elevated, but typically they are normal in AFS. And asthma is less common in AFS as compared to chronic sinusitis with polyposis. So if you ask me treatment, then most of these patients, they will at least need one surgery. What is the aim of surgery? It is for clearance of your fungal material and restoration of pathways. You open the sinuses, you clear those osteometal complexes, and let our medications and sinus washes reach those areas, so that it makes one pathway for clearance for any future recurrences. Also, it helps to obtain material for biopsy. Minded, CT scans are 99% sensitive or specific, but they are not 100%. You have to obtain some material for fungus, some material for biopsy. You might find an odd inverted papilloma or a tumor or a cancer in these scenarios. So it is good to rule out invasion. It's good to biopsy them and do a fungal analysis. Steroids are mainstay in medical treatment. Mind it, it's not antifungals in AFS, it's the steroids, they are mainstay because it's a non-invasive disease. They suppress inflammation, they suppress eosinophilia, and also decrease IgE levels. We don't know what is the exact duration of steroids, but many books or articles, they mention it from 3 months to 1 year. Topical steroids, we employ regularly a lot in our practice, but there is no defined role. What is better? But most of the textbooks, most of the literature says it's the oral steroids which prefer. Topical steroids still have a doubtful role, but in our experience, it seems that they work. That's what the typical fungal ball or muck looks in. This snapshot has been taken from one of the videos where we have widely exteriorized the sphenoid sinus, and we are in process of clearing the fungal muck from sphenoid sinus during endoscopic sinus surgery. There is a lot of debate. Some surgeons or clinicians, they prefer to use oral antifungals. in AFS, I did not exactly know whether they have a role or not. I myself at times have used in extensive AFS, that is recalcitrant. But I read the international consensus statement on allergy and rhinology. This was published last year in Journal of Allergy, Rhinology and Immunology. So they have said that some studies show promising results, but these are balanced by significant number of non-responders and adverse events. At this point, there is insufficient evidence to recommend for or against antifungal therapy in AFS. So we really don't know whether antifungals work or not. Maybe you can try anecdotally in cases which are not responding to usual treatments. Immunotherapy, again, this article very good. Symptomatic benefit in short term. Long term, it's not established. I have no personal experience in use of immunotherapy, and it's recommended in this article that you may try it in refractory cases, maybe cases which are requiring repeated surgery. You may give it a try of immunotherapy. Leukotriene modulators, they have no role. They have doubtful role. I will not recommend it as solely as treatment for AFS. Biologicals was very interesting. Again, we got a drug that is omalizumab. It's very widely being discussed in allergy conferences. Again, this international consensus guidelines, they have said that given type 1 fungal hypersensitivity and typical extremely elevated IgE levels, it may have a treatment option. So mind it, omalizumab is anti-IgE. So since IgEs are raised, it may have a treatment option for AFS, but they are saying that current evidence is lacking. But these guidelines, they came around 1 or 2 years back. So I searched PubMed and I came across an evidence that is in fact a randomized controlled trial in which they have given intranasal steroids in one group and omalizumab in another group. And omalizumab is just one dose. And steroids, they were administered regular steroids for around 6 months, and they have found it is more effective than daily dose of local steroid in control of symptoms with similar improvement in endoscopic follow-up. So they have mentioned it's a promising drug. Omalizumab, it's a biological anti-IgE. It's not an established, it's not come in guidelines, but one trial that I have found, it has played a role, but only thing that they have mentioned is it's costly. It's around 3 times the cost of steroids, this omalizumab. Chronic granulomatous, I would say it's a step ahead of allergic fungal. Its invasion past the mucosa. There is not enough literature on what exactly chronic granulomatous is, but they are saying if it's AFS and it has invaded beyond mucosa, they call it chronic granulomatous. It coexists with other forms of fungal disease and forms non-caseating granulomas that are typical of this pathology. So we have a paper from my colleague, senior colleague, Professor Thakkar. It came out a few years back. So they have also documented that non-invasive and invasive forms, they are not necessarily discrete, but they may coexist in same patient. So you may take a biopsy from one sinus, you may encounter some invasion, and possibly they were talking about chronic granulomatous in that particular paper. I've already commented on acute is less than 4 weeks, chronic is more than 4 weeks. And I will just now start talking about the invasive fungal sinusitis. What is invasion? Invasion we have already discussed. If the fungus has gone beyond the mucosa of sinuses, it is called as invasion. Or there is clinical evidence, there is radiological evidence of invasion, or at times there is more than one organ involvement. There is diffuse fungal dissemination and there is more than one organ involvement. So that is one patient who's admitted in our medicine ward. You can classically see that patient has lost 1/3 nerve. Patient had a history of nasal blockage. He had a lot of nasal discharge, nasal stuffiness, some bit of blood in discharge, and look at his chest X-ray. So he's having an X-ray evidence of fungal pneumonia. He's having clinical evidence. You don't need any probably diagnosis or any fancy gadgets to detect that this is an invasive fungal sinusitis. So I already shown you this photograph. Allergic fungal sinusitis can also have orbital features, but look at starking difference between these two. This is a clear-cut pathology. Patient will hardly have a vision loss. They do present with vision loss, but invasive fungal will classically have erosive disease, invasive disease, presenting as more or less like cancers, loss of vision, loss of cranial nerves, and so on. So chronic invasive, another patient, you can see more or less similar presentation, ptosis, some degree of facial swelling, some degree of facial puffiness, nasal mass, mucosal thickening in the sinuses. You can see it's clearly extending into the orbit. Orbit also looks a very well-defined mass lesion, which definitely you feel should be biopsied, and very important differential here is malignancy. Acute necrotizing will classically present in matter of days, at times hours also. How it starts? it classically occludes the blood vessels. It will enter the maxillary artery, it will enter the small arteries that are supplying this area, and it will essentially necrose this area. So it is called as acute necrotizing fungal sinusitis. Starts off with pallor, and after that, the area will slough off, and gradually the patient will develop blackening of skin on the face, on the mucosa, nasal areas, nasal mucosa, septal mucosa, turbinates, and so on. So very rapidly progressive disease. Blackening of skin, it starts off with palate. It starts off with turbinate. If you ask me one area that will be initially involved, it will be middle turbinate. Then it involves palate, it involves skin of the face and rapid intracranial spread, and at times there might be infarcts. They are diagnostic of mucor, and typical appearance will be like this. It can be deceptive on scans. So my teachers, they have taught me that a patient might be coming to you in a very bad shape. He might be in a not able to breathe, he'll having a lot of complications, patient might be having stroke, but still you might see very minimal features on CT scan or MRI. It is not a very diagnostic modality, but still, if you ask me how to diagnose them early, clinical suspicion followed by CT scan or MRI. Mucosal thickening is almost always present, but it can still be deceptive. Patient might be having more disease than is seen on CT scan, and always look for brain in MRI scan. So you can have a carotid artery involvement, you can have a cavernous sinus thrombosis, and you might have a large liquefaction coming as a stroke in brain. So always assess brain in these patients. So coming to differential diagnosis, I have been seeing a lot of patients of cancer that have been misdiagnosed as mucor or fungal sinusitis and vice versa. Some of the fungus diagnosed as cancer, so always take a biopsy in case you suspect. Roughly, if you see a malignancy or a lymphoma that was in this particular case, it's more pinkish mass, it's vascular, fungus is not vascular, and biopsy will tell you what it is. So this patient had come to us. On face, it is very difficult to say what it is. The patient had a facial puffiness. The patient also had some crusting and blackening of palatal area. The patient has conjunctival ecchymosis. He also had proptosis. He also had vision loss. But eventually it came out to be vaginous granulomatosis or polyangiitis granulomatous, which is another important differential diagnosis in invasive fungal sinusitis. I've really been saddened. Probably in our referral practice, this is the most commonly misdiagnosed condition in rhinology practice. That is lethal midline granuloma, or what we used to call, what we now call as NK cell lymphoma. This patient had come to us with similar feature, midline, palatal. You can see necrosis. You can see a lot of crusting, lot of atrophy, septal involvement, lot of blackening of mucosa. You can see some area of congestion in and around the eye and face, skin of face. And eventually you need biopsy to diagnose it. In fact, sometimes you need repeated biopsies. So this is a NK cell or a midline lethal granuloma. One very important differential is diagnosing or differentiating fungus from pyogenic, normal sinusitis, bacterial sinusitis. So this child was a diabetic. He had a facial edema. He had some preseptal cellulitis, in fact, abscess formation. He had opacities on CT scan. It's very common to get them in your emergency or routine OPD or referral from ophthalmology. And it is good idea to send smears, a lot of smears from nasal cavity, and if they return as negative, or you take a lot of biopsy, drain these sinuses and send them all for fungal smears and cultures and treat accordingly. This child was fortunately only a pyogenic bacterial sinusitis. He responded to IV antibiotics and endoscopic sinusitis. This is not exactly a differential diagnosis of fungus, but we were confused when this patient came to us. There was no bone involvement, but a lot of skin involvement, redness, actually had a wooden stick piercing this area, and this was eventually a necrotizing fibrofasciitis, but bones were normal, and we had to make multiple incisions and a lot of antibiotics. So this is, as if you go by your surgery textbook, a flesh-eating bacteria does form at times a differential diagnosis in invasive fungus. So that's what our fungal smears looks like. It's been contributed by my microbiology colleague. Thin septate hyphae with acute angle branching. You can see acute angle branching, septate hyphae. That's typical of aspergillosis seen on 40X. And if you see right angle branching, this is one, this is second. It's almost a right angle there. No septations, aseptate hyphae is typical of mucormycosis. Very easy to diagnose. You can do it yourself or send it to your microbiology colleague. Management, I'll not say there is a controversy in surgery versus medical. Surgery is almost always required if patient is stable, but there is a lot of debate on when. So there is a lot of debate on when surgery should be done. Maybe some like to wheel in the patient as soon as they come, but I have found that most of these patients, they are medically very unfit. They have got a lot of renal issues. They will have sugars of more than 400. They will be presenting with ketoacidosis and so on. So they are generally not fit for emergency. I feel it's a good idea not to take risks and wait for their stabilization. Not to forget, you should stabilize the underlying condition. Waiting for stabilization doesn't mean that you let the patient go here and there and wait for your surgical debridement. This control of underlying condition. If sugar is 400, control it. If kidneys have failed, then dialyze them. And build up your medical treatment very rapidly. Give amphotericin so that its levels, they start rising in the blood. That is the mainstay of treatment. If it's aspergillosis, then voriconazole is as good as amphotericin, or if it's in fact better. So this is not a sinus-focused trial, but it's a landmark trial published in New England Journal of Medicine for invasive aspergillosis. Voriconazole is considered better than amphotericin. So if you are considering aspergillosis, there are ways how you can diagnose this. I showed you one of them before. It is a better drug than amphotericin, less toxic probably. If you are considering mucor, amphotericin is the best proven drug. There is no alternative to amphotericin. There are newer alternatives coming, but their effectivity is yet to be proven. Liposomal amphotericin has come nowadays. It is better alternative because it's tolerated better, and you can give higher doses and compliance is better. Mind it, azole antifungals, that is itraconazole, voriconazole, they do not work for mucor. They are not good for mucor. Timing of initiation is most important prognostic factor in invasive fungal sinusitis. And surgery, if you are doing it, you are bringing them for surgery, it should be as radical as possible, and you should achieve, this is not an adequate surgery. The bone is still dead. You can see a lot of sequestrum here despite orbital exenteration. So we have removed all this bone, and this is what we should achieve. Good bleeding margins all around. So it looks very debilitating. It looks very bad, cosmetically disfiguring. They are cosmetically disfiguring. And this is the CT scan that you get at the end. Right? It's almost a complete rhinectomy, orbital exenteration, complete maxillectomy. But that is the end result which is desired if you are doing surgery. Sequestrum complicates disease. There is a lot of sequestrum in this patient. It might be looking apparently that it's a well-debrided large cavity, but there was a lot of sequestrum in this patient. Frontal bone was sequestrated. You have to remove it for your medical treatment to act. Defects can be very bad. They can be very debilitating. This female was reconstructed in our department by my colleague, Dr. Amit, with the anterolateral thigh flap, and you can see a long-term follow-up. It has got a reasonable, and she's fit for a orbital prosthesis. So look at the defect intraoperatively and look at the rehabilitation. You can achieve a good rehabilitation. Another method which we follow is, these are not cancers. These patients are not going for chemotherapy or radiotherapy. So this bone and skin is going to stay virgin. It's not going to be irradiated. So it's a good idea to place these abutments, also integrated, and thereafter you can give them ocular prosthesis. It works very well in these scenarios. When to stop treatment, I probably will not have answered to this. Some mucosal thickening does persist for months together. You may find this at scans done 6 months or 12 months after that. But that is what we are targeting at. I had shown you this endoscopy picture before also. So we must see a normal healed mucosa all around. Small crust here and there, they can be removed. If you look at normal endoscopy and only slight mucosal thickening, you can think of stopping treatment, or of course patient should be asymptomatic. So it tells you that voriconazole works. That was a fungus, invasive fungus in fact, hole in the sinus, and after 3 months of voriconazole, you can clearly see the clinical and radiological response. Future trend, we have worked on invasive fungus in our department. As I mentioned, Dr. Prangpur has done a study. It has come out with few salient guidelines. Iron overload, it controls, starves the fungus. I'll come on to that. Posaconazole is probably a promising agent. We are prescribing it for a back home treatment for patients who have completed their amphotericin, but mind it, it's a costly drug. Cytokine therapy, we have found that some of the cytokines, they are elevated in these patients, and maybe anti-cytokine drugs or pro-cytokine drugs, they may have a potential role, but that's a far from dream. It's yet to be seen. And there are studies, this one I just got from JLO 2 years back, there are diagnostic tests or kits like Maspin. They are just experimental and we really don't know its efficacy. If you talk about iron overload control, our some physician colleagues, they are giving desferrioxamine. They reduce the iron levels in the blood, and they feel that fungus needs that iron to survive or thrive. So if you reduce the serum iron levels, it may be beneficial in treating cases, especially of mucormycosis. So thank you so much, and thank you for opportunity. And any question or any comment is welcome.
Thank you, sir. Thank you. It was a very comprehensive session on fungal rhinosinusitis. I would like to invite comments or questions from faculty.
Dr. Kapil, excellent talk, and I think you have very beautifully explained all the different types of fungal sinusitis, and I think postgraduates must be now aware of differentiating features of invasive and non-invasive fungal sinusitis.
That was my intention. Maybe they should be aware of one, differentiation, and two, maybe differential diagnosis. We should not misdiagnose fungus as cancer and sometimes vague symptoms. Should have high depths of suspicion.
Right, absolutely right. I have just two comments to make. One is that bent and cone classification, you said it is not, available in normal textbook.
I did not see it in coming. I was surprised. I don't know. Yesterday I was going through because it is there. Maybe I'm wrong.
It is there in the latest Scott Brown 8th edition.
Yeah, I was reading Cummings, and I did not find bent and cone there. I might be wrong. I did not read.
It is very, very commonly used criteria for diagnosing AFRS. And regarding the present situation of COVID-19, have you seen an increase in mucormycosis cases, invasive fungal sinusitis cases because of, this steroid therapy which is being given? And most of the patients who are diabetic patients or who are on long-term steroids because of COVID-19, these patients are presenting with mucor. Your comment about this?
We have experience, sir. I think there has been some increase recently of mucor cases, because if we look at previous 2 weeks, we must have had at least maybe 8 or 10 cases either in our ward or in infectious disease ward who have presented with mucor. But I feel that it should be a more comprehensive population-based survey. What was the incidence before COVID and what is the incidence after COVID, to make it a conclusive evidence that they are more in COVID. But yes, if you give steroids, I think COVID steroids, they are not giving for months together. It's for maybe 10 days, 15 days, they might be giving steroids. I don't think that should be contributing to increased invasive fungus. I would like opinion from others also, but I don't think that is enough to cause fungus sinusitis in COVID scenarios. Steroids, there are more scenarios where you give. Yes, sir.
Right. Okay, thank you for your comments. Can we go ahead, sir? Dr. Ishwar, Dr. Rathore, do you have any comments, or we go with the next topic?
Go ahead with next topic.
Moving on to the next session, robotic surgery and TOS in ENT. Very important topic in recent advances. It's my pleasure to invite Dr. Alok Thakur, consultant surgeon, professor and head of department at AIIMS, New Delhi. His areas of special interest are neurology and skull-base surgery and head and neck oncology. Sir, please.
So hello everybody, Dr. Rathore, Dr. Ishwar, and of course Ravi and Dr. Ali. So thank you. I know we're running late by almost an hour, and I'm sure many people must be very impatient. So I'll just rush through. I'll try and do it a little bit quicker than usual. Excuse me. So yes, we are here to talk about transoral robotic surgery and transoral ultrasonic surgery, transoral robotic surgery and transoral ultrasonic, TORS and TAUS. And this is about the robot. I think by now everybody has sort of seen pictures and videos, and many of you have experienced the robot. But the robot is actually two bits. There is the surgeon's console and the patient console. And the surgeon sits at the surgeon console and basically controls whatever happens with the robotic console. And this is how it goes. An assistant surgeon sits with the patient console, or rather with the patient. And because this is transoral robotic surgery, so basically the robotic arms are going through the mouth, which is held open by a retractor. And usually the retractor that we use is the FK retractor, which is specially designed for the robot or for the laser. And but you can do this also with the tonsil retractor. And when we started out, we were doing it with the Boyle-Davis retractor. So what is in the mouth is one 3D camera, 10 millimeter in width, and two arms on each side of the camera. One is they're both 5 millimeter arms, or at least they used to be 5 millimeter arms. The current generation, we have 8 millimeter arms. That is a bit of a disappointment, but nevertheless, they are nice wristed arms. And this is what you can do with it. So, well, here's a patient who had a parapharyngeal space tumor. And you can see the tumor. You can see that it is medial to the vessels, and so it's easily accessible transorally. And because the robot offers you 3D vision and magnification and lighting, and you have the small miniature arms with which you can work inside, so you can go ahead and do the operations. You have given an incision lateral to the anterior tonsillar pillar. You mean to get lateral to the superior constrictor muscle, and as you go down, you then will get the medial pterygoid, which is what you're beginning to see there, and then you cut through the medial pterygoid, and you will be in the parapharyngeal space. Straight, direct approach. And once in the parapharyngeal space, if it's a well demarcated benign tumor, as in this situation, then you can easily work on it. The assistant surgeon, what you see here is laterally, you can see the ICA pulsating at 2 o'clock, and then you just dissect this out with the robotic instruments, and sometimes a little help from the surgeon who's there at the patient's edge with the elevator. And so this tumor comes out. You can still see the pulsating ICA with the robotic instrument pointing towards it there, and you just need to put it back. So the basic thing is that the robot allows you to work transorally, gives you the illumination, gives you the miniaturized arms, gives you the control to be able to work. And if you can do this, then of course mobility can be greatly minimized. So the advantage is 3D visualization. You can work intraorally. Of course, the robot is designed to work with in the thorax or in the abdomen, but you can work intraorally too. Angled instruments with great degrees of motion. So it's basically like your arm. And we say that there are 7 degrees of freedom. So it can come out and go in, it can rotate. And then there is a wrist. And on the wrist, it can rotate on every side. And then, of course, there's the pincers, and you can use all these instruments. And so very nicely controlled, and you can move your camera up and down and look from different angles. It eliminates physiological tremors. It allows you to work in a very fine way, because if you make a 3 millimeter movement with your hands, it will probably translate it to a 1 millimeter movement. So there's scale motion, and you can do very nice, fine work. But if you look at really why, I mean, there's so much glamour about it, but you should look at it not as the robot, but as a transoral way of doing things. So the transoral robotic surgery is really an advance on transoral laser microsurgery. What the laser had allowed us to do was to work on the larynx, which was a line of sight, straight organ, which you could work through the mouth, and you could work there. And because you work from inside, and because you maintain the architecture of the pharynx and the larynx, and because you did not disrupt the nerves and the muscles on its outside surface, and because you did not disrupt the sensory nerves on its outside surface, your final physiological retention of physiology was so much better, and these patients swallow it so well. And the robot does exactly the same. Only thing is that you can now work on the structures which are not easily accessed by the laser. So you can work on the base of tongue, which is a major advantage. You can work on the tonsil. But the base of tongue, really, epiglottis, supraglottis, where the robot allows you to work transorally, and because you work transorally, you get the exact same advantages, and you minimize aspiration. So these patients swallow well. What the videos you see out there are basically at about 5, 7 days, 10 days after the operation, and you can have early discharge, and you can have early adjuvant treatment, and of course a low morbidity resection. This is an important slide. This slide actually tells us the indications and contraindications as to where we use the robot, and then we will tell you the oncological results that we have got out of it. So of course, many of them are stage 1 and stage 2, which means T1N0, T2N0. There's the occasional T3 tumor, of course. The T3 tumors are tumors which are 4 to 5 centimeters. You don't want too large a tumor. Below I have listed out the contraindications as to when we don't use the robot to work on the oropharynx. So of course, if there is poor transoral access because the patient has trismus or very large teeth, or because the patient can't extend the neck, or there's very narrow mandible, which basically means that there's poor transoral access, then you can't use the robot. This is unusual, but certainly one of the situations which can occur. In the tonsil cancers, if the tumor is going through the superior constrictor and going too far into the parapharyngeal space, it's a relative contraindication. You may not get too good control because it's too close to the ICA. And if there are anatomical issues that the ICA is located too medially because in the retropharyngeal space, then it may again be a dangerous operation to do. In the tongue base, I don't like doing the operation. Others do, but I don't like doing the operation if it's reaching the vallecula or going beyond the vallecula into the pre-epiglottic space. I do not think that you can get an appropriate oncological resection. And I would be more comfortable with an open approach. But as I said, if it's very deep infiltration, then you shouldn't be using the robot again because you may not get good oncology. And if both lingual arteries are at risk, then of course it may not be a great way to do the operation because that would place the anterior tongue at risk if you clip both lingual arteries in the operation. These are our oncological results, fairly good in terms of locoregional control and overall survival. At 4 years, we had 55% locoregional control and 88% survival, which compares very favorably with what we were getting previously with chemoradiation. So what you see in the slides on the right is what we got with chemoradiation in the black, and in the red you see what we got with TORS. But it's still a small series. It's still a small series, and you shouldn't take too much into it. But certainly, there is suggestion that at least in the HPV negative oropharyngeal cancers that you and I treat, if the tumor is amenable to TORS, then there may be oncological advances. There may be oncological advantages to doing this. So then how we do it is of course not just the primary excision. This is a patient who had a base of tongue T2N2B. So you have to do a neck. So we did the neck dissection, and with the neck dissection, we have clipped the lingual artery. And in fact, for every TORS resection, we nowadays tend to clip the vessel which supplies the area. So we'll clip the lingual artery or the facial artery, depending on whether you're doing a tongue base or a tonsil resection. And after you've done the neck dissection and clip the lingual artery, we would go in and do the primary excision. And of course, many of these patients may need post-op RT. So looking again as to how we do the resection, you can see the tumor on the right base tongue. You can see the epiglottis. You see that we have packed around that area. And this is the spatula. 2 arms we are using. The robot allows you 3 arms, but for transoral, there's really space for only 2 arms. So that's the incision, the superior incision, the lateral incision being marked. Traditionally, you don't take the lateral incision down initially. You're just marking the lateral incision. Then the medial incision with appropriate margin. Laterally, a little bit more careful about going too deep because you like to get a little bit more access and tumor mobilization before you go laterally, because the vessels and the nerves will come laterally, and you expect more, let's say, more surgical structures when you come from laterally. Medially, on the contrary, you can not expect any major structure, so you're working superiorly and doing an appropriately deep resection. The depth of the resection is planned as per the scan, and then you go medially and develop a plane. So this is all being done with monopolar diathermy. You can use a robot with monopolar diathermy, and there's also the option of using ultrasonic energy and laser energy, but the laser energy hasn't been a good experience in our practice, and ultrasonic is no longer easily accessible. So here you find the lingual artery branches coming in, which you clip This is the surgeon at the assistant end or at the patient end who's doing it. And traditionally, I and Dr. Sharma used to do this. So I'm not quite sure if Dr. Sharma was on the robotic console on this patient or I was one of us. Now you can see the glossopharyngeal nerve becoming obvious as you go down. And the glossopharyngeal nerve or a branch of the glossopharyngeal nerve is being sectioned. This would be just medial to the stylopharyngeus muscle, and you would expect it here. Lateral to it, you would expect the stylopharyngeus muscle. You go down and you keep going inferiorly till you get to the hyoid, because the hyoid is where you will get to the vallecula, and basically you have to make an assessment that if I excise this patient at the vallecula, would I get an appropriate resection, an appropriate margin. So you go down till the hyoid, and once you have down to the hyoid, you can feel the hyoid, then you take a resection and you remove your specimen. So straightforward operation. Because we have ligated the lingual artery, it hasn't bled too much, and also the risk of secondary hemorrhage is significantly reduced. Otherwise, these patients have a risk for secondary hemorrhage. And of course, once you have done the primary and neck, as we have done here, if required, the patient will also need post-op radiation. I've already told you the results we can anticipate in this situation. And we do also, on a fair number of occasions, use a sternomastoid muscle flap, which we have mobilized while doing the neck dissection. And this is used if we do a robotic resection and we realize at the end of the robotic resection that the robotic resection has led to a communication with the neck, which has already had a neck dissection. So in that case, you can put the sternomastoid flap and suture it in place, and this generally works quite well. So this was a publication to the same effect a couple of years ago in the head neck. Sorry. And this is another thing to show that if you have a middle 1/3 tongue tumor, wherein you can't quite access it transorally, and you generally feel that you might need a mandibulotomy for that situation, then you can use the TORS as an option to do mandibulotomy sparing. And this was again something we published earlier this year. This is one example of the same. I'll rush through this. So you see the alveolus, the lower alveolus out there. You see the tongue. You see the incision being developed along the floor of mouth. Out here is the tonsillolingual sulcus. So this is a tumor going fairly medially, and you can see the middle 1/3 tongue being appropriately section right down till the midline. So you take this right down to the midline because it's a fairly thick tumor, you can see, and beyond the midline. And then you can start to work medially a few branches of the lingual, which you will need to clip. And you continue to work along the medial resection and work posteriorly on the base tongue. Very thick, big resection. So as you come laterally, that's where it tends to help that you have a robot and you have this access to peep into the floor of mouth, because as you come from here, you can actually see structures more clearly. You can see the circumvallate papillae on the base tongue, and you can see the dissection goes far beyond the circumvallate papillae. Not something you can see otherwise unless you have this robotic scope in the mouth. So it is here you get advantages, and then you get advantages again when you come to the TL sulcus and behind, because you can see more and do an appropriate oncological resection. So incision right down till the middle of the base tongue, and then coming laterally. Wherein you separate it from the TL sulcus under vision. And you can go down deep because you have the right wristed instrument which can work there. And as you go deep, you will come to the extrinsic muscles, and you can have a good resection. So you see these fibers which are pointing forward, which is a styloglossus, and it basically means you've been through the intrinsic muscles, gotten as deep as the extrinsic muscles, and did an appropriate resection, including all these muscles. So because of the visualization and the wristed instruments, you can do things transorally which you could not have done otherwise. So you can see the resection, large resection. You don't quite need to do a big reconstruction because on the outside there's no real exposure to the neck. So now that was about TOR. So I'll take you a little bit through using the robot for thyroidectomy. This is becoming popular. As I said, I'll try and rush through a little bit. So I will rush through a little bit of this. But basically, I'll say to you that this is an option which is becoming popular because there is a demand for hemithyroidectomy to be done possibly with minimal morbidity, because there are so many nodules which are being picked up by ultrasounds. There is so much awareness. And today, I mean, I'm sure Dr. Rathore would remember that when we started out, having a thyroid nodule did not necessarily warrant surgery. We used to smile at most of the patients and say to them that this is okay, this is not likely to be risky. And I remember my undergrad professor telling me that the risk of malignancy is only 3%. But today you tell to a patient that the risk of malignancy is only 3% and he's going to jump. So society has changed, and today there are so many patients who have these small nodules who want them out. And yes, we are a risk-averse society currently, and we can detect so many more nodules. And there is the need for this operation, which can do where you can do an operation without an obvious incision. So this is remote access robot-assisted thyroidectomy done through the hairline. There are other ways of doing it. You can do it through the axilla. You can do it through the areola or through the breast. It is not minimally invasive because at the end of the day, there's a fair amount of dissection, and incision right on the thyroid is less invasive. It has no functional benefits. And we said that TORS has lots of functional benefits in that it improves swallowing. This has no functional benefits, but certainly has cosmetic benefits. Nevertheless, an operation worth doing. In our practice, we tend to restrict it to nodule size of less than 30 mm, but it has now slightly gone up. We may be doing it for 30, 35 mm too. But basically, we do the operation in a situation wherein we're doing what is known as a capsular dissection, which basically means that you can just take the thyroid and you don't quite have to take the lymph nodes along with it. So a patient who needs a closed thyroidectomy without lymph node dissection, does not have extracapsular spread, is the patient who is appropriate for this. In my book, this is also the recommendation by the American Thyroid Association, though I'm aware that there are many surgeons, especially in Korea, who would be more aggressive and can do far more. But these are our indications. So hemithyroidectomy with a relatively small thyroid nodule, 3.5 centimeter at the most, which needs a hemithyroidectomy by capsular dissection. Generally a diagnostic hemithyroidectomy. We like to do nerve monitoring, and we need the special retractor which sort of holds your skin flap up so that you can work under it. And this is how we use it. This time we use 3 instruments. There is the scope, which is the 3D scope, and it's put at an angle to make space for the other instruments, and there are 2 other instruments. A ProGrasp, which you will see, the Maryland, which you have seen, and a scissor with the monopolar. So these are rather sophisticated instruments. I'll come to that when we get there. And I'll try and move a little bit forward. So this is a patient who needs a left hemithyroidectomy under GA, and we have planned a remote access thyroidectomy. As you can see, there's a 3.6 by 2.8 a lesion in the left lobe of thyroid. So you can see the pinna, you can see the incision, and we have developed the incision. There's the pinna, that's superior, going up and looping down again in the hairline, or the facelift incision as it's called, and the flaps being developed over the sternomastoid muscle. You can see the greater auricular nerve. So you develop this flap, which you need to develop right down till the sternum, really, to get the space to be able to do your thyroidectomy. And now you see from a slightly different angle. This again, the pinna there, the flap being raised, working on the sternomastoid, pushing the sternomastoid down with your finger to be able to get the traction to be able to raise a flap. Now you see inside. Now you're looking from inside the incision. You can see the anterior or the lower inferior edge there, and a sublatissimal flaps being elevated. This is medial, this is lateral. This, of course, is cranial. And you can see the sternomastoid being pushed down, and the surgeon working down that pocket, looking down that pocket to develop a flap, which continues right down to the sternum. Very carefully, you need to use diathermy. And then once you have made the full flap, then you can see the sternomastoid muscle there again. I'm now looking for the strap muscles, which basically means the omohyoid here, which you would find going from the sternomastoid to the straps. I have difficulty in finding it, so I'm retracting the sternocleidomastoid away by this suture, which is coming in through the skin. This is again a fairly standard practice that we have developed now, learned it by watching the Koreans do this. So the sternomastoid is retracted, and now again working on the omohyoid. Find the omohyoid. You have to be careful here because you know the omohyoid is right on the carotid sheath, on the IJV and the carotid. So just hug the omohyoid, go under it, and basically if you go under the omohyoid, you will get to the plane between the straps and the thyroid. You don't need to cut the omohyoid, but I've now started to cut the omohyoid as a routine because it gives you a little bit better access. So cut the omohyoid, find the right plane between the thyroid and the straps, and lift this up. And it all seems very tedious, and it is a little bit, but with practice it gets better. And there really is the thyroid that you can start to see now, that you see the thyroid. And you put in a retractor and it gets a little bit better. And you see this retractor coming in, and the self-retaining retractor, as a self-retaining retractor, it comes in, pulls up, and you develop along the straps, and you can see the left lower thyroid coming into view. As the self-retaining retractor fitted onto the edge of the table, the robot comes in, both with its, and now it's the robot. But this time you're using the robot with 3 arms. So you have this, which is a holding instrument, which is what we call the pro grasp. On the left, you have an instrument, which is the Maryland, but which also has a bipolar. And on the right, you have an instrument, which is a scissor, but which is also a monopolar. And you're dissecting by holding the upper pole up, and you're trying to define the upper pole. That's like you do in a normal thyroidectomy. So you can see that you have a fine scissor, which is also a monopolar. You have an instrument on your left side, which is the Maryland and the bipolar. So it's a kind of a forceps, like kind of an Adson's forceps with a bipolar fixed on it. The upper pole being developed, you can see the vessels along the upper pole. We haven't yet seen the superior thyroid nerve, which we're looking for very carefully. Of course, the artery and vein are here. And now, after having isolated the artery and vein, you buzz them and cut them. So the bipolar to buzz them, and the monopolar or the scissors to cut them. The same with the artery. And then you sort of go on carefully. As you dissect, you can see the external branch of the superior laryngeal nerve on the cricothyroid muscle, which is being confirmed with the nerve stimulator. And then you work laterally like you normally do. And you can see that the tubercular zuckerkandle is slowly coming into view. Here, the tubercular zuckerkandle, and you pull the tubercular zuckerkandle up, and you can already see the nerve there. And you can develop this dissection a little bit better. You can, of course, mop. This is the assistant again on the patient's side, and you can see the nerve. And you can see the parathyroid there, superior parathyroid, the nerve, the superior parathyroid. You can dissect, and basically it's the same operation. So the nerve stimulator to check that the nerve is functioning, or to recheck the nerve. It's pretty obvious, but if you have a nerve stimulator, you might as well check. So the same operation slowly developed forward. I'll skip a little. As you go laterally, you have to be very careful that you don't find a middle thyroid vein. And then you sort of raise it laterally and come to raise it till the isthmus. This is the isthmus. And then you sort of bipolar the isthmus and cut the isthmus. So basically it's the same operation, but it's a lot of dissection to get to the area where you want to do the operation rather than a straight incision. You do it through a retroauricular incision, create a pocket, put in your retractor, and then get your instruments in. And that essentially is the hemithyroidectomy being completed. So you can see the trachea now. You can see the trachea. You can see the other thyroid a little bit on the isthmus and the other side of the thyroid which is dropped in. You can see the three instruments, the ProGrasp, the bipolar with Maryland, and the scissor with the monopolar. And that really is all there is to it. We generally put a little bit of gel foam or something and just close the whole, let the whole flap drop in with a small suction drain brought out again from the hairline. That's the specimen. As you can see, it's possible to do a hemithyroidectomy plus isthmusectomy quite competently and quite safely. I can't say we've had no complications. We did have recurrent meningeal nerve palsy in the early part of our experience, but that fortunately recovered. So a good way to do this, it has only cosmetic benefits, as I said, but nevertheless, there is certainly joy in seeing a patient, both for the patient and for the surgeon, I think, in having a virgin neck after doing an appropriate operation. So moving on to TAUS, a few minutes that I have left. So TAUS is transoral ultrasonic surgery. Use the same retractor like for the robot. You have this flexible tip endoscope which you put in through the mouth. You have both 2D and 3D options. We generally use a 2D option because it's a slimmer scope. Sometimes you can use a 3D option. And this is how the scope is going in through the retractor. If you look here on the inset, you see how the scope is coming in and you see the picture. And because flexible tip, you can move it around a little bit and get a little bit better access. Once you have happy with the access, then you can fix the scope. And you see that here on the inset that you have a stand which fixes the scope. So now you have a stable situation with a fixed scope, and you can get in these instruments which are being held by the surgeon, one in each arm. The assistant holds the suction, and you can do what you want to do. In this particular patient, it was only a benign situation, but I'll take you a little bit further. This is a patient who has a tonsil tumor and a fair bit of superficial dysplasia, maybe carcinoma in situ, maybe. So a fair bit of tumor here. The TAUS gives you the advantage that you can also combine it with narrowband imaging. The system comes with narrowband imaging, so that gives you a little bit better access as to the margins of the tumor. Very good for superficial tumors, like you can see these small corkscrew areas. And then again, the tonsillar anterior pillar, the posterior pillar, all this tumor, which is rather superficial but rather irregular. And you're again developing a plane lateral to the superior constrictor, as we did for the parapharyngeal space tumor. So lateral to the superior constrictor, you develop this plane to include a fairly deep resection, which includes the superior constrictor. So you can get this plane between the superior constrictor and the medial pterygoid muscle, which you will get here, and move forward along it. This is better than the robot in terms of hemostasis, but of course it's not as precise, so there's a price to pay. So you have developed the incision lateral to the superior constrictor along the anterior pillar. You can see the medial pterygoid a little bit there. And then you can see the tonsillolingual sulcus. And because all of this needs to be included, so you're including a fair bit of tongue. Again, the advantage is you can work transorally. So a good excision, which includes a tonsil, which includes a tonsillolingual sulcus, a bit of the tongue, connects. And then as you push it downwards, you can see this fascia lateral to the superior constrictor. And There's probably some of the palatoglossous kind of fibers which are coming into the tongue, which you take. Out here, you see some branches of the glossopharyngeal nerve, which are slowly becoming obvious. So you do get remarkably good vision, which can be both 2D or 3D, depending on how you want it, and you slowly work along it. The basic advantage, again, is the same. It's the transoral operation. What instrument you use, laser or robot or ultrasonic, is really immaterial to the patient. They all give you similar outcomes in terms of preserved functional swallowing. Because you can see the nerve, you can preserve the nerve, and of course, you can preserve the muscles laterally. And that is the resection, a fair bit of the posterior pharyngeal wall, a little bit of the prevertebral fascia, the outer muscles of the pharynx, the constrictor has been taken, but the outer muscles, the palatopharyngeus, still there, and the epiglottis. So this is TAUS. So how does TAUS and TORS compare? TAUS is cheaper. I'm not saying it's cheap, but it's certainly much cheaper than the robot. It's easier for the surgeon because you can schedule at your own will. You own the equipment. It's not that you're sharing the TAUS or the robot, and you have to work with other departments to get your time slot. In terms of access, it's a little bit better because the scopes are smaller, are thinner, and because the hemostasis is so much better, because you see how little the opening is, and you can't get your TORS into in someone with such limited opening, but you can get your TAUS in. And because there is such good hemostasis that you are confident to work, just like surgeons, general surgeons are confident to work in the thorax and in the abdomen with these instruments, because there's such good hemostasis that they don't need any open exposure or any open because there's such good hemostasis, you're confident to work with lesser degrees of mouth opening. The robot certainly scores in terms of having more wristed instruments. We saw that in the video, and you saw as to how this current generation of robotic instruments actually combines instruments. You have the bipolar with the Maryland, you have the monopolar with the scissors. So there is so many more instruments you can get in with the robot. With the TAUS, at the one moment, a surgeon can hold only 2 instruments. But of course, you can always take one instrument out and get another one in. But you can't have 3 instruments in at the same time. It becomes difficult. So the TAUS also has the advantage of having NBI. So you see NBI out there. So these are the advantages. The problem with both is secondary hemorrhage. You were initially told that TAUS is very good in terms of bleeding, and so you won't get secondary hemorrhage, but that is not our experience. You can still get secondary hemorrhage. And because you can get secondary hemorrhage, it's sensible again to tie the vessel. If you're doing a TAUS operation, it's sensible to use a sternomastoid flap, which in this case is placed medial to the carotid, and you can see it here in the tonsil fossa. And this is a very simple, straightforward way of sealing small defects that tend to occur after a TORS or a TAUS situation. You can also use it as for a thyroidectomy. We have only experience with one patient. It's not as convenient as the TORS because you get only 2 instruments, not 3. But again, we are not the only institutions who are using endoscopic, non-robotic thyroidectomy, and it is one of the ways of doing it, and you can do it, and it works reasonably. So this is a thyroidectomy remote access being done with TAUS instruments, and this is also feasible. So I say thank you with the message that when you talk about TAUS or TORS or laser, always remember it's a transoral way of doing things which gives you the basic advantage. And if you can do that same operation, the same oncology by a transoral than with an external approach, then it's a good way of moving forward. So thank you.
Thank you, sir. It was a very informative session on recent advances, robotic surgery, TAUS in ENT. I would like to invite comments from the faculty.
Hello, Alok. Hello.
Yes, Ishwar.
Alok. Very well presented, very informative. How much is the margin in base of skull, base of tongue you take for this resection?
So clinically, I tend to look at 1.5 centimeter margin and sometimes 1.2, 1.5 centimeter. You know that histologically you're aiming for a 5 millimeter margin and allowing for the shrinkage that you might occur and allowing for the fact that there will be submucosal spread which you will not pick up. My general rule of thumb is 1.5, sometimes 2 centimeters mucosal margin on the gross specimen.
And do you allow this wound to heal secondarily with granulation, or you put some flap or something, or you just leave it open?
So it's a mix of primers. Yes, so when we use the flap, our first option flap is generally the sternomastoid muscle flap, as I showed you. It's a quick, easily accessible flap which you can get into the field very quickly, and that is what we tend to use. But we have used some other flaps too. We have used the FAM flap, and otherwise you use primary intention closure or part primary intention and part secondary intention. So I mean, you will close it, but you will also leave a little bit of raw area, which will be mucosalized.
And then you take a frozen section also?
No, it is not a usual practice to do frozen sections with TAUs and TORs because there's a fair amount of burning because with these instruments when you use them on the it's not we may take a strip for on occasion we may take it, but it's not routine. It's not routine to do frozen.
Thank you.
Right. So these are basically operations which have been designed as standard operations for a base tongue resection or a tonsil resection. And you do the full resection and try and fit the tumor to the resection.
Hello.
Thank you.
Yes,
Hello.
sir. Thank you. Thank you.
Thank you.
Moving on to today's last session, most awaited is discussion. I'm sure no resident will want to miss this session. We have Dr. Nimisha PR and Dr. Abhinav Agarwal to present the case. And to moderate the session, we have expert faculties, Dr. SPS Yadav, ex-professor and head, PJ Rohtak, Dr. NN Mathur, professor and director of Lady Hardinge Medical College, Dr. Khaja Nasruddin, professor and head of Hamdard Institute of Medical Science and Research, Dr. Arunabh Chakravarti, professor, Lady Hardinge Medical College, and Dr. Ashok Kumar, professor, Ram Manohar Law here. Over to Dr. Nimisha PR and Dr. Abhinav Agarwal.
Hello. Hello. So,
Good evening, sir.
Good evening. We don't have Dr. Mathur on board right now. I will request the faculty, Dr. Rathore, Dr. Pasi, and Dr. Ishwar Singh. They are here with us. So I would request you to please give your inputs in the case discussion if required. Thank you.
Okay.
Sir, can I start?
Yes. You can start, Nimisha. Start.
Okay, sir. Good evening, all. Today, I'm presenting the case of a 19-year-old female, Sangeeta, who is a resident of Selampur, Delhi, and who is a housewife. She presented with chief complaints of bilateral ear discharge since childhood and bilateral ear decreased hearing since 5 years. It was more on the right than the left. She also complains of deviation of angle of mouth to the left and difficulty in closing the right eye since the past 1 month. She also complained of right neck swelling since the last 10 days. The bilateral ear discharge was since childhood, and it was insidious in onset, and it was continuous, scanty in amount, purulent, foul smelling, and it was occasionally bloodstained. There were no aggravating or relieving factors. She also complains of decreased hearing, which was more on the right side since the past 5 years, which was insidious in onset, gradually progressive, and she was not able to hear whisper, but was able to hear and understand normal conversation, telephone ring, and doorbell.
Her daily activities were not hampered. She preferred left ear more than right during telephonic conversations. There was no history of any fluctuant hearing loss. There were no aggravating or relieving factors. There was also history of deviation of angle of mouth to the left with drooling of saliva and inability to close right eye since the past 1 month. And this was insidious in onset, non-progressive. There were no aggravating or relieving factors, and it was also associated with watering from the right eye. It was also, she also complains of right upper neck swelling since the past 10 days. It was insidious in onset, gradually progressive. Initially, it was small in size, now has increased to the present size to around 3 into 3 centimeters. It was also associated with pain. There are no history of any other swellings. There were no aggravating or relieving factors. There was no history of earache, fever, no history of ringing sensation in the ear or giddiness, no history of pain behind the eye or double vision, no history of headache, neck rigidity, vomiting, or blurring of vision. There was no history of gait abnormality or seizures, no history of focal neurological deficits, and no history of recurrent URTI. There were no history of any other ENT complaints. Past history. There was no history suggestive of tuberculosis, diabetes mellitus, hypertension, jaundice, or epilepsy. No history of any surgical interventions, and no history suggestive of blood transfusions or drug allergy. Personal history. She had a normal sleep pattern, normal bowel and bladder habits, and there was no history of addictions. The family history was not significant. Menstrual history. Her last menstrual period was on 9th of November, had a regular 28-day cycle. Socioeconomic status, she is married to a farmer and has belongs to a 5-member family, lives in a 3-roomed pakka house and belongs to upper lower socioeconomic class according to modified Kupaswamy scale.
Good evening, sir. Sir, I will continue with the examination.
No, I think
just hold on.
Dr. Yadav.
Faculty interact with you.
Thank you. I'm Ashok here.
Yeah.
Can you
Good evening,
summarize
sir.
your chief complaints and history and chief complaints?
Yes, sir. Sir, it's a 19-year-old female with chief complaints of bilateral ear discharge, bilateral decreased hearing, which was in childhood, and bilateral decreased hearing for the past 5 years. And she developed deviation of angle of mouth since the past 1 month and right-sided neck swelling since the past 10 days. The family history, personal history, or menstrual history or was not significant.
Did you ask about how much is the hearing loss?
Yes, sir. She was able to hear, not able to hear whisper, but was able to hear the normal conversation.
Okay. Thank you.
Thank you, sir.
Was there any history of pain?
Sir, there was no history of pain.
In a case of CSOM, if
Yes.
there is a history of pain, what will you think of?
Sir, any history of earache or headache usually is an ominous
Not
sign.
headache. I am
And
just asking pain here in case of CSOM. What are various conditions?
sir, it usually points to any complications such as mastoiditis or lateral sinus thrombosis, or even in cases of abscesses, the patient can have aches, earache.
Any others?
Even in meningitis, there can be.
You are going to the complex things, simpler things. Have you
Sir,
seen
abscesses.
that you
Mastoiditis.
told complication is 1 point. If you tell 10 complications, still it is a 1 point. Even undergraduates tell 4 points.
Sir, mastoiditis, then
That you have told, if you say mastoiditis 10 times, that doesn't mean you have told 10 things.
in acute otitis media, patient can have pain.
Is this a case of acute?
No, sir.
Then can there be otitis externa in these cases?
Yes, sir.
Will there be pain?
Yes, sir. Otitis externa is
Any other
associated.
condition?
So, what is the
Sir,
kind of pain in otitis, malignant otitis externa?
Sir, deep throbbing pain.
What is the typical thing you can diagnose with the history of pain in otitis externa? What type of pain it is? Is it in the night, morning, evening, or 24 hours?
What is the diurnal variation of the pain, sir is asking?
Have you seen any case of malignant otitis externa?
Yes, sir.
So what were the findings? How did you diagnose that case?
Sir, there will be an extensive, excruciating pain, inflammation, and
Patient usually has some immunocompromised condition and some malignant otitis externa.
Now, what will you find in
they are
the?
discharged.
What are your clinical findings? Sir is asking. How do you diagnose?
This pain is at night. These
Sir, there
patients complain pain at night.
Okay,
Have
sir.
you any other condition? Do you know any other condition where there is a pain at night and you diagnose immediately this is a case of this? Any orthopedic condition? You have just passed out MBBS, no?
Yes, sir. Oh, sir.
Chal, proceed.
Sir, should I continue with the examination, sir?
Oh, yes, continue.
Yes, sir. Good evening, sir. Sir, general examination, patient was conscious, oriented to time, place, and person. General condition was fair, and patient was afebrile to touch. Blood pressure was 110 by 70 millimeters of mercury in the right arm sitting position. Pulse rate was 80 beats per minute, regular, normal in volume and character. Respiratory rate was 12 breaths per minute, regular, thoracoabdominal. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Sir, on local examination, sir, on pinna, there was no abnormality detected in both right and left ears. Sir, preauricular region and postauricular region were also normal in both the ears. Sir, I'll continue with the right ear. Sir, there was no tracheal tenderness or mastoid.
Hello. So what do you mean by a normal preauricular region and a normal postauricular region?
Sir, by normal preauricular and postauricular region, I mean there was no abnormality like preauricular scar or sinus fistula or any tags or any swelling.
What is the cause of preauricular scar or fistula?
So preauricular scar is suggestive of any
fistula.
Yes, sir.
Preauricular region you got fistula?
Sir, sinus.
Huh?
So preauricular
You got
sinus.
fistula or sinus in preauricular region?
Sinus.
Sinus, sir. Sinus.
So what all you observe in the postauricular region?
Sir, postauricular region, sir, again, first of all, I will look for the retroauricular crease, groove, then the appearance, then I will look for any swelling. Again,
So
sir,
what
any
is the
scar mark.
normal appearance or normal filling of the postoral groove or the postoral region?
Yes, sir.
So what is the normal filling? If you palpate that area, what is the normal filling of this postoral?
Sir, it is not smooth. It is, sir, it is a bit grated sensation, sir.
It's an irregular.
Regular surface.
Okay, continue.
Yes. Sir, there was no tracheal tenderness or mastoid tenderness in the right ear or left ear. Sir, on examination of the external auditory canal, there was purulent discharge present in the right ear. which was cleaned. Sir, then on examination of the tympanic membrane,
tenderness, where are you just tragal tenderness? That's it. Where else you elicited?
Sir, mastoid tenderness and tragal tenderness.
What is the site of
other sites of tenderness you look for?
Sir, at the pinna, in otitis externa.
Sir, in the 3-point region.
3-point tenderness in the mastoid region, at the Simba concha, at the tip of the mastoid and the lateral process of the mastoid.
Lateral process indicate what? If there is a tenderness at the lateral process, it indicates what? Or you just go?
Sir, that it is involving the mastoid region. Sir, basically
pardon, before you proceed, just hold the discharge. Please describe all the characteristics of this ear discharge, what you are seeing, all the characteristics.
Yes, sir. Sir, it was a purulent ear discharge, which was not blood-stained, but foul-smelling ear discharge.
Color?
Sir, it was yellowish in color.
Various characteristics of a discharge, then you can answer well.
Sir, characteristics of the discharge, sir, it can be either blood-stained or foul-smelling or mucoid, purulent or mucopurulent.
In discharge, first has to be what is the amount, then appearance, then the character. So, what Dr. Sir is asking, what are the features of a discharge that should be described? What is the amount?
Sir, amount, it was scanty, sir. Scanty.
And when is the profuse and moderate amount?
Sir, moderate amount is generally in safe type or the tubotympanic type of chronic otitis media, moderate or profuse, when the discharge completely fills the AC and spills out of the AC during sleep.
What is reservoir sign? Reservoir sign?
The reservoir sign is basically when the disease has involved the mastoid region and the pus accumulates in the mastoid cavity. So as soon as we clean the discharge from the external auditory canal, it again fills from the mastoid cavity. And it occurs because the mastoid cavity is a larger cavity compared to the middle ear cavity.
Can you see the mastoid cavity?
Yes, sir.
Can you see in mastoid cavity?
No, sir.
In a patient of CSM, when there is a reservoir sign is positive, can you see the mastoid cavity? You see,
Sir, we cannot see, but
you cannot see.
We cannot see. Does the discharge fills again as soon as we clear it?
Then where discharge collected?
Sir, in the.
It comes out from the EAC end. Where did?
Sir, from the middle ear.
External auditory canal.
In other words, which type of mastoiditis is there when their reservoir sign is positive?
Coalescent mastoiditis.
Coalescent mastoiditis.
Why the simple answer? Why are you running around?
My question is, coalescent mastoiditis, is it a safe disease or unsafe disease?
Sir, coalescent mastoiditis elicits symptoms, so it is safe disease. It can be managed.
So, what is the other type of mastoiditis which will attribute as a unsafe disease?
So, masked mastoiditis or subclinical mastoiditis, which does not elicit any symptoms, but the disease continuously progresses and can lead to intracranial complications.
That masked mastoiditis, how will you diagnose a case? What are the findings in masked mastoiditis?
Sir, in masked mastoiditis, there is no typical clinical features. There is no ear discharge, but subclinical disease is progressing in the mastoid.
How will you diagnose?
What
will be the symptom?
Sir, there may be earache, mild earache, or fever.
Fever? Never.
What is masked? Which clinical feature is masked?
Sir, the ear
features
will, yes.
Yes, one by one. Okay.
Sir, the signs in the that can be usually associated with like otorrhea, ear discharge will not be present.
Which thing is masked? Which thing is covered in this type of mastoiditis? Right? Which thing is?
Ear discharge.
Very good. So why it is masked?
Because the tympanic membrane will be intact but bulging.
We are giving so many antibiotics, common things you tell me. Okay, so the symptoms become masked and we are looking at a different type of picture. So that is why it is known as masked.
Continue with the otoscopic finding.
Continue.
Yes, sir. Sir, I'll describe right tympanic membrane first. Sir, pars tensa, there was an inferior marginal perforation. Sir, posterior superior retraction pocket was present. Discharge was present. Fundus was not seen of the retraction pocket. Granulations are present adjacent to the lateral process of the malleus. Anterior part of the pars tensa was intact, but the cone of light was distorted. The handle of malleus was foreshortened. Other ossicular landmarks were not visualized. Pars flaccida, there was no abnormality detected. On cingulation, cholesteatoma flakes were seen. The anterior pars tensa was mobile, suggestive of grade 1 retraction.
You are saying a cholesteatoma on cingulation.
The flakes were seen, movement of the flakes.
Is this the way to describe a cingulation? You are seeing a cholesteatoma flakes on cingulation finding. You should be able to see on otoscopy only. If there is a cholesteatoma flakes, you should be able to see on otoscopy.
In other words, what is the role of cingulation?
So cingulation is to look for the movement of the tympanic membrane or to differentiate.
That's all.
No. Doctor, don't be in the trap of examiner. See, cingulation is a 10 diopter lens, okay, and it has a side tube. This you don't have. What we have in horoscope we have. Otoscope is not a part of cingulation. Magnification is less. You can do less function. So don't be in this trap of the examiner. You answer properly. This is not a proper cingulation.
Cingulation can also be.
Anyway, you think the cholesteatoma is in the attic?
Yes, sir. Sir, in the posterior superior region.
In the attic and posterior superior region, both?
Yes, sir.
First you said in the posterior superior region, then you said attic, and now you are saying both.
Sir,
do you think they are synonymous?
Sir, in the posterior superior region, sir. Sorry, sir.
Say posterior superior, why are you running around?
So she is a girl of 19 years. The discharge is since childhood.
Yes,
so what do you think is the type of cholesteatoma you are dealing with?
Sir, it may be due to the tubal obstruction. So it may be due to adenoid hypertrophy leading to eustachian tube obstruction that may have caused retraction of the tympanic membrane leading to cholesteatoma.
Do you think it's a primary? Do you think it's a primary acquired cholesteatoma or a secondary acquired cholesteatoma?
Sir, primary acquired cholesteatoma.
It's a primary acquired cholesteatoma.
Yes.
With
Patient is having discharge since childhood, and now the patient is coming with a picture of cholesteatoma. So whether it is primary acquired or secondary acquired.
Sir, there is no history of any. Sir.
This patient gives the history of ear discharge since childhood, isn't it?
Yes, sir.
So do you think it's primary acquired or it's a secondary acquired cholesteatoma?
Sir, primary acquired only, sir. Patient.
Why do you think it's primary acquired?
Sir, there is no history of any previous surgery or trauma or.
Sir, it can be secondary acquired also in childhood. She may have developed a perforation in a safe type of CSOM, and then there would have been epithelial migration, which would have led to there are also chances that it could be a secondary acquired cholesteatoma also.
Can it be congenital cholesteatoma?
No, sir. There is, sir, perforation in the tympanic membrane.
Yeah.
So it cannot be congenital cholesteatoma.
So what is the typical presentation of a congenital cholesteatoma?
So the typical presentation of congenital cholesteatoma is given by Levinson's criteria. So the pars tensa, there should be no perforation in the tympanic membrane. It's a white pearly mass behind an intact tympanic membrane, and most commonly in the anterosuperior quadrant.
Do you have any grading of congenital cholesteatoma?
Yes, sir. There is
So what is the grade? What is the grade for congenital cholesteatoma?
So grade 4 congenital cholesteatoma means when it has involved the ossicles and the mastoid antrum region.
Sir, it can be grade 1, 2, 3 or 4. 1 is involving 1 quadrant, 2 is 2 quadrants, and 3 is when it involves the ossicles, and 4 when it has involved the mastoid also.
Is this patient a pediatric patient or an adult?
So she is now 19-year-old.
Okay,
Adult.
19 years old.
Hello. Hello.
Yes. Yes.
Doctor,
Yes, sir.
Congenital cholesteatoma common site. Where is the common sites?
Sir, anterosuperior quadrant is the most common site.
Okay. Any other
Any
common
other site?
Sir, then the posterior superior, then anteroinferior.
फिर आगे और कोई site, common site where it can be
Sir, it
present?
can be in the middle in the mesotympanum region.
It can also
Can
be
it be in the
CP angle
petrous
or
apex?
petrous apex or CP angle tumors. Cholesteatoma can be congenital.
So it congenital means it is coming at an early age. I want to say congenital means patient will be symptomatic at early age. Am I correct?
No, sir.
No,
Why?
Sir, because congenital cholesteatoma occurs mostly due to an embryonic cell rest, which usually progresses and leads to symptoms, disease progression leading to ossicular erosion. Sir, after it takes time, sir, and usually.
What is petrous apex syndrome? It takes long time to appear.
Yes, sir. Sir,
Okay.
Yes, sir.
Okay, you got the sixth nerve. All right.
Yes.
So it takes a lot of time. Now my question is the congenital cholesteatoma a hereditary disease? Hereditary disease. Is the congenital cholesteatoma a hereditary disease?
Sir, it is not passed through generations, sir. It occurs due to an embryonic cell rest, which remains in the middle ear.
Yes.
But
so it is a developmental disease. It is not a hereditary disease.
Yes.
Okay. Clearly,
Yes.
you should make it. Don't get confused. Huh? Right.
In case of if you are dealing a case of pediatric cholesteatoma, so what is the incidence of congenital cholesteatoma in terms of percentage you get? A case of pediatric cholesteatoma, in how much percentage you can get it is as a congenital cholesteatoma. The diagnosis is a congenital cholesteatoma.
Sir, it is very rare, sir, but I'm not sure about it.
No, somewhere in the literature it is mentioned in the range of 10 to 28% of pediatric cholesteatomas are congenital cholesteatomas.
Sorry, sir.
Can move forward, I think.
Sir, now I'll describe the left tympanic membrane. Sir, the pars tensa, there was an inferior central perforation. The remnant was retracted. The remnant of the pars tensa was retracted and congested. So there was a posterior superior retraction pocket filled with cholesteatoma flakes, but the fundus of the retraction pocket was not visible. The cone of light was distorted. The handle of malleus was foreshortened. The other ossicular landmarks were not visualized. Pars flaccida, no abnormality was detected. On cevalization, pars tensa was not mobile, which was suggestive of grade 4 retraction.
So the retraction pocket is in the posterior quadrant.
Yes, sir.
Rest of the tympanic membrane is normal.
Yes, sir. Yes, sir. It is retracted, sir. Pars tensa is retracted, but no perforation.
What is grade 3 retraction? If it is
there is a perforation, and why there is a retraction? Then you can see anteriorly there is a big perforation.
Sir, on anterior inferiorly there is a central perforation. Sir,
yeah,
rest
big
of
perforation. Why there should be retraction?
Initially, there would have been retraction, and later on, perforation would have been formed. Sir.
Is it a God's help then?
So once the perforation occurs, it should be relieved.
Sir, it is grade 4 retraction which gets adherent to the promontory. So
how do you know it is adherent to the promontory?
Will you do a signalization?
Yes.
In a perforation, will you do a signalization?
So why this posterior-superior quadrant is more prone to develop retraction pockets?
Sir, posterior superior quadrant, sir, the fibrous layer of the tympanic membrane is not organized as in the rest of the tympanic membrane. Secondly, the blood supply is more, so there are more inflammatory markers, which leads to more changes due to the disease, leading to its the posterior superior quadrant being more susceptible for a retraction pocket.
Something else you'd like to add?
The ventilation is less at this point.
So why do you get less ventilation in the posterior superior quadrant?
Sir, due to the position of the eustachian tube.
It has been mentioned that there is less ventilation in the posterior superior quadrant. In one of the studies, it has been mentioned in 25% of the cases, there is the absence of circular fibers of the lamina propria in the posterior superior quadrant. So it is the posterior superior quadrant has only radial fibers. Circular fibers are absent.
Yes.
So less capable to respond to the pressure changes.
Yes.
Yes, sir.
Nimisha, this question
Yes, sir.
explains why is this perforation? Now there is a retraction. Is it?
Yes, sir.
Is it some God's help to the patient?
So now it will help in maintaining the pressure of the middle ear through the perforation.
My
So
question is it a God's help? Again, I am.
yes, yes, sir, yes, sir. It is.
So who proposed this theory? Hello, it is Sade's theory. It is a God-sent ventilation tube in case of retraction. Okay.
Okay, sir.
Yes, sir. Sir, continuing with the examination of the tuning fork test, sir, for 256 hertz, it was negative for right ear. On 512 hertz, it was negative for right ear, and on 1024 hertz, it was positive for right ear. So similarly, on left ear, it was negative for 256 and 512 hertz, and positive for 1024 hertz. So the Weber's was lateralized to the left ear. Absolute bone conduction, it was bilaterally not shortened.
You are right.
How much the hearing loss?
Yes, sir.
You are right-handed or left-handed?
Basis of tuning fork?
Sir, sorry, sir.
You are right-handed or left-handed?
Right-handed.
Which hand you have used to do these tests?
Sir, right hand.
You are sure? Where was your left hand when you did the test?
Sir, with the left hand, I vibrated the tuning fork and then.
With the left hand. What? You are right-handed. Right-handed person will always vibrate from the right hand.
Sir, the bony prominence was used of the left hand, but the tuning fork was held in my right hand.
वो तो आपने vibrate किया. What after that? When you place, say, on the masthead with right hand, what do you do with the left hand?
Sir, the head is fixed.
You use both hands for doing all these tests. You have written Rene test, Weber test, Schabeck test, but you have written ABC test. Why this ABC? Why there is no name with? Otherwise, every scientist is very fond of writing his name. Say Bing test, all these tests. You have read, no? Rene
Yes,
test, Weber test, Schabeck test, Bing test. Why there is no name with ABC?
Sir, it is actually a comparison with the examiner. So there is.
So there is no need of any name. Schabeck also you compare.
So why do you keep the vibrating tuning fork while doing the Rene test?
Sir, for bone conduction, we keep at the mastoid tip.
And while doing the air conduction, I tell you to keep the vibrating tuning fork in the acoustic axis. So what do you mean by this?
Sir, the prongs of the should be facing the external auditory canal, sir.
Parallel to the.
At what distance from the external auditory canal?
Sir, around 2 to 3 centimeter away, sir.
Around 2 centimeter. Parallel to the?
The prong should be parallel, sir. And to the
parallel.
Which tuning fork you have used?
Sir, for Renis, we have used all the 256 Hz, 512 Hz, and 1024.
256 is usually not used. You usually use 512.
Yes, sir.
Yes or no?
Yes, sir.
Why you use 512?
Sir, there are multiple reasons. First of all, 512 Hz is in the auditory frequency, in the speech frequency. Secondly, sir, it has, sir, adequate amount of overtones, and the tone decay is adequate, sir, for examination. It has less tone decay as compared to 102.
Adequate amount of overtone. What is overtone?
Sir, overtones is any frequency above the frequency of the defined frequency of the.
What will be the overtone of 512?
The more the higher frequency sound from 512.
No, what will be that higher frequency? Define.
Sir.
When you don't know what is overtone, why are you uttering this word? And this is wrong also. Any other point you tell?
So the tone decay is also, sir, less.
Tone decay is what?
So the amount of time it will, the tuning fork will vibrate.
You say decay time is adequate, not tone decay.
Decay time is adequate.
So that you can go to the bone as well as the air conduction. Any other point?
Sir, it lies in the, sir, speech frequencies.
That you have already told. This answer is not complete, and this is an undergraduate answer. You try to read it.
Yes.
What was the ABC?
Sir, it was not shortened, sir, bilaterally.
So what is your inference?
Sir, that there is no sensory neural hearing loss in the patient, sir. Okay. As compared to.
Can you get sensory neural hearing loss in otitis media, chronic otitis media?
Yes, sir, we can get sensory neural hearing loss.
Yes.
Sir, due to if the toxins get passed through the round window membrane, bacterial exotoxins, or any ototoxic drug has been used, or if the disease, if the cholesteatoma progresses and it involves the, sir, cochlea, sir, inner ear structures.
Okay. So, what is the amount of loss you think?
Just tell the various parts of the tuning fork.
Sir, tuning fork consists of the, sir, the two prongs, then the shoulder, the, sir, neck, and, sir, the
stem
base,
and the
sir.
base.
Stem and base.
Any other name of prong which is more proper?
So, what is the amount of conductive loss in this patient?
Sir, I expect as the Renis test, 512 Hz is negative and 1024 Hz is positive on both the ears. I expect around 30 to 45 decibel of hearing loss in both the ears, sir.
30 to 35 decibel loss.
30 to 45.
30 to
45.
30 to 45 decibel loss. Can you explain this loss?
Sir,
how the patient has landed in this 45 decibel loss according to you?
Yes,
what
sir,
all
sir.
has been affected?
Sir, in both the ears, we saw, sir, there was tympanic membrane perforation. And secondly, sir, there can be, sir, ossicular erosion as the incus IS joint was also not visualized. So there may be long process of incus may have been, sir, necrosed.
Can you explain this on the basis of an ossicular coupling and acoustic coupling?
So, sir, acoustic
has this
coupling.
been affected?
Yes, sir, it has been affected.
How?
Sir, the oscicular coupling, acoustic coupling is when there is a phase difference in when the sound reaches the oval window and the round window, and the oscicular coupling is basically by the tympano-ossicular system. So the vibration of the tympano-ossicular system when there is erosion of the ossicles and when there is perforation in the tympanic membrane, the oscicular coupling is affected. Whereas in case of acoustic coupling, when there is a tympanic membrane perforation, it directly the sound waves directly reach the oval window, and therefore there is increase in the acoustic coupling.
In a normal ear, is it which one is dominant?
The oscicular coupling is dominant.
Huh?
The oscicular coupling is dominant by about 60 decibels.
Yes. So in a diseased ear, how the acoustic coupling takes over?
Sir, when the oscicular coupling is affected, the total contribution is around 60 decibels. So when the vibration of the tympanic membrane is affected and the oscicular vibration is not there, this will be so there will be a decrease in 60 decibels. And the but the when there is a perforation, the sound directly hits the oval window, and therefore the acoustic coupling will be more dominant.
Okay.
Which is the ossicle which is mostly eroded?
So the lenticular process of the incus and part.
That part is commonly eroded.
The lenticular process and the yes, sir.
Excuse me.
Why that part is eroded?
Sir,
excuse me here.
Yes, sir.
See, the Rene is equally negative in both the sides.
Yes, sir.
ABC is not shortened on both the sides, but Beeper is lateralized to the left. Is it significant?
Yes, sir. Sir, it signifies that the conductive hearing loss is more in the left ear as compared to the right ear.
But the disease appears more on right side or left side?
Sir, disease, sir, clinically it appears, sir, cholesteatoma is present in both the sides, sir.
You can have this one side more amount of conductive loss than the other. You can have this.
Yes, sir. Sir, first to look which has more progress, which has, then we may have to look for a radiological investigation, sir.
So, doctor, I give you a clinical situation.
Yes, sir.
In left side, the picture is like left side, and there is a minimal cholesteatoma.
Yes, sir.
So you would like to operate this patient or use medical management?
Sir, minimal cholesteatoma with, sir, hearing loss is present.
Exactly same situation, left side of the ear.
Then I would like to, sir, operate the patient because I think that ossicular erosion will be present.
Just for ossicular things you will operate?
And
what are
sir,
the areas of operating?
Sir, any unsafe, any cholesteatoma, sir, which cannot be, sir, managed through office management, like if the patient cannot follow up or if the fundus of the...
I am giving you a situation, a small cholesteatoma.
Sir, if...
With, you should ask me with atoria or without atoria. That will make a difference.
Yes,
okay.
Sir. Yes, sir.
Small cholesteatoma without any, then you can do repeated suction or you can continue with your medical management. All right.
Yes.
So all cholesteatoma do not need a surgical intervention. That's what I wanted to convey. Now there is a situation, there is a cholesteatoma with intermittent atoria. What will you do next? You have not enumerated in your test.
Sir, cholesteatoma with intermittent atoria.
Intermittent atoria.
Sir, I would like to operate, sir.
No. First tell me what test you will do. What do you want to do beforehand? Okay, directly I'll ask you, how will you do a station tube function test in such patient?
Sir,
you want to assess a station tube?
Yes.
That is part of your ear examination. So how will you assess if there is this type of picture, TM?
Sir, through we can, sir, inject dye can be inserted through the nasopharynx.
Sir, endoscopic assessment can be done if there is a perforation.
Mm-hmm. What are the various other methods?
Sir,
you want to say that you want to do a station tube catheterization. Will polarization help in this patient?
Sir, but there is a tympanic membrane perforation.
Very good. You cannot do. Any other special test is there? What is Dundergrant test? Let me ask directly.
The Dundergrant test, sir, is when we use air instead of water to check.
What air use होती है, कुछ और use होता है इसमें? Hello.
Hello.
Hello. Anyway, continue. Next.
Would you like to use an endoscope in this patient in your diagnosis?
Sir,
Yes, sir.
Are you using an endoscope in your diagnosis?
Sir, after our clinical examination, an endoscope can be used for better visualization.
So, what will be the advantage of an endoscope? You think?
Sir, all the areas, especially in cases where there is retraction pocket, it will not be. It is better visualized with an endoscope rather than a microscope, sir.
So, can you tell something about the retrotympanic space? If you are doing an autoendoscopy, so what is this and a retrotympanic space?
Sir, anatomy?
Yeah.
Sir, retrotympanic.
Where lies the retrotympanic space?
Sir, behind the. It is a space behind the mesotympanum, but in continuation with the epitympanum and the hypotympanum.
So, what is the fulcrum of this retrotympanum?
Sir,
you have heard about pyramidal eminence?
Yes, sir.
So, is this the fulcrum?
Sir. Yes.
Do you know or not? The various spaces, subdivisions of the retrotympanic space.
Sir, it is divided into superior and inferior retrotympanic space by the subiculum.
There is something known as the caudal ridge and the ponticular ridge. How does it divide the retrotympanum and into what spaces?
Sir, it divides into ponticulus, sinus tympani and the sub tympanic space, sir.
Okay, you'll have to read about it.
Let's move forward.
Sir, nystagmus was absent on both right and left eyes. The fistular test was absent, but this was, sir, it is written here, it was done at the end of the examination. Sir, on facial nerve motor function, there was grade 5 lower motor nerve facial.
Kindly tell us about nystagmus is absent means what?
So there was no nystagmus, spontaneous nystagmus or gaze-evoked nystagmus.
Gaze-evoked nystagmus, or you want to tell induced nystagmus?
Any spontaneous and gaze-evoked were absent, sir.
So what is the typical feature of a peripheral nystagmus, peripheral vestibular nystagmus?
It is an horizontal nystagmus.
Sir, there will be latency and it is easily fatigable. And sir, optical fixation is not possible.
And what is the direction of the fast component?
Sir, There can be paralytic or irritative lesions, sir. It differs.
Can you differentiate the fistula on the base of nystagmus? Which part of the semicircular canal involved, whether it is posterior canal or lateral canal or superior canal, can you distinguish on the
Yes,
basis
sir.
of nystagmus?
Yes, sir. The direction of nystagmus.
Lateral canal fistula, what is the nystagmus? How is the nystagmus?
Sir, vertical nystagmus can be seen.
And what about posterior canal? If it is in the posterior canal, fistula is posterior canal.
Sir, posterior canal will have vertical fistula, sir.
Both have vertical.
Sir, lateral canal will have
Lateral
horizontal.
will have horizontal and posterior will have
Posterior
vertical.
and superior will have
And what
vertical.
about superior semicircular?
Sir, they will have vertical but with rotational components, sir. Torsional component.
Rotational in the superior canal. If it is a vestibule, that again it is rotational type of.
Yes.
And it is towards the normal side.
Yes, sir. Fast component will be towards the normal side.
Yes.
What is an Alexander's law?
Sir, Alexander's law, sir, it states the degrees of the nystagmus between grade 1, 2, 3. So grade 1 is when the vision is towards the slow component of the nystagmus. Grade 2 when patient is looking straight, and grade 3 when patient is looking gaze is towards the fast component.
Okay.
Can we go ahead towards the surgical part also? We can discuss. No?
One question. Why this cochlear component is tested earlier than vestibular component?
Sir, because if vestibular component will be positive, and if patient has then develops vertigo and nystagmus, then patient will.
Question is basic. I am not. Why you want to test hearing first, and then vestibular system later?
So then, because patient will become uncooperative if it is positive.
No. See, not uncooperative. It may develop a vertiginous state in the patient. Suppose you are pushing something in ear to test the, all right, maybe air or cold air or nitrogen. So he may be having a vertiginous attacks. So you have to defer your examination after that. So always go for cochlear first, means hearing component first, then vestibular component. All right.
Yes.
And one more question I want to ask, which was asked earlier by Dr. Yadav. Is there any role of assessing lymph nodes in unsafe CSOM?
Yes, sir. Sir, we need to assess the cervical lymph nodes to rule out any tuberculosis. There may be tuberculosis leading to lymph nodes. So tubercular otitis media needs to be ruled out.
Any other thing? Which any other lymph node? Cervical, okay, I got your point. You are assessing some sort of malignancy, all right, temporal bone leading to. But any other lymph node you want to see?
Post-auricular.
Post-auricular or pre-auricular?
Pre-auricular lymph.
Why? Again, the tumors of temporal bone in the malignancy is in parotid lymph nodes. All right. And second thing is, suppose there is a otitis externa, then the pre-auricular region will be painful. All right. So because the lymph nodes will get infected, and that is how we diagnose it. So there is still role of assessing the lymph nodes in PSOM. We can carry on now. Thank you.
Yes. Sir, on neck examination, there was a single oval swelling of size around 3 into 2 centimeter present in the right infraauricular region, which was extending superiorly up to the mastoid tip, inferiorly 1 finger breadth below the angle of mandible, anteriorly up to the ramus of mandible, and posteriorly it was reaching till the posterior border of the right sternocleidomastoid. Overlying skin was.
What do you think this swelling is?
Yes, sir.
What do you think is this swelling?
Sir, on inspection, on examination, sir, it looked like an abscess, sir.
It means it's a complication of chronic otitis media?
Yes, sir.
Yes.
So which abscess you think?
Abscess or what abscess?
Basalt abscess, sir.
It's a basalt abscess.
Yes, sir.
The patient has got a infranuclear facial paralysis along with basalt abscess.
Yes, sir. Sir, on palpation, the inspection findings were confirmed. The local temperature was raised, tenderness was present, the consistency was soft, and there was fluctuation was present.
this abscess, why does it is just below this? Why can't it be how it is formed? Can you tell me the pathophysiology of Bajol's abscess?
Yes, sir. Sir, when the infection sir reaches to the mastoid, sir, then after mastoid, if the collection, basically the suppuration breaks the mastoid tip, then in deep to the sternocleidomastoid, Bajol abscess develops.
It percolates through the posterior border of sternocleidomastoid and lies deep to the deep investing layer of the deep cervical fascia.
Is of the anterior border or the posterior border?
Posterior border, sir.
So why can't it travel down? Why it stays below, just below the, or in upper 1/3 of the clavicle? I mean, muscle.
Sir, because of the investing layer of the deep cervical fascia, sir.
What happens to that?
Sir, it has an attachment to the clavicle.
Sure.
Hello.
Go ahead.
Yes, sir.
Hello, Mike.
Is your examination over?
Sir.
No,
sir. Systemic examination.
It's normal.
Yes, sir.
So you now tell us the diagnosis.
Chakravarti, one question. Chakravarti, one question.
Doctor,
you are what group of nerves you will examine in this patient? Can you?
Sir, I have examined, sir, all the cranial nerves.
Why do you want to see all cranial nerves? Why? It is a ear case, straightforward ear case.
Sure.
Why do you want to see cranial nerve? Your answer is right, but you explain it properly. First thing is, it is a vestibular apparatus is never complete with full cranial nerves. Suppose it is a neural system, not cranial nerve even, neural system. Suppose it is a case of multiple sclerosis. Suppose it is a case of some other cranial deficiencies. So collagen vascular disease. So you have to assess all neural system. This is for your clinical purposes. Now, what is your diagnosis as Dr. Chakravarti?
Sir, my provisional diagnosis is, sir, bilateral chronic otitis media, active squamosal disease with bilateral moderate conductive hearing loss, with right lower motor neuron House-Brackman grading 5 facial palsy with right Bajol's abscess.
Very good.
what do you mean by moderate conductive hearing loss according to the WHO classification of hearing loss?
Sir, so WHO, sir, moderate is between 41 to 60 decibel of hearing loss.
And what is a profound loss?
So, sir, severe,
classification.
sir, more than 81 decibel hearing loss will be profound.
And what is a normal hearing loss?
Sir, up to 25.
Normal.
Sir, up to 25 decibel hearing we consider it normal.
Less than 25 decibel is considered as normal,
yes.
Right?
Yes, sir.
Dr. Abhinav,
yes,
sir, it is bilateral active squamosal disease.
Yes, sir.
Why do you say it bilateral active? Was
sir,
there
because
discharge in the other ear also?
Sir, cholesteatoma flakes was present in both the ears, sir.
If it is only cholesteatoma, then you can call it an active disease?
Sir, patient presented with bilateral ear discharge and bilateral.
You said only discharge was only in the right side, no?
Sir, patient on history gave, sir, discharge but on EAC there was discharge on right side. Maybe, sir, left side it was not required to.
It was not there, you said, no?
Sir, on examination it was not.
The definition of active ear disease. When you call it active ear disease?
Sir, for squamosal disease.
Active ear disease, okay.
Sir, for squamosal disease, active disease is said when the cholesteatoma flakes are present.
This is a active ear disease, bilateral. According to your finding, this is a bilateral active ear disease.
Yes.
If it is inactive, it comes in the category of what? It's a retraction pocket.
Retraction pocket, sir. Cholesteatoma flakes will not be present.
Chalo. ठीक है, go ahead.
Who has coined the term cholesteatoma?
Muller, sir.
In which year? In 1838.
Long back.
Hello, doctor. What are the other structures at risk? Now you have facial palsy.
Sir, the vestibular apparatus, the lateral semicircular canal, and then, sir.
अरे भाई वेस्टिबुलर apparatus में सब कुछ कवर हो जाता है, तुम कंफ्यूज नहीं क्या करो?
Yes, sir. Yes, sir.
क्लियर चीजें बोलो.
Yes.
Okay, vestibular apparatus is one.
So then the disease can progress intracranially also.
Tell me, what are the structures at risk? Tell me, dura. I will agree.
Dura mater, the petrous part.
Dura will be at risk, so you will have all sort of intracranial complications. Okay, what else?
Petrous apex.
Petrous apex, petrous part of the temporal bone.
No, not because of this disease. No, petrous apex, no relation. Talk of sigmoid, common things you think. What are the other structures at risk? Talk of jugular bulb, talk of auditory system, ossicular damage. So these are the structures you are expecting when you open up the case. All right. So you will plan your investigations in this manner so that you rule out all such related complications. All right.
So how do you proceed further now from your
diagnosis? One question I want to ask: how this facial nerve is affected in this case of CSO?
Sir, facial nerve can be affected through cholesteatoma. There can be direct erosion of the facial canal through the because of the cholesteatoma. Secondly, there can be, sir, the facial canal may have been dehiscent congenitally.
How many patients have dehiscent facial nerve? Percentage?
30%, sir.
30 is very less. It is almost 50%, I think.
Okay.
And sir, and thirdly, there may be the natural pathways like the nerve to stapedius or the foraminus in the normal facial canal through which the disease can progress. Sir, yes, sir.
Commonest part of dehiscence is facial nerve.
Tympanic part, sir.
Tympanic segment, the second genome, sir.
Tympanic part is a long structure.
The second genome.
And what about cholesteatoma? If cholesteatoma is eroding which part of facial canal it will erode first?
There's a tympanic segment and the second.
How do you proceed further now? What all investigations you would like to do?
Sir, we would like to do otological and radiological investigations for this patient.
Tell us.
Sir, first we will get after clinical examination, we will do an examination under microscopy so that we confirm our findings. Then we would like to get a pure tone audiometry for documentation of the type of hearing loss as well as the degree of hearing loss. And we would also like to get an HRC high resolution CT of about 1 millimeter cuts for the patient.
Temporal bone.
Temporal bone for the patient.
So what all specific things you would like to look in the CT scan?
Sir, in CT scan, first of all, in this case, we will look for the ossicular status.
First thing will be the ossicular status.
Sir, the extent. Sir, first of all, we would like to look the normal anatomy and the extent of the disease.
And tell one by one what all things you would like to look for.
You can see 10 structures, enumerate all those 10.
Sir, in the middle ear, we would like to look for the middle ear as well as the mastoid erosions, widening of the antrum, then tegmen and the dural plates, if there is erosion or not, and then the ossicular status, where there is erosion, and as well as the jugular bulb, if there is high jugular bulb or any abnormalities are present. We would also like to look for the facial nerve, and if there are any dehiscences, or for and as well as the vestibular system if there are any fistulas, and the inner ear anatomy also should be looked for if there is normal anatomy or not.
Can you pick up a fistula of the lateral semicircular canal in 100% of the cases?
No, sir, very small fistula.
And a dehiscence of the facial nerve in all cases?
No, sir.
No, sir. We are having 1 mm.
Percentage in which you can miss?
Sir, very small fistulas will be missed.
What do you mean small fistulas?
Sir, we are getting HRCT temporal bone of 1 mm cuts. So, if it is less than that, we will not be able to diagnose.
So what is the sensitivity and specificity of HRCT temporal bone in diagnosing a fistula of the lateral semicircular canal or a horizontal semicircular canal, and in picking up a facial nerve dehiscence?
Not sure.
Read about it.
Yes.
Yes.
So next.
Hello.
Go ahead.
Yes, sir.
Hello, doctor. My question is: suppose it is a case of unusual pathogen, PS1, with
Yes,
similar type of neck abscess. All right. So,
yes, sir.
what will you take precaution, and which area you will treat first? Now there is a disease in the ear, and there is a disease in the neck.
Yes, sir. Sir, it can, sir, unusual presentations can be either tuberculous otitis media presenting with an abscess in the neck, for which we have to primarily treat the patient with anti-tubercular drugs.
Why are you diverting your case? This is not a tubercular lymph node. This is, you are talking about a basal abscess.
Yes, sir.
You tell us the management of your case.
Okay, sir. Sir, in our case, after getting the investigations done, we would like to take the patient for canal wall down mastodectomy, modified radical mastodectomy.
Along with the drainage of the abscess, sir.
You have already decided you will do a canal wall down mastodectomy?
Yes.
Yes, sir.
Why?
Sir, the patient has presented with complications, so.
So,
how many complications are there in this case?
2 complications.
There's so many complications.
Hello?
Yes, sir.
Yes, sir.
You are inexperienced. You are inexperienced surgeon. Both answers are correct.
Yes, sir.
You understand? You explain properly. You are inexperienced surgeon, so you will do canal wall down. But when high otological training is there, and you have all microscopy section and everything, then you may decide differently. Instead of canal wall down, you will do different type of surgery.
Yes, sir.
And you can decide on the basis of HRCT also which approach you should go.
But in this case, we have a facial nerve palsy and basal sepsis.
So one should go for canal wall down as well, yes.
Yeah.
Which cell you will take care of, especially in this case, when there is a visual abscess? Mastoid air cells.
Tip cells, sir. The tip cells should be removed in total.
Yes. Can it lead on to other abscesses, visual abscess?
Yes, sir. In association with this, we can also have Citellus abscess and Luke's abscess.
Once it is down, how it will go up?
In what % of cases, if there is one complication, the second is also associated?
44%, sir.
Can get parapharyngeal abscess or retropharyngeal abscess. Okay.
Yes.
Any
Yes.
other way you can get retropharyngeal abscess in a case of CS1? Have you read?
No, sir.
From the tip of the petrous. If there is a petrositis, this comes
Yes.
in the loop of the parapharynx.
Okay, sir.
It can come two ways, either through visual or tip this petrositis. Petrositis is seen in which cases? We usually don't see which type of petrous bone will be there when there is a Gradingo syndrome or petrositis.
Sclerotic or diploic petrosis.
You have said both.
Sclerotic, sir.
When it is pneumatized.
Highly pneumatized mastoid.
Not
Pneumatized.
Vitreous attacks is pneumatized in what percent of cases?
30%, sir.
And what are the various tracks which leads to the vitreous attacks?
Sir, anterior and posterior tract, sir.
Have you heard anything like supralabyrinthine?
Supralabyrinthine, infralabyrinthine, yes.
I asked one question, how this lenticular process is destroyed or eroded? What is the mechanism?
Sir, there is only a single, it is a artery that supplies the lenticular processes, an end artery, and therefore there are high chances.
So what happens to that artery?
Sir, during if there is any ossicular destruction, if this artery gets occluded.
Don't go that way. You are explaining how it is destroyed. You are already saying it is destroyed.
Due to the necrosis of the
That's
why the original question, how it is necrosed, and she said due to artery, and that question is correct. But how that artery is affected?
Sir, pressure.
Hypoxia, sir.
Pressure.
Does it get thrombosed?
Due to infection, okay, not due to pressure. Usually you answer like that there is a pressure of cholesteatoma and there is a restriction. There is infection that leads to inflammation of the artery and blockage. Okay?
Yes.
Since that the terminal part, that is the part that is commonly affected, even if there may not be any cholesteatoma, even then it may be necrosed.
Yes, sir.
So now you will be exploring that part, isn't it?
And you said there may be bulging of the tympanic membrane. In mass mastoiditis, you may have a normal tympanic membrane, and usually it is normal.
Okay, sir.
Then how you diagnose? That question was not
Sir,
answered.
by computed tomography scan, sir, CT scan.
When will you this order computed tomography or any other case? Any normal tympanic membrane patient comes and you go for tympanic this CT scan.
Sir, the patient had a history of acute otitis media, which was resolved with antibiotics, but with but the patient is on long-standing antibiotics.
Patient.
And the patient.
Number of cases, maybe even one of you who had acute S1. So that way you will order so many CT scans. When some patients come with unexplained pain in the ear and there is a history of acute SOM or whatever SOM and there is no other finding, then you can order CT scan, not in every case. Unexplained pain, otalgia, and there is a history of acute SOM.
Okay, sir.
Yes.
That answer that another question I asked, what are the causes of pain in CS1? Two were answered. Any other? One, there may be acute exacerbation of the CS1. Okay. And fourth, rare, there may be CA, carcinoma. Chronic irritation can lead on to CA also. So these are the four causes. Apart from referred otalgia. Okay?
Yes.
Yes.
Clear?
Yes, sir.
How will you manage the case of mass mastoiditis?
Sir, we will do a cortical mastoidectomy, sir.
Have you read?
Yes, sir.
Okay.
So in this patient,
medical management.
Yes, sir.
You will not do medical management. Cortical mastectomy is done not in every case. It doesn't heal.
There is a message from Dr. Ravi to finish the discussion. So let us finish it first. You'd like to explore the mastoid, no?
Yes, sir.
Yes, sir.
You have started doing the mastoid. You have encountered that it's a very contracted mastoid. You are not able to proceed with a low-lying dura and a forward-lying sigmoid sinus. So what you will going to do at this stage?
Sir, we can get the aid of an endoscope.
So endoscope. How the endoscope is going to help in this stage?
Sir,
We can also go from the middle ear through atticoenterostomy.
Yeah, you can change your route from, you can go from inside out. Inside out canal wall down mastoidectomy you can do, right?
Yes, sir.
If you are to do a canal wall down, you can change from outside into inside out.
Yes.
You have done any mastoid during your residency?
Sir, in second year we did, sir, but in third year due to corona we could not.
Suppose there are two cases. One with a posterior superior perforation with cholestatoma, one with attic cholestatoma, and you are not a confident surgeon. Which one you will like to do and why? One is attic, one is posterior superior.
Sir, attic cholestatoma, sir, it will be confined to the mostly in the epitympanic region.
And how are you going to deal with the facial paralysis in this patient?
The facial nerve decompression should be done.
Why facial nerve decompression should be done? Have you assessed the facial nerve? Intraop?
Sir, intraop we assess the facial nerve and
you decide whether you go for
yes,
it.
Sir.
There are so many granulations around it. How will you deal with it?
Sir, we first of all, if the granulations they do not have to be plugged with lots of pressure. If granulations, if we are removing it, we have to do it in the direction of the parallel to the facial nerve.
Okay.
And some granulations can be left, minor granulations.
So the answer is not the facial nerve decompression, no?
Yes.
Like first we have to
assess the facial nerve first.
Yes,
Then
yes,
you decide.
In the intraop finding, you find
it is already decompressed.
in your intraoperative finding, you have found that the malleus is absent, the incus is absent, even the stapes suprastructure is also absent. What you have is a mobile footplate of the stapes. So what will you do in this situation?
Sir, then after
After
clearing,
the eradication of the disease, you are sure you have eradicated the disease.
sir, then I would like to place as a total ossicular reconstruction prosthesis from the tympanic membrane to the footplate of the stapes.
This is which type of tympanoplasty?
Sir,
Right?
sir, this will
1, 2,
type
3.
4.
How it is 4?
Sir, the
Only
suprastructure.
only stapes footplate is present.
Sir,
type 3, sir.
Type 3. Type 3 is when you have got the suprastructure of stapes.
Columella effect hota hai when you place the graft directly on the stapes head. That is type 3.
Type 3 is what we call as meningostepidiopexy.
Yes, sir.
Columella. Yes, sir.
And type 4 is?
Sir, when
this type 4?
Sir, when we place the graft on the round window and expose the oval window, then it is type 4.
And type 5?
Sir, type 5, we do a fenestra operation, sir, lateral semicircle.
Type 5 is A and B. A is fenestration and B is the mobile footplate is left as such.
So now the last thing is you have eradicated the disease. You have done some amount of ossiculoplasty. And would you like to obliterate this mastoid cavity?
Yes, sir.
Yes. So what are the advantages of obliteration of the cavity?
So, sir, the cavity-related problems will not be there. For example, recurrent discharge, dependence, dizziness, decreased hearing. These factors will be reduced.
Will you do a primary obliteration or secondary obliteration? Because it's a case of complication.
Yes.
So
Sir, we should wait and do a secondary obliteration, sir.
In this particular case, will you like to remove the tip also?
Yes, sir.
Yes, sir.
It must be removed. Not may, or it must be removed. So my question was, you were answering, one is attic cholesteatoma, one is posterior superior. Which one you will like to do and which one you will not like to do? Since you are a beginner. Otherwise, you have to do both. Posterior superior cholesteatoma is likely to go into the sinus tympani.
Yes,
and for a beginner, it will be slightly difficult. Okay. So if it is only attic, that will be much easier to do for a beginner. Is it correct?
Yes,
Have you read it or no? So answer is this.
So my question here, Nimisha.
Yes, sir.
You have planned a canal up technique. Okay.
Yes,
What are the conditions during surgery you have to resort to canal wall down technique?
Sir, when there is irreparable posterior wall defect, or if we find intraoperatively we find a fistula or facial nerve dehiscence or any other complication.
Don't say facial nerve dehiscence. If facial nerve, then also say I am a beginner. Okay.
Yes, sir.
Because facial nerve can be fully exposed, if the surgeon is experienced with canal wall, because there you have to dislocate, take out the incus and find out the root. Okay. So even if with canal wall up, you can do a full transmastoid decompression. You can see whole of the root up to the ganglion. It is possible. So, but say that I am inexperienced, so I will do canal wall down.
I am a beginner.
So you have done a good surgery, but after some time you are seeing that there is some evidence of residual disease or it has recurred. So how do you diagnose this?
Sir, we can diagnose it by imaging by an MRI or a CT scan.
Diffusion weighted MRI is the either you previously a second look surgery was done, but now with a diffusion weighted MRI we can diagnose.
And patient has come back to you with all the symptoms. So that means there is residual disease or recurrence. Yes or no? Even if you don't do MRI or CT scan. If there are no surgery, the patient will not come to you.
After how many months the patient comes to you, then you can think that the disease is left or it is recurred.
After 6
Usually
months.
mastoid cavity dries in how much time?
3 to 6 months, we expect the mastoid cavity to be completely dry.
If it goes beyond 6 months, then you can suspect that there is some residual disease
Residual
there.
disease. Yes.
What is the definition of residual disease? Residual cholesterol?
Sir, residual disease, when we have left, sir, cholesteatoma during the surgery, when we have not...
As soon as you remove
unplanned,
it will be there. Recurrent has to come at a later stage. Okay. Residual will be present as soon as the immediate complications are over. Recurrent, you have to wait. It will reappear. The disease osteoresorptive process will reoccur again. So you should answer properly. Okay.
Yes, sir.
Okay, can you? What are the relative indications of mastectomy?
Canal wall down.
Tell me any type of mastectomy. Relative indication. Absolute, you know, cholesteatoma. What are the relative indications?
Sir, if the patient is unable to follow up frequently.
What do you mean? You will do mastectomy in this patient. You give a drop and send the patient. See, profused otorrhea, even in absence of cholesteatoma. All right. So, in such cases, you have to do mastectomy. If there is a there is a history of that you have done some sort of tympanoplasty and it has failed, you have to go for a mastectomy. Okay. Any tympanic perforation which is not responsive to any sort of treatment, then what you do, you make a mastectomy. Okay. If you are a beginner, go for a canal wall down. If you have experience, go for a canal wall up. You understand, na? What is a neo-editus? Neo-editus. Hello?
Yes, sir.
What is a neo-editus and how will you keep it patent? Neo-editus is the area which it is the area which we make a window in posterior canal. Sinus, you know, posterior tympanotomy approach. There
Yes,
we
sir.
make a triangular hole and we want to keep it patent because suppose you have done a canal wall up technique. If immediately after surgery this window gets closes, then again it will be a wet ear. It may be due to, in such cases we give steroid directly, oral steroid, antibiotics, then this window will remain patent. So we want that the mechanism of the air flow from station tube to the mastoid cavity remains in one flow and it gets a automatic clearance. The ear has a natural pathway, it gets automatically cleared. Self-cleansing mechanism is there. And only your purpose is to make it again so by various type of surgeries. All right. So we have to make this thing. So what are the causes of blockage of this type of posterior tympanotomy opening, which I say as a neo-editus? It is a okay. What are the causes?
Discharge, sir.
So what discharge?
Rahul, can we call it a day now?
Oh yes, I'll have an answer. Granulations, edematous mucosa, and unusual type of bone specule. These are the various things which are causing a blockage. So some such things call it. I think now we can call it a day.
Yes, sir. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, everyone. I think case discussion is one thing which can continue indefinitely.
For 24 hours.
But we are here since morning 9 o'clock, so I think we must call it a day. We had a good discussion today, and right now I am very happy to tell you that we have 573 total attendees live online at present, and we will be meeting tomorrow at 9 a.m. again sharp, and with more lectures and case discussions. And I would like to personally thank Dr. SPS Yadav, Professor Khaja Nasruddin, Dr. Ashok Kumar, Dr. Arunabh Chakrabarti, and Dr. Ishwar Singh, Dr. Rathore, and Dr. Taneja for
we are the hosts. We are part of the department.
Definitely, but you have been very actively involved in the case discussion. So I personally thank everybody for a wonderful
I was
case
on back foot.
discussion,
I
and,
was letting others to ask the questions so that our students have a good exposure of the questions of the outside. Not outsider, means other experts better than me.
Right. So thanks all, and we'll meet tomorrow again at 9 a.m. Thank you very much.
Thank you, Ravi. Thank you, Ravi.
Thank you, sir.
Thank you.
Bye, sir. Bye.
Thank you, sir.
Thank you, sir.